There are 4 classes in that. The first group is the patient who has a good functioning FCU, FDS and palmaris longus. The FCR and pronator teres are not available for transfer. So in this group of patient, you can do an FCU to EDC transfer for finger extension, FDS for the wrist, and 1 FDS to the EPL. We can get a quite good result, independent wrist, finger and thumb extension, and you can have a very good function in such a case. If the FDS of the ring is not strong enough, we can even put an FCU to the EDC and EPL. This also gives a reasonable amount of independence to the thumb and function is quite acceptable. More severe involvement where the FDS and FD or the FDPs are weak, we can choose to put an FCU itself to the finger extensors and EPL, so one tendon doing all the work. This is good enough for the patient to open up the fingers, but when they make a fist, the wrist appears to be unstable. So if our main aim is to improve the prehension, this is good enough, and patients were actually quite happy with the outcome. The last category where the FCU also is weak, but the FDS are good, we can use one of the FDS for the wrist and one for the finger. It looks like they may not work well, we thought so, but surprisingly, we got a quite good outcome in these patients, and this is another one option by which we can prevent the fusion of the wrist. So when you are having a case where you want to restore finger and thumb extension in extended brachial plexus palsy, there are many ways to avoid wrist fusion. So if you have any of these tendons available, like the FCU, FDS, or both of them, various combination of tendon transfers as written over here can be used. By using this algorithm, almost 80% of the patients which you would otherwise think of using the wrist can be left with a mobile wrist. Thank you so much.
Thank you very much. Do we have questions from the audience? There are 2 microphones. No, there are several microphones actually, or you can just shout.
Thanks, Praveen. Do you think nerve transfers would give you a better result in compared to your tendon transfer?
Yes, sir.
For the same function?
So that is a very nice question, sir, and thanks for asking that. So when a nerve transfer would give good result, provided we have a donor for that. So these patients, first itself the hand is weak, and in the weak hand patients, we are doing an Oberlin transfer with that weak nerves. So one would be really concerned to do a tendon transfer for the fingers. But yes, if the pronator quadratus is working, we can take pronator quadratus branch and put to the ECRB.
Yeah, that's very promising.
So we can get the wrist extension, but finger extension, you would have to require to do one of these tendon transfers. So presently our protocol is, while doing a nerve transfer for the elbow and shoulder, we also do for the wrist and leave the finger extension to the next stage.
Absolutely.
Yes,
Thank
sir.
you.
Thank you, sir.
Do we have any more questions? Thank you very much.
Thank you.
We'll move on to the next speaker.
Our next speaker is Professor Anil Bhatt. He will speak on screw trajectories for scaphoid waist fracture fixation. Welcome, Dr. Bhatt.
Thank you, chairpersons. Greetings from the Indian Hand Society and Team India here. Well, we all know that the screw placement, ideally from the biomechanical studies, is more of central placement, which is considered superior. And if the fractures are oblique, perpendicular screws are equivalent strength. But then due to technical difficulty, a lot of times we as surgeons would fix it in different screw trajectories. So the aim was to determine if variable screw fixation trajectories influence the fracture union in percutaneous fixation of scaphoid waist fractures. We wanted to study the fracture patterns, various angles of the screw to the fracture and to the central axis, and its influence on the fracture union time. Acute scaphoid fractures, both transverse and oblique, were chosen, and open and comminuted scaphoid waist fractures were excluded. Plane radiographs, the PA and the lateral, pre-op, post-op, and the follow-up ones. Fracture patterns of the scaphoid waist, direction of the screw placement in the proximal and distal parts, which is ulnar, central, and radial, or dorsal, central, and volar. And then the angle of the screw to the fracture, and the angle of the screw to the central axis of the scaphoid, and the length of the screw, and of course the fracture union time. These were the ones which were studied. We had 27 of patients, young patients, mostly males. If you look at the screw trajectories, there are only 4 patients who were perpendicular to the fractures, and the central axis were about 4, but majority of these were others, which basically means it could come from the distal radial volar side to proximal central. So there are various combinations which can happen as we look at these trajectories in our X-rays. So it could be radial volar, or it could be central, or volar radial. So different combinations exist based on these. And the fracture patterns we had almost equal. Transverse was oblique. The union time was average about 8.9 weeks. The average screw length we used was 22. The angle of deviation of the screw from the central axis, you can see, is from 0 to almost 34 degrees. Angle of the screw to the fracture was, again, 69 to 138 degrees. We had 1 non-union out of these, and majority went on to union, and 1 for follow-up. This is a distal central to the proximal central. So this is a central axis, which ideally would be nice and biomechanically proven. This is the distal central radial to proximal radial. So this is the perpendicular for the oblique kind of fractures. But then these are the other ones, distal volar radial to proximal central, but union went on 6 weeks. Distal radial volar to proximal dorsal central. This is radial volar to proximal ulno dorsal. And this was a non-union which we had. The axis was distal radiovolar plus proximal central, but then this patient basically, when we look back, was a perilunate fracture dislocation. But then we fixed everything closed, and the scaphoid was fixed percutaneously. But this was the only case which went on for non-union. This was the case we lost for follow-up. Again, the axis is volar radial to proximal central. At 2 months after that, we have not seen him. So biomechanically, strength of the fixation is greatest when the screw is placed centrally in the proximal pole. And the screw placed centrally throughout the scaphoid is biomechanically superior to a screw placed centrally only in the proximal pole. But it remains unclear whether the more central screw placement afforded by the proximal approach might translate into improved clinical outcomes. So this was where we took off and we started looking at our X-rays. But retrospectively, there's no clinical studies to establish whether these screw trajectories actually will lead to good union or not. And probably this is one study where it says that actually it probably doesn't matter. So we demonstrated that union is independent of different screw trajectories and angle of fixation of the screw to the fracture and also to the central axis. But then it's not just the screw always or the axis always. There are many factors which influence the union: the compression at the fracture site, the adequate screw purchase in both the fragments, and the screw thread crossing the fracture site. And of course, the patient factors are always there in terms of the age, smoking, and other things. So it's a retrospective study, small sample size, of course, but it definitely gives direction to better design future studies, especially of different trajectories. Biomechanically, we can study a finite element analysis kind of a study would definitely prove that probably the trajectories might not really matter at the end of the day. Thank you so much.
Thank you, Professor Bhatt. Are there any questions from the audience?
Thank you very much. Very elegant study. My question is, would this be an operation that would be suitable for development as robotic assist to consistently get that screw very accurate for an extra 5 to 10% on the results?
Thank you. Well, I think before that, probably one of the things I would personally want to do is to get in an AI prediction model for these trajectories or do a finite element analysis and then go on to the robotics for, again, going back to the central axis. So if we consistently show that the axis deviation might not matter too much and all the patients are uniting, I think I would not invest on a robotic thing for this particular condition. Thank you.
Any more questions? Thank you very much.
Thank you.
Our next speaker is Mr. Ricky Wade, and he's talking on imaging for root avulsion injuries in the plexus.
Thanks very much. Only if the slides come. Yeah. Thanks very much for having me, and good morning, everybody. This is the debut of my PhD work using a particular MRI sequence called diffusion tensor imaging in adults with traumatic brachial plexus injuries. Now, we're all using MRI to try and identify these patients, particularly selecting out those with a root avulsion because they're common in high-energy plexus injuries. And we know that early nerve transfers are the way to go. Time means muscle, lower pain, and so forth. But NHS MRI is not up to scratch, and our metadata shows that. We all do it, and then we promptly ignore it and carry on doing what we normally do, which is why for the last decade in Leeds, we've been developing various MR approaches to get what we need, which is microstructural information about nerves and end organs. Now, water in healthy nerves, like in the blue picture, diffuses only up and down the axons in axoplasmic flow like we know. Healthy myelin insulates the water from leaving the axon, and because they're tightly bundled, there's very little diffusion in the radial plane, in the cross-section of the nerve. And we can sensitize MR images to this phenomenon. We know that unhealthy nerves, whatever disease they're subject to, maybe they lost myelin, maybe there's fewer of them, less water goes up and down the nerve, and more of it seeps out of axons into neighboring ones or around the fibers. And clearly, if the nerve is toast, there's no microstructure to guide diffusion. So diffusion is more isotropic. So on the red side, diffusion is equal in all planes, isotropic. On the blue side, it is anisotropic, highly directional. We've been able to do this for a lot of years now. This is a tractogram of the brachial plexus. It's just poster fodder. We don't really care about these pretty pictures. But what we really care about is the data contained within each voxel, each pixel. This is simply a mathematical model of how water is moving. The top glyph in your top left is in a healthy nerve. Lots of very polar diffusion up and down the nerve. And the voxel just below it is fat, next to it. Very disordered, big cells, water can go wherever it wants. We've been applying this technology to adults with acute plexus injuries in Leeds, in the north of England, for some years now. So many thanks to those centres who supplied patients. Very difficult population to work with. We scanned 14 adults in our scanner, serially, actually, many times, and for months and years afterwards. But today, just the debut of our very early scan findings. On average, we're scanning these patients somewhere between 1 and 6 weeks after their injury, depending on how stable they are and can they get to the scanner. Most of them went on to exploration so we could confirm what we found with the scans, although some of them actually spontaneously recovered, so clearly they did not require exploration. And this is what we found. Red box first, please. The y-axis is the amount of ordered diffusion in the distal nerve stump. The red box is those where we've gone in and we've seen their root is avulsed. And just like we expected, the fractional anisotropy is lower in these patients' distal nerve stumps, just a few weeks after their injury. You compare that now to the blue boxes in the violin plot, where in the middle, you've got the uninjured roots on the other side of the neck. We scanned those values. They fit with the normal population parameters that we've already defined. And the roots that we looked at and found were in continuity and did nothing to. They also have very similar microstructural values. So here, we now have an objective, reliable, reproducible yardstick for the microstructural health of a peripheral nerve. And this is the sort of thing that we see at the scanner end. On your left is a healthy upper trunk, C5-6 coming to upper trunk. Drop a crosshair on there, and that's what we measure in a pixel. They're normal values in blue. Look at the other side, where this gentleman has a C5-6-7 avulsion, and you choose just to look at the values in the C5 root, you see that they're different. And the story is the same throughout the length of the nerve. Now, this is just a very small piece of a very large portfolio of work on plexus injuries, and I'm enormously grateful to all of these people and more who've made this body of work possible. And thank you for your attention.
Thank you very much. We've got a question from the floor.
Hi, Ricky. That was a fantastic study. Thank you for presenting it. You mentioned these changes happen a few weeks down the line after a plexus injury. In high-velocity injuries in my unit, we tend to explore them between a week and two after injury. So how useful is it at that point?
Thanks, Mr. Boyce, for the question. That is hard to answer with any certainty, given it's a small number of patients, so I wouldn't want to be very, very, very specific in the answer there. But as soon as I can scan them, or as soon as you can operate, I can probably scan as well. So if they're fit for the theatre, they're fit for a scan. So if this helps you to guide your exploration or what you may or may not do in theatre, then I struggle to understand how more information would not be helpful. Does that roughly answer the question?
More questions? I've got a question for you, Ricky. Obviously, this looks like there's more to come, but have you been able, or are you planning to identify a cutoff in this parameter for operating and kind of looking at sensitivity and specificity?
Thanks. That's a very long-term goal. Clearly, thresholding is a problem in of its own. So I might have to come back to you in a decade or so.
Oh, wow.
Tell you that.
Thank you very much. You can tell how much I know about diagnostic accuracy testing.
Okay, thanks.
For the next talk, I invite Dr. Butt again to talk on his novel technique for treating nascent malunions of the PIP joint fracture dislocations.
Thank you. Well, most of our patients, the clinical problem is in the PIP joint fracture dislocations. They come to us late. That is the usual story. And at that point of time, there are a few options left to us. And one of this is what I would be talking to. So these are the options if at all they come acutely and also late. But then when they come at 2 or 3 weeks down the line, the options reduce to very few in terms of maybe an external fixator, dynamic external fixator, or a volar plate arthroplasty or a hemihamate arthroplasty. Well, it's not so novel, but then it's a slightly different technique in terms of the nascent malunion itself, which is basically misalignment before a fracture is fully healed. What we are looking at is joint stability and some fixation techniques so that congruous reduction can be achieved. Our concerns basically are finger stiffness, of course. That's why the patient comes, loss of motion, pain, and chronic joint instability. Well, reestablishing the articular congruity, early motion, converting that hinge to a glide is what we are looking at this particular point of time. And there are various techniques described earlier, but then most of these percutaneous techniques are K-wire fixations were for early fracture dislocation presentations. Nothing of late as in more than 2 weeks or 3 weeks. These are early fixation techniques. So we wanted to see the functional outcomes in the nascent malunion, PIP joint fracture dislocations with only percutaneous K-wire technique, looking at the range of motion, the dash score, and the Ishidan Ikuta scoring system basically talks of these parameters, the range of motion, pain, deformity, instability, the ADL disorder, and radiographic evaluation. So we had 11 consecutive patients who underwent this particular technique with a minimum of 1 year follow-up. What we're doing is basically taking advantage of the soft callus there. So when they're coming at 2 weeks or 3 weeks, we just want to push them out all together and make it congruous. And using any of these reduction clamps, the soft callus formed in the nascent malunion is manipulated, and then to reduce the articular surface to obtain the congruity there. And there are 3 wires which goes there. The first one is a subchondral drafting for the articular congruity there. The second is, if there's a big chunk of fragment, you can see the fragment-specific wire goes, and then we would put in the extension block to convert the hinge to gliding so that it doesn't dislocate or subluxate again. So that is the triple wire technique which I'm talking of. So gently manipulate the finger when they come in. They will be stiff, and the stiffness is more again due to, they've not mobilized because of pain. So you could get some good range of motion as you start mobilizing them. And the reduction forceps is the crucial one here. We would like to just to tap that soft callus back into its position. And those are the 3 wires going in. And that is how it's converted from the hinge to gliding action. So that is the range of motion you get on table. And then we immediately start them on mobilization next day. So this is, again, a patient. So this is day 1 mobilization with a dorsal block splint. And then we would just immobilize, or rather give a dorsal block in about 30 degrees of flexion. Make a small window there for the K wires in that splint there. And then in the end, we would go for a Kapner's kind of a splint to get rid of the fixed flexion deformity of those 30 degrees. These are patients. If you see average about between 2nd and 3rd week is the presentations. And mean percentage of articular surface involvement was about 40%. The mean active ROM at final POP, what we could get was about 81.9 degrees. The mean dash score 5.2. And this is, again, results with in terms of the functional evaluation itself. So if you look at the surgical management review of outcomes there, the percutaneous fixations yielded the highest post-op range of motion at final follow-up. And our study mirrors that we could get a good range of motion at the end of this. And no treatment method or fracture type yielded consistently better outcomes than other in this systematic review. If you look at the Suzuki frames or the external fixators, again, delayed treatment with this technique is effective in restoring the function to the PIP. When we compared this to ours in terms of the historical data, again, we could get a good results. And if you could compare with the percutaneous fixation techniques, the previous ones, of course, as I said, most were done for very early presentations. Our average was about 16.9 days and good range of motion. So again, we looked at the last 6 years follow-up of our patients with the volar plate and hemi-hamate, which we had in our own setup. And again, they reasonably work out similarly, both of these. This is a 23-year-old injury, 23 days old injury, sorry. And that's a 2-year follow-up, very nicely remolded there. And that's a 2-year follow-up of this patient. This is a 3-week-old injury. Again, good healing there at 14 months follow-up. So delayed presentation is quite common in our setting, and favorable functional outcome is always the problem in delayed presentations. So the Dayson malleus undergoes remodeling over time to restore a smooth and functional articular surface. The presence of the soft callus is what we take advantage of, and the results of this relatively simple treatment appears as satisfactory as those obtained by other a little more complicated, like the hemi-hamates and the volar plate. Thank you.
Any questions?
Yes.
Dr. Ravi, there is a...
Yes, thank you. So yeah, my question to you is, would the size of the fragment, the volar fragment, have any bearing on your wire choice or placement? And what's the longest duration you've had? I mean, like the delay between the injury and your triple wire?
Yeah. Well, if we have a good chunk of fragment, life becomes easy. But otherwise, even if they're comminuted, sometimes by the time they're at 3rd week or the 2nd or 3rd week onwards, they start healing up. So what we're doing is trying to convert those tiny small fragments to a single fragment by just compressing with the crocodile. The clamp is nicely, we have padded it so that we don't cause injury to the skin. So we just push that back and then do that. I think the longest follow-up has been 3-point-some weeks till now, the presentation. Thank you.
What size?
So this is 1 mm and 1.2. So the raft wire is 1 mm generally. The fragment specific can be 1 mm or 1.2. I mean, we talk of 1 mm and 1.2 in India. So these are the wires. The extension block is always 1.2.
Thanks.
Thank you.
Professor, when the patient comes at 2 weeks,
Yeah.
do you try a closed method and then go on to fix it, or you always go for a KY fixation in such cases with the big fragment? Do you try to reduce it closed with after manipulation and do something else like a external fixator?
Closed method, I mean, I didn't get that.
Passing the wires through the joint.
Yes.
So if you can avoid it, do you try it, or you always try to fix it in such cases?
Yeah. I mean, the X-ray would tell me that what is to be done in terms of whether I would just go closed. So again, when we screen the patient, when we take up the patient, we would see how the reduction happens. And if there's some amount of the hinging which is still there, at least just an extension block. But if the articular surface is, I mean, it's not congruent, then I would do this. So it's quite flexible on table for me, yeah.
Thank you.
You do make it look easy. You mentioned a modification to the crocodile forceps.
Yeah.
Like, in case any of us want to try it, can you tell us what the modification is?
It's just a rubber tubing, nothing else. Yeah, just to, reduce the bite of those serrations. Yeah.
So not to crush the skin.
Yes.
Thank you very much.
Thank you so much. Yeah.
I'd like to invite Abigail Shaw now to talk to us about surgical site infection after hand trauma surgery across the world.
So good morning, and thanks for the opportunity to present our systematic review and meta-analysis on surgical site infection after hand trauma in low and middle income countries. So, for some reason it's completely frozen here. Okay. Anyway, so our group did a previous systematic review of surgical site infection after hand and wrist trauma. And surgical site infection is the most common post-operative complication and hospital-acquired infection. And we looked at 200 studies of over 300,000 patients, and the meta-analysis showed a surgical site infection rate of 5%, as high as almost 10% in the randomized controlled trials included. So earlier this year, I was lucky enough to be part of one of the first BSSH trips to the Lion in Malawi, and we quickly learned that hand infections and post-op surgical site infection were both really significant issues in these settings. It's associated with increased morbidity and mortality and can lead to catastrophic patient expenditure. And on my return, I decided to do a top-up search of the original review and reanalysis of surgical site infection in the context of countries' income classification. So this is the study selection we used. So we looked at primary clinical studies of adults with acute hand and wrist injuries in the studies of surgical intervention that reported surgical site infection. And we grouped all of the studies by country of origin into the 4 income classifications as reported by the World Bank. So that's low-income countries, lower middle-income countries, upper middle-income countries, and high-income countries. So our original search was of around 10,000 abstracts, and we included 202 studies. Our top-up search was an additional 1,000 screenings, and so we had a total of 236 studies. So interestingly, there were no studies included from low-income countries, 40 from lower middle-income countries, predominantly from Asia, and similar numbers from the upper middle-income countries, again from Asia. There were the most studies from the high-income countries, mostly from North America and Europe. And most of the studies from high-income countries were over about a 50-year study period, whereas the ones from the middle-income countries were much more recent. The middle-income studies, the lower middle-income studies were also, interestingly, mostly prospective, whereas the upper middle-income and high-income were retrospective, and there wasn't much difference in the study design. Okay, so looking at the mean number of participants for studies, there were many more participants in the high-income country studies. and the mean age of the participants was a bit higher. So looking at the surgical site infection risk, from the lower middle income studies, the risk of infection postoperatively was higher compared to the high income studies. And looking at the risk of bias across all of the studies, it was a much higher rate in the lower middle income studies compared to the high income studies. So in conclusion, there were no studies from low-income countries, and this potentially is indicative of limited hand surgery capacity and research. There is a reduced volume from middle-income compared to high-income studies with significantly fewer patients reported per study, and the risk of surgical site infection after hand trauma was slightly higher in middle-income countries compared to income countries, but it might be underreported in those studies. The risk of bias is also higher in those studies. And so, in conclusion, I think we need further investigation into the burden and outcomes of hand trauma and infection, particularly in low-income countries. Thank you.
Thank you very much, Abigail. Are there any questions?
Hello, thank you for your study. Can I just ask, did you look at the treatment of this kind of patients? Was it fairly homogeneous, that they all washed out, debrided, and gave antibiotics if necessary between the high-income countries and the upper middle-income countries?
So we didn't look into, so we looked at the particular type of treatment. So some are closed, some are open injuries, and I've got all of the kind of individual data, but it's a very heterogeneous study population. So there's a mixture of closed injuries, but actually the variation across the kind of three categories where there were studies isn't that different. But we didn't go into such detail as looking at the specific antibiotic and debridement, but that's what we aim to do next, is go into more detail.
Based on what you have now, what's your hypothesis for the difference?
I think probably it's very difficult to know, and I think that's why I think it's possibly to do with the delay of presentation. I don't have much, so we looked at the delay to presentation, and there's not much data on most of the studies in that. In fact, only a very small proportion of each of the studies reported time to presentation of these hand injuries, but from kind of looking at those studies, I think possibly that is, but that's what we'd like to look at, and that's what we're highlighting.
Any more questions?
Thank you.
Oh, yes, there's one here.
Thank you. Do you think in the lower middle income country group, the fact that the studies tend to be prospective might be skewing the data as well? Because you're probably going to get a better pickup rate of infection with prospective versus retrospective.
Yeah, I think that's definitely the case. Although, interestingly, the upper middle income countries, it was mostly retrospective studies. But yeah, I think, you know, the lower mid, although they are prospective, the lower middle income studies, they are at higher risk of bias. I think generally the data is probably not that solid, but I thought it was generally interesting that there is just such a lack of data in some of the settings to look at.
Yeah, it might also be severity of the injuries in the settings. So there's lots and lots.
There's lots of factors, I think, that
factors to kind of look at.
Absolutely.
Okay. Thank you very much.
Thank you.
Our next speaker is Dr. Rajendra Nehete. He will speak to us on free innovator Tina flaps for reconstructing volar defects in fingers and thumb.
Good morning, chairpersons and the delegates. I'll be talking about the innervated flaps for the fingertips. Start going forward. Anybody from audiovisual? It's not going forward.
It is on the big screen.
Oh, yeah. Okay. The glabrous skin of the thumb and fingers have a good quality of sensations, mainly responsible for the excellent functional recovery. Oh, so sorry. And injuries leading to soft tissue loss in fingers and thumb. So sorry. If not addressed properly, it can lead to loss of function. As said by Dr. Harold Gillis, tissue losses should be replaced in kind. We have options of local flaps like a VY-plasty, oblique triangular flap, reverse homodigital flap, and pedicle thinner flap. But they can cover only smaller defects and may lead to scarring and contractures in the hand. The larger defects are better reconstructed by the glabrous flaps. They have less than ideal result, different color, develop only protective sensation, and all of them leading to less optimal results. The flaps from the sole can be done, but they have limitations due to 2 surgical sites. They require either a 2 regional anesthesia or a general anesthesia, and also lead to temporary disability. Hence, a free thinner flap, which has advantage of being glabrous, innervated, and involves same surgical site. It has been first described by Kamai, then Dr. Sabapathy, and there are many other people who have studied. But all of them, they have used a different type of nerves for innervation. What we were interested in from this paper by Fortune et al., based on the innervation based on the palmar cutaneous branch of the radial nerve. While some authors have reported the innervated flaps have better sensations, others have questioned the validity of it, and we present our experience of this. The study period was 17 to 22, total of 11 patients, and in whom we did 12 flaps. The thinner flap is based on the superficial palmar branch of the radial artery. This artery has consistent origin on the ulnar aspect of the distal part of the radial artery, 1 to 2 centimeters proximal to the distal wrist crease, and passes towards the scaphoid tubercle. It divides at the distal wrist crease into superficial and a deep branch. The superficial branch supplies the skin or the thinner area, while the deep branch continues as the palmar arch, or it may end into the first web by perforators to the skin and branching at the princeps polliceps. The palmar cutaneous branch of the median nerve, while passing underneath, innervates the skin in the thinner region. And this is the flap design. So we mark the superficial branch using a color Doppler, and a petal-shaped flap is planned. The medial edge is along the thinner crease, and the lateral depending on the defect size. And this is the harvested flap showing all the structures. And this is the flap inset with primary donor site closure. So after 1 week after surgery, patients were discharged, and they are followed up 2 monthly for objective sensory assessment, functional assessment, the donor site morbidity, and patient satisfaction. So total of 11 patients with 12 free thinner flaps. 8 has post-traumatic defect, 2 had cellulitis defect, 1 post-frostbite defect, and 10 males and 1 female. 5 out of 8 had post-traumatic defects of the thumb. 1 had loss of dorsum of the hand along with the finger defect. Both needed a flap cover. So our largest flap size was 6 by 2 centimeters. 10 flaps survived, while we had 2 failures. All flaps had arterial supply by superficial palmar branch of the radial artery, and 2 had distal perforators. All flaps had consistent innervation by palmar cutaneous branch of the radial nerve. This is arterial variation where there can be a distal perforator which is perforating the flap, and you may not get a superficial branch which supplies the flap. This is the demonstration. So 2 flap failure due to arterial insufficiency. 1 was treated by skin grafting after some time, and the other was treated with cross finger. This patient had 2 defects, and unfortunately we did 2 free flaps, and 1 of them failed. So sensory assessment was done by Semmes-Weinstein filaments and JAMA-2. Range of motion and extension lag and thumb abduction was noted. The mean hospital stay was 7 days. We had 8 patients who had more than 2 years follow-up. 2-point discrimination was 3.6, and it was 5.4. And all patients, 8 patients were past 6 months of surgery had developed good protective sensation. All patients had good range of motion. There were no scarring or contractures. The aesthetic results were superior. The donor site morbidity was not there, only paresthesias for 2 months. The scar tenderness was not there, and quality of score was good to excellent with no scar hypertrophy. These are a few cases. This was the index finger tip which was reconstructed with the thinner flap, a well-innervated flap, and a good cosmetic result. Another patient who had post-cellulitis defect covered with the thinner flap. He has excellent function. At the 5 years follow-up, he has excellent flexion and extension, no contractures. Another patient with thumb defect, and she had excellent function. So this is one of our doctor's friend who had frostbite when he did the Everest expedition, And he's an anesthesiologist, so we wanted to preserve length of the index and the middle finger in the right hand. So we did two innervated free flaps from the bilateral hand for the index and middle finger, because he works mainly with these three fingers, and he has an excellent result. So in our series, the largest flap was 6 by 2 centimeters, mean follow-up was 3.6 years. The mean 2-point discrimination was 5.4, and flaps had diminished light touch. That was 3.84, normal is 2.83. So as compared to other studies, we had consistent innervation by palmar-cutaneous branch of the radial nerve, and sensory recovery is excellent. It's a glabrous flap. It has consistent and reliable arterial supply, consistent innervation by palmar-cutaneous branch. It's from the same surgical site, and primary closure has no donor site morbidity. Only disadvantage is it requires a higher level of microsurgical skills. So it is one of the excellent option for volar defects of the fingers and thumb. We haven't done any comparison with other flaps like cross-finger flaps. Thank you very much, and I invite you to Asia Pacific meeting, microsurgery meeting. We have kept a low registration of 35,000 rupees. That comes to around 350 pounds, and you are all welcome. There is a separate section of one-day section of head and neck microvascular surgery. You can register for only 1 day also. Thank you very much.
Thank you, Dr. Nehete. Any questions from the audience? Dr. Nehete, other than the accessory branches, are there any other variations for this artery? Anatomical variations?
There is no significant anatomical variation. It is a consistent branch of the radial artery which goes to the thinner eminence and continues in the deep palmar arch.
Thank you.
Thank you.
I'm now going to bring the session to the close. A big thank you to all the speakers that were so well prepared and ran to time. And we will see you in the next, hopefully, in the next VPAPER session, which is in the parallel hall at 10 o'clock. Thank you.
Okay, everybody, we're going to start the next session now, please, if everybody wants to sit down. Luckily, the free paper session went very well according to time and schedule. So just to thank everybody for coming today for the session. Our session is on transplant and toes, indication and state of the art. We've got a really great group of speakers and we're hoping to have a really good discussion in this forum today. First, I'm going to introduce Dr. Christian Fessa, who's come from Cyprus. Christian has a lot of experience with toe transfers in the acute setting, and we're looking forward to hearing what he has to say. Thank you.
Hi, thank you. So it's great to be here among so many friends and esteemed colleagues as well. And thanks for the invitation. It's really an honor for us to share our experience. My name is Christian, and we run the unit in Cyprus with Alkis Alkiviadis. So this is a private center based in the American Medical Center in Nicosia. So Cyprus is an amazing island, and this is a warm invitation to anyone who hasn't visited to come. It's a great place to see beautiful, beautiful things. And this is our, as I said, this is our unit. So historically, Nicoladonia, as we all know, performed the first documented staged toe transfer. But it was, of course, the amazing work of Banki and Cobbett in the 60s that really led the way to this explosion in microsurgical techniques and surgical innovations that we use today to push the frontiers in these procedures to really amazing new limits now. We know how devastating hand injuries are, especially when digits are lost. And of course, traumatic thumb amputations diminish drastically hand function, and that's why we are called upon to reconstruct these in the best possible way. However, digital amputation injuries as well, they offer varying levels of functional limitation. And I think that nowadays, the reconstructive outcomes are really paramount to patient well-being, post-op function. And it really does require innovation and inspiration to achieve really good results, I think. I'm not going to bore you with indications for toe transfers. What I will say is I think that nowadays a lot of people, they do cases that may have not been done previously, just because the expertise is there. People are easy now with a lot of these small microsurgical toe transfers, and therefore, ad integrum, we are able to reconstruct almost anything now, and fairly easily as well. Of course, the pediatric congenital conditions are in an area of their own. I won't talk about those. And as I said, certainly in our practice in Cyprus, we see a lot of private patients who demand meticulous digital function, digital outcome in terms of aesthetics and function. And it was interesting that I saw a quote by Hiras et al. That said that since the hand is always naked and exposed, even if only the fingertip is lost, it presents a large handicap for patients, and they want it fixed. So our goals are, of course, to restore function, and we need to have a digit that's similar in appearance, sensate and mobile, obviously, associated with minimal donor side morbidity. But as we will see in the talk, it's so important, I think, and it's pivotal, the psychological issues that patients are faced with these procedures. Something else that I found very interesting was the concept of surgerying. We must be careful not to do cases just to maybe inflate our own ego sometimes as well. So the timing of this surgery, when is the right time to do a toe transfer? And this is very controversial. I was reading, obviously, various papers to prepare for the talk, and it is really a controversial area. So I think many cases are done as delayed procedures. I'm not sure of the statistics. A lot of people are now starting to do more immediate reconstructions because similar outcomes are being shown. But what do we mean by early and late? The terminology is very confusing. And it reminded me a little bit when we were looking at the work for free flap reconstruction, and people were giving arbitrary definitions of early, late,
it was all based on different criteria. And we know the work of Godina and Lister, and more recently, Gheorghescu, who gave their own classification. Immediate was at the same time as debridement, and then the rest of the classification. This doesn't all apply to toe transfers, but Yim et al., in a paper in 2004, this is the Fu Chan Wei team, big study, they said basically primary was anything before definitive coverage, secondary was after definitive coverage. So again, quite a big scan and span of time. Wu et al., for them immediate was an emergency procedure performed if a replant wasn't possible or had failed. And then recently Ornelli, fairly small study of 33 patients, immediate was 48 hours, or if there had been a failure of replant, delayed after 48. So all of these are talking about similar things, but the time frame is very different. So in our team, we like to try and simplify the issues, and we have to get down to basics. Is a replant possible, first of all, because that's the best option we have for our patients? If not, what other options are there? But we have to think, what is the injury site? What is the zone of injury? What is the risk of infection based on mechanism and contamination? Very, very important, what is the patient's psychological status? Do they understand what we are offering them? And then, of course, the issues, as we'll see, about recovery, rehabilitation, and the economics of these procedures. So 3 different cases, they all involve the fingertip, but the case on the right is a 2.5-year-old little boy that came to us with 2-finger amputation, traumatic, in a bicycle chain, but they brought us one of the digits. Now, it was a very difficult thing to achieve, to try and do a replant, but we had to go ahead. We had to try, because the parents said, we want you to try. And it looked fine up until a day after the surgery, but then we lost it. So the case on the middle is a crush injury. Again, different requirements because we have to offer an option there. Or the 2 fingers on the left, which was an acute guillotine-type injury. This patient here, degloving avulsion injuries of the index and middle finger. This was a work-related, obviously, but he insisted that he wanted to have an attempt at a replant. So, it will take us maybe 2.5 hours to achieve this. Unfortunately, it didn't work. Failure of replant, but we knew it would probably not work. And therefore, we go then ahead with a reconstruction with a dual toe based on a single pedicle, and this is a result maybe 6-8 months later. So if we compare variables on timing, and we talk about an early transfer, well, obviously we have to wonder whether a transplant was possible, first of all. The injury zones are less defined because we don't have the time to think about whether this can be done or not. Faster recovery, some studies say, reduced hospitalization and early rehabilitation, but everyone questions the psychological status of patients in most of these studies that I've looked at. Late transfers, you have time to think, the patient has time to think, but there is a question about increased hospitalization, and we will look a little bit about that. So obviously, clear-cut case, this is a hand replant. Obviously, this is going to be attempted, and he did well. But had it not been possible, for whatever reason, what would have been the options? And would anyone have considered doing an immediate, at the time of injury, transfer on this patient? He's been through so much. Would you put him through a transfer at the same time? Similarly, 4-finger amputation, they brought us 3 fingers. Of course, we're going to try and attempt to replant these, and we did. And there he is working maybe 7 months, back to his normal activity, and he even came a few years later to want a toe transfer on his index finger as well. This is the psychology of these patients. So just a few examples now on toe transfers. This is a 2.5-year-old boy. We tried to do the replant. It failed at 2 days. We went ahead with a dual second, third toe reconstruction. Fairly bulky pedicle. And that's because, obviously, you have to be very careful with the vessels in the area. This is a result after staged flap thinning and debulking. And this is a little boy, probably a year later. I couldn't load any of the videos, but he has very good hand function, and he's progressing well. This is a delayed presentation. Obviously, you're going to do a toe transfer if the patient wishes, much easier because it is delayed. And this was one of the first cases back in 2007 that we had done. These are the complicated ones because these are the patients that come industrial cases. Look at the finger on the index finger on the right. That zone of injury is not yet ready for us to surely know with confidence whether we can progress or not with a toe transfer. So we waited a few days. Patient had more time to think about it. And there's the result at a few weeks post-op. Similarly, this was a Greek, a young Greek guy who came and was working in Cyprus, hand caught in a industrial equipment. That one finger that was brought to us, that would never have worked. And luckily, he understood that. We waited a few days again. Is that a delayed transfer? No, it's not, because we're waiting for everything to show up, be confident about our zone. And then we did the first transfer from the 1 foot there. And then a month later, from the other foot, we took the second toe, fixed the other finger. And there he is at 6, 7 months, progressing well and starting his rehabilitation now. I'm just going to complete, just to show, fitting in, I think, with the previous speaker. This is a pulp injury that came to us. You know, we could have shortened the finger. He wanted, I think he was a piano player, he wanted to have a sensate tip. So we did a free island toe transfer there. You can see that nowadays, in the last maybe year, we take very short digital artery and we plug it in onto the digital vessels. The vein is longer, and that's the result there. So Georgescu in 2019 had a nice paper where he basically described 31 patients and said that within 24 hours, 70% had an immediate or a primary reconstruction. No difference in overall satisfaction between early and late, but patients were less satisfied and their expectations were not met, they said. What are the benefits of immediate transfers? They say that surgically it's an easier field to work in. There are economic benefits according to their study, but it's small. The disadvantage is reduced patient satisfaction and unrealistic expectations. And they suggest that possibly waiting 2 or 3 days, you have the benefits of early surgery, but the patient understands and is able to consent better. Wu et al., 2016, immediate reconstruction for them was an emergency procedure if a replant wasn't possible, delayed transfer within 2 weeks if there was contamination, or 72 hours if it was a failed replant. And that was all immediate. No statistical difference in success rates or outcomes between immediate and delayed. Yim et al., this is Fu Chan Wei's team. Primary before definitive coverage, I remind you, but anything between 2 and 25 days. Secondary, average of 10 months. And they came out and looked at survival, anastomotic revision, intra-op, healing issues, infection, no statistical difference regarding those areas. And this supports the idea, they say, that delay poses no additional risk. So in conclusion, I think the timing of surgery, everyone will agree, is a controversial topic. There is no conclusive evidence to support improved outcomes between primary and delayed reconstructions, and indeed no additional risk to transfer failure if you delay it. Potentially, there is a faster recovery and rehabilitation in primary, but I think a lot of work is needed there. And certainly in our practice, we manage to get our patients following a transfer, maybe within 5 to 7 days they go home, they're in a cast, we are very careful to guide them, we see them regularly in outpatients, and they start rehabilitation fairly easily. Gheorghescu said that there was no overall difference in satisfaction, but patients had reduced expectations. So I think the psychological status is where we really have to think about. And just to close, I would say that an informed and understanding patient is the key to avoiding disappointment. This little boy, he's 12. He came to us following a motorcycle accident. Don't ask why he was on a motorcycle, he was. He had a horrible, non-viable amputation of his lower leg, just above the ankle. We replanted it, and this is him back to his normal activity that makes him happy, his social well-being. So we want to keep our patients happy as much as we can. Thank you very much.
Thank you. We're going to hold questions until the end.
Thank you.
So our next speaker is Dr. Hendra Nahite. He's going to speak on functional restoration of bilateral hand amputee.
This is the case report of the patient we faced. And this was a 25-year-old male with bilateral crush at the wrist level. He works in a press punching machine injury. And this was the level of the amputation at the intercarpal region. So this is an extreme mutilation, and mutilating hand injury means patient with loss of fingers or thumb proximal to the MP joints. The various authors have described mutilated hand in a different manner. And this amputation at the wrist level is really an extreme level of mutilation. As a consequence, the patient is completely dependent on others for activities of daily living, and there is total loss of earning capacity. So aim of treatment in such patients is to make the patient independent. There is social rehabilitation and workplace rehabilitation. So there are options for the treatment, like bilateral hand transplants, and I'm proud that India is one of the leading. We already done more than 23 bilateral hand transplants in India. It achieves normal function. The only disadvantage is cost is prohibitive, and there are consequences of lifelong immunosuppression. Vicky's procedure, if you think, it achieves pincer function, good supporting hand, but it is suitable in unilateral cases wherein other hand is normal. The Krukenberg reconstruction, in my opinion, today achieves some function by pincer grip, but socially it is unacceptable in today's era. The prosthetic eye limb, again, the cost is prohibitive. The patient has to be careful while using it in water, and it involves lifelong maintenance of the prosthesis. So our thought process was, can we provide the reconstruction with reasonably good function, affordable in Indian scenario, with no immunosuppression, and make patient independent of others? So in Indian scenario, especially for poor factory workers, toe transfer is a viable alternative. Classically, patients who have suffered traumatic loss with an intact metacarpophalangeal joints are ideal candidates for toe-to-hand transfer, but this was at the wrist level. So there are various authors who have, as previous speaker also mentioned, they have described toe transfers in great detail. And Del Pinal, in his article on severe mutilating injuries, it's a type 5 injury, a bilateral injury. He suggests to do a bilateral second toe transfer. But then when you are doing, if you have a bilateral patient, it becomes a complicated procedure. So what we planned for this particular patient was the primary transfer of 3 toes with a free flap on each hand, and 1 hand in 1 stage. So this was to provide a tripod grip with adequate hand span and pulp-to-pulp pinch. So why in acute stage? There was a lot of discussion by the previous speaker also, but in our set of circumstances, many times the patient is not ready for secondary toe transfers. They don't realize it, what they are going through. And if you can get a consent within 2-3 days after the injury, then it becomes much beneficial for them. So this was the right hand reconstruction done using a great toe and two second and third toe at the wrist level. So these are the technical details. I'll skip it. So it needed a soft tissue cover. So we did a primary ALT flap, and this was on-table reconstruction of the hand. After 7 days, we did the left hand reconstruction using the similar. So in problem in this patient with amputation at the wrist level, there is total loss of metacarpals, and it leads to reduction in the length of the reconstructed fingers. So therefore, there is no possibility of achieving wide grasp and pulp-to-pulp pinch in the same hand at the same time. And that is why it's not going forward. Yeah. So while doing the left hand reconstruction, we purposefully kept it the span, the larger span, so that he can have a pulp-to-pulp pinch in the right hand, whereas the wide grasp he will have in the left hand used as a supporting hand. However, on the first post-op day after the left hand, second and third toe had no circulation, so we had to put intervening vein graft on the next day. But the wound closure could not be achieved because of the edema of the tissues. It's taking time to go forward. Yeah, so we did a TDAP flap on the proximal ulnar artery to cover this defect. So this patient had 6 toes transverse and 3 free flaps within 10 days of injury for both the hands, and this was his result. It's taking time. Yeah. So this was his X-ray and the fixation on the carpal bones. So when we did the functional assessment, the 5-gram filament, we had a good sensation, and we did the Jamar 2-point discriminator, 2 to 4 millimeters in and all the fingers. When we scored the Tamai ADL score, it was 8 out of 20. Although the function can be easily restored, the aesthetic appearance is more difficult to achieve. Not surprisingly, digital and thumb amputations have profound impact on quality of life and psychological functioning and the ability of the patient to work. Although patients make significant strides with respect to function and appearance, the return to pre-injury function is less clear. But then this patient, when we saw, he does all the activities of daily living himself. He is not dependent on anybody else. At workplace, after 2 years, he is working fine. He's modified his work. So he works himself, and he goes on bicycle to his workplace. So if we talk about the donor site morbidity, it is not very significant because he can cycle, he can walk normally. So 3-finger grip with the opposable thumb gives a superior function over a pincer grip. The function of the MP joint can be mimicked on the radiocarpal joint by bone fixation in a flexion for better function of the palmar grip and grasp rather than forceps grip in the straight fingers. So that is why we fix these toes in the flexion. It's taking a long time. So to conclude, although the toe transfer technically continue to evolve, this procedure are lengthy and technically demanding, but meticulous planning and execution can achieve a better function. So there are articles about the evolution of toe-to transfer, and the multiple toe transfers can provide prehensile tripod pinch for the metacarpal hand. However, the functional results of the multiple toe transfers will be restricted when it is a proximal, and sometimes there is an alien appearance of the reconstructed hand. The psychological benefits of the transplanted hand are more, but however, there are ethical debates concerning the psychology and immunosuppression to the patient. So there was the invited paper, The Battleground Between the Two Giants Toe Transfer. The Fuchanwei states that further discussion is needed to delineate which giant of reconstruction should prevail in each scenario. So we think that primary hand reconstruction using 3 toes and a flap is an excellent alternative to the hand transplant or a prosthesis to achieve a good function. At present, in Indian scenario, we don't find any other better alternative for such mutilating injury. It's at a reasonable cost of less than 10,000 USD, and no immunosuppression and consequent complications to these patients. So I have questioned many times for this patient, is it a surgical tramp or reason? And I always get the answer no. Thank you very much.
Okay, thanks very much, Dr. Nahete. We look forward to having the discussion. Thanks for such a challenging case. Now we've got Professor Jones, who's going to talk to us about toe transfers again. Looking forward to hearing the California or US view. Thanks.
Thank you. So I'm going to give a general overview of toe transfers for trauma. And obviously there are many, many options for toe transfers, from a great toe, the various modifications, a second toe, a partial toe, and then combined second and third toes. This just shows you the various options: a great toe, a second toe, a Morrison wraparound flap, and a trim toe transfer. The anatomy is very important, and you need to understand the arterial anatomy. Most surgeons still base these toe transfers on the dorsal circulation, which is the dorsalis pedis, and then its continuation into the first dorsal metatarsal artery. But in fact, the first plantar metatarsal artery is much larger, but it's very, very short, and therefore you have to elongate it with a vein graft. This is, again, just showing you most surgeons go from proximal to distal, but I think Simon Kay probably was the first, and then Fu-Chen Wei actually wrote it up, talking about a distal identification in the web space and then going distal to proximal. So on the left-hand side is a proximal to distal dissection of the first dorsal metatarsal artery. On the right-hand side is showing you this very large first plantar metatarsal artery and going from distal to proximal. The nerve and venous anatomy is fairly straightforward, and obviously you decide whether to take 2 nerves or 3 nerves, depending on the recipients that you have. I think the decision to do a toe transfer is very, very difficult, and it's difficult especially if you're dealing with children, because obviously you're dealing with probably 2 parents and the child, as opposed to just one adult. And you can simulate these toe transfers with prostheses, you can show them photographs, you can show them videos, but we've really based most of our work now on hooking up patients with other patients who've had a toe transfer, or a family who've undergone a toe transfer. And this just shows you I think he's a 12-year-old boy who's had a second toe transfer. This girl is 2 years old. This girl gets it already and understands that she needs a toe transfer for this transverse failure. The surgical technique is straightforward. We use 90-90 interosseous wiring for bony stability. The flexor and extensor tendon repairs hopefully can be done for most trauma cases, but you need to be able to think on your feet and do tendon grafts or tendon transfers, and the same for the nerve repairs. You may have to do nerve grafts or even do end-to-side nerve transfers. The venous anastomosis is usually straightforward to a dorsal vein. The arterial anastomosis, again, can be into the radial or the ulnar artery or branches. And you really have to be very, very careful that you don't put too much tension on the closure, so we liberally use split thickness or full thickness skin grafts and remove them if necessary later. Monitoring, I'm a great believer in pulse oximetry. We have a very large series. We even sometimes send patients home very early with the pulse oximeter if they live close. And obviously the pulse rate itself reflects the patency of the arterial anastomosis. The oxygen saturation, the SaO2, reflects the patency of the venous anastomosis. But we don't know where the cutoff point is, but it's fairly high. And once the SaO2 drops below 90, 92, we get really worried about the venous anastomosis. This is our classification of thumb amputations. R1 is obviously just a thumb, R2 is thumb and index finger, all the way to an R5 hand, which is amputation of all 5 digits. What's the critical level for a thumb reconstruction with a toe transfer? In most textbooks, they'll tell you it's at the level of the mid-proximal phalanx. Anything distal to that may be quite functional. Anything proximal is definitely not functional. But many patients want a reconstruction, even distally, at the level of the distal phalanx. So just showing you some examples of the various techniques for an isolated thumb reconstruction. Just showing you an R1 hand, an R3 hand covered with a groin flap, and then an R5 hand with absence of all 5 digits. Harry Bunke did the first toe transfer in a monkey in 1966, but obviously Cobbett did the first toe transfer here in Great Britain in 1969. This is a great toe transfer, and it's still useful to use a great toe transfer, as in this child. This is an explosive injury, an M80, which is a very powerful firecracker. And you can see the thumb has to be released from the first web space. And to do this, most people use a groin flap. We've advocated using reverse radial forearm flaps. And by using a reverse radial forearm flap, you can use the proximal radial artery to provide inflow, as I'll show you, into a toe transfer. So this is radical release of that first web space, removing the index finger metacarpal. A groin flap is very useful in a 16-year-old to give you lots of soft tissue coverage, and then a great toe transfer. And you might say, well, this is too big. Well, it isn't too big because you need a lot of surface area with good tactile simulation, and you can see it's the same size as the opposite side. A second toe was probably done in China, actually even before Bunke and Cobbett in 1966, but this is still very debatable. The great advantage of a second toe transfer is that it's an inconspicuous donor site, but it's certainly less satisfactory, appealing cosmetically. So here's a young boy of 3, an amputation at the level of the MP joint, and you can see here we can either use the first dorsal metatarsal artery or we can use the first palmar metatarsal artery, but obviously we'd have to put a vein graft onto that. And this is the result 2 years later. And the beauty is that this is an almost inconspicuous donor site in the foot. Here's another 3-year-old with another severe amputation injury. Once everything is healed, this is an incredibly proximal injury. There's only just a remnant of the CMC joint, and there actually are some thenar muscles. But again, we have to use a second toe to get the length of the metatarsal. So here, again, just demonstrating liberal use of skin grafts to close the wounds on the hand. And here's the result down the line. Again, very inconspicuous donor site in the foot. Wayne Morrison in Australia came up with the concept of the wraparound great toe transfer. And this is just essentially a degloving of the soft tissues and then wrapping those soft tissues around an iliac crest bone graft. But the problem is that iliac crest bone graft over time resorbs. And so this is rarely used, I think, nowadays. But it can be used in the emergency situation where you get a degloving injury of the thumb, as is shown here. This is an electrical burn injury bilaterally. And so we did a fairly rapid elective bilateral toe transfer, a degloving using the Morrison wraparound flap to cover the bone and tendon of each thumb. And this is just showing you the result 1 year post-operatively. The wraparound flap was really modified by Jim Steichen, and it's very hard to find in the literature. But what he said was you need to take the distal phalanx of the great toe so that you have the distal phalanx of the great toe, then into position bone graft, and then the remnant of the thumb metacarpal or proximal phalanx. And in these cases, when you use the distal phalanx of the toe in this modification, you don't get the resorption of the iliac crest bone graft. So here's an example, again, just distal to the MP joint in a young woman, and just showing you the Steichen modification, and now making literally a custom-made toe transfer to mirror the opposite side. And you can see that interposition iliac crest bone graft. And here's the result. And now the donor defect in the foot is relatively minimal. Here's another example. Again, this is a carpenter. And again, showing you this is now a trim toe transfer advocated by Fu-Chen Wei in 1988, but also Joe Upton in Boston described the same technique the same year in 1988. But this is now trying to make a custom toe exactly to mirror the size of the opposite thumb. And so you can leave, hopefully, the proximal phalanx of the foot, but you're trying to make the size of the toe transfer exactly the same size as the opposite thumb. And this is just showing that tangible excision of the medial aspect of the distal phalanx and the medial aspect of the proximal phalanx. And this is showing you the comparison now of the toe transfer with the opposite side. And obviously, in the donor foot, we've taken both proximal and distal phalanges. But you never, ever take the metatarsal of the great toe, if you can possibly help it. Here's another example of using this technique. And again, in a young woman, an excellent cosmetic result. And finally, this is a relatively young boy at the level of the MP joint with a trim toe transfer. And again, just showing you the comparison between the normal thumb and the toe transfer and the donor defect. And just if the video plays, this is him with his eyes closed, tying his shoelaces, just showing you the functional reconstruction. So finally, where are we in terms of reconstructing thumbs nowadays? I think the first speaker talked about doing toe transfers very early, and this is obviously a crush injury with obviously gangrene of the toe. And so we can just take the small amount of tissue out of the foot and reconstruct that reconstruct that thumb very early with a custom toe transfer. This is the result, again, showing you liberal use of skin grafts so you don't compress the vein. And then the comparison with the opposite thumb and the defect in the foot, which is quite acceptable. What about multiple fingers? Multiple fingers are usually replanted. This is not really a replant, this is a revascularization. But this is a very, very young child. You have to go the whole mile to reconstruct these children. And this is just a 5-year follow-up just of that replantation, multiple tendon, multiple nerve transfers, and this revascularization using a vein graft and 3 enterocystic anastomoses. This is another young child, again, with a transmetacarpal amputation. You have to try and replant this at all costs, and this is the result after amputation of the small finger. So occasionally you see these children and adults with either amputations of all 4 fingers, this is what we call a U4 hand, or amputation of all 5 digits, which is an R5 hand. And these are definite indications for toe transfers. So we can use a single second toe just to make a finger. We can use bilateral second toes. We can use combined second and third toe transfers. So this is a boy from Gaza, not recently, a few years ago, picked up a grenade and obviously decimated his hand. And so in this boy's case, we used 2 second toes done sequentially. And again, showing you this concept of using the reverse radial forearm flap. The radial artery is flipped down. The proximal radial artery now gives the input to the toe transfer and soft tissue coverage. And then we come back 3 months later and go end to side into the same radial artery with the second toe transfer. And just showing you a 3-year follow-up, his donor feet, and this is a 12-year follow-up on this same child. And finally, this is an 8-year-old boy with burns, with again an R5 hand bilaterally, amputation of all 10 digits. And in this case, you have to make, because there are metacarpals, you have to try and deepen the web space first between the thumb and the index finger. And then we use great toes to reconstruct his thumbs in contralateral combined second and third toes to give him 2 fingers. And we did this because he was 8 years old in sequence. So we did 1 great toe transfer to make a thumb, then a 2nd great toe transfer to make the opposite thumb. When he was 8 years old, this is him after the 2 great toe transfers. And again, we want to use the great toe transfer because we want to have the greatest surface area for tactile simulation first. And even doing this, it gave him dramatically improved function. And then we went ahead with combined second and third toes. We'd already taken the great toes on the dorsal circulation, so now we have to take them on the, in this case, the 2nd plantar metatarsal artery, and again, did these sequentially. This is his result after the 6 toe transfers. Actually, I was going to amputate him at the transmetatarsal level. He said, absolutely not. And so we left his 4th and 5th toes, and then we waited 4 years to test his gait analysis. And his gait analysis is essentially normal. He can run a mile without any problems. This just shows his testing 4 years later. His DASH score, or his inverted DASH score, is 27. Normal, it would be 0. He has no functional limitations. And in fact, we've tested now 15 prosthetic patients, which will lead into the next talk. We've tested 5 bilateral hand transplant patients, and we've tested 6 toe transfer patients, either bilaterally or unilaterally. And the toe transfer patients beat the function of the of the prostheses and the transplants quite significantly. So in conclusion, toe transfers after distal hand loss, the success rate should be very close to 100%. Re-exploration is still a potential problem for anastomotic thrombosis, maybe somewhere between 2 and 8%. Sensation is excellent, much less than 10 millimeters. Joint motion is debatable. Some people get excellent motion at the IP joint and the MP joint, others don't get as much. The pinch strength is much better with a great toe or a variation, much less with a 2nd toe. And growth in children is exactly the same as the growth of the contralateral toe. In terms of appearance, I think wraparounds and trim toes now are the way to go unless you want a big surface area of the great toe for sensation. And the donor foot, you must not really take any part of the metatarsal head, otherwise you'll end up with problems with ambulation. But really, if you use the 2nd toe, the donor site is inconspicuous, and gait analysis of many of these children and adults is very close to normal. So in conclusion, I think toe transfers have evolved over the past 40 to 50 years, and I think they exemplify what Sterling Bennell said in the 1940s, to those who have nothing, a little means a lot. Thank you very much.
Great, thank you very much, Neil. That was a fantastic talk. Looking forward to the discussion. I'm going to introduce now my colleague David Leonard, who's not Simon Kay, but Simon's on Zoom. He'll join us for the discussion. So David's part of our hand transplant team, leading force for the research side. So thanks, David, for coming today.
Thank you. All right. Apologies, just a moment or two while the technology catches up. hopefully. Excellent. Ms. Burke, Professor Jones, ladies and gentlemen, it's a real pleasure to be back in Glasgow today, where I did so much of my training, and to speak with you today on behalf of Professor Kay and the Leeds hand transplant team. Please let me start by apologising to those who were looking forward to hearing Professor Kay speak on this topic. Prof sends his apologies. Personal commitments have prevented him travelling to join us in person, but hopefully, technology allowing, he will join us online and contribute to the discussion. I'd like to share with you the experience of the Leeds UK hand transplant team with transplantation distal to the wrist. The slides will advance. I have no relevant conflicts to disclose. To date, our total experience with hand and upper limb transplants extends to 17 limbs for 10 patients. In many spheres, these numbers would, of course, be considered modest, and certainly we're not keeping up with the Indian experience that we heard about earlier. But we do now count amongst the most experienced units in the Western Hemisphere, and with 5 patients currently on our waiting list, our activity is continuing to increase, while unfortunately units in other jurisdictions are beginning to discontinue their services for want of consistent funding streams. Of these 10 patients, 3 presented with amputations distal to the wrist, but for various reasons were unsuitable for toe transfer, leading us to consider and ultimately proceed with distal level allotransplantation. These 3 patients now have follow-up of 7 years, 5 years, and 9 months, respectively. Their amputations resulted from crush injury and industrial press, and secondary to life-threatening sepsis and prolonged ICU stay and inotrope dependence in the second 2. I will return to the details of each case in more depth shortly. In assessing any patient for hand transplantation, regardless of the level, one of the principles by which we are guided is that while transplantation should, of course, meet the functional and psychological goals of the patient, we should plan for failure, and subsequent reamputation should not leave them at a disadvantage over their pre-transplant condition. But how does this principle apply in amputation distal to the radiocarpal joint? In a metacarpal hand, functional capacity is limited, as we've seen, and as we all know, but prosthetic fitting is also a significant challenge. Convention amongst hand transplant centres faced with this scenario has therefore been to undertake proximal revision of the amputation and transplant at the level of the radial metaphysis. This lessens the technical complexity of the transplant, and proponents of this approach cite the secondary benefit of straightforward prosthetic fitting on the distal forearm stump in the event of transplant loss. This statement is, of course, accurate, and shortening to the distal forearm level might appear the most straightforward means to comply with our guiding principle. However, we believe that this approach misses out on the psychological ramification of transplant loss, and we see value in planning to decouple such a negative event from any potential future decision to shorten the residuum in pursuit of better prosthetic fit and ultimate function. Just to get into the cases in a little more detail now, and what led to their journey to hand transplant at distal level. Patient 1 was 57 years old at the time of transplant. He sustained bilateral crush amputations of all his fingers at the level of the metacarpal necks and industrial press, a U4 hand. His thumbs, thenar eminences, and wrists were uninjured, and he'd undergone debridement, soft tissue coverage with bilateral posterior interosseous artery flaps, avoiding the sacrifice of a major axial vessel in the limb. He was not a candidate for toe transfer due to advanced gouty destruction of the toes of both feet. So in 2016, he underwent bilateral transmetacarpal level transplants with preservations of his native thumbs, bony fixation, as we see here, and his nerve coaptations were performed distal to the separation into specific motor and sensory components. Patient 2, who was 43 at the time of transplant, is a female survivor of life-threatening sepsis. She required amputation of the right hand at the level of the proximal metacarpal shaft, left transhumeral amputation, and also bilateral transmetatarsal amputations of her feet, again excluding the use of toe transfers for her right hand reconstruction. Her right wrist was competent. In 2018, she underwent transplant of the left arm above the elbow and of the right hand through the midcarpal joint with box wire fixation as shown, and again targeted motor and sensory neuropathies. Our third patient, a 23-year-old student, survived meningococcal septicemia during her first year of university studies, but she required bilateral below-knee amputations in addition to right transmetacarpal amputations of all digits. Her left thumb and fingers were amputated through the proximal phalanges for the fingers and just distal to the IP joint in the thumb. This hand provides her with useful function, and we agreed as a team with her view that this should be retained. Her right hand, however, provided only a paddle assist function. So earlier this year, she underwent right transmetacarpal transplant of all the digits on the right hand, as shown here, again with distal coaptation of sensory and motor nerves. All of these patients have received our standard immunosuppression regimen with induction with alemtuzumab and methylprednisolone. This is followed by maintenance with tacrolimus, mycophenolate mofetil, and prednisolone, rapidly reducing to 5 to 10 milligrams a day. The rehabilitation is supported both locally by the team in Leeds and by therapists in each patient's local area. Another technical pause. There we go. So what of outcomes? I've no doubt that those of you who have heard Professor Kay or Ms. Burke speak on our program in the past will recognize this slide as how best to encapsulate and present the wide array of outcomes following hand transplantation is a recurring discussion amongst our group and a challenge with which we continue to battle. The human hand, as we all know, fulfills a vast array of functional requirements. But beyond that, it is, along with its contralateral partner and the face, an integral component of the ring through which we interact with and project ourselves into the world around us. Of course, presentation of objective measurables is a necessary component of outcome assessment, but relying solely on such measures, we feel risks reducing our perception of the hand to akin to a living mechanical prosthesis. And we've learned much from our patients to remind us of the value of defining outcomes broadly, not least the value that transplant can have in restoring an individual's feeling of completeness. So with the limitations of outcome scores duly noted, our score of choice is the Canadian Occupational Performance Measure, as this maps scores to patient-identified goals. These graphs depict the COPM performance and satisfaction scores for the entire cohort of 10 patients, which of course includes transplants at all levels from distal to transhumeral. Those in bold orange, yellow, and red are from the 3 distal hand transplant recipients. You will note that the third of our distal transplants, patient 9 overall, has not yet reached their first annual assessment. Both performance and satisfaction scores of the earlier patients are comparable and demonstrate steady improvement up until year 3, which is a rather longer period than we initially predicted. DASH score similarly continues to decline steadily to year 3, and our distal transplant recipients are, as one would expect, given intact function of shoulder, elbow, and wrist, reporting levels of disability at the lower end of the overall cohort. All 3 of these patients demonstrated rapid return of protective sensation, benefiting both from the short regeneration distance resulting from the distal coaptation of targeted nerve branches and the enhanced pace of regeneration that we now routinely see in patients treated with tacrolimus. All patients demonstrate recovery of strength sufficient for functional integration of the hands, but the peak force, pattern of force production in different grips, and progression over time vary widely. Patient 1 leads an active retirement as a keen gardener. Patient 2 has returned to employment, now working as a medical receptionist in a private hospital, in addition to her busy childcare commitments. And patient 3 is still on a leave of absence from her university studies, but is looking forward to getting back to these in January. So on the basis of our experience with distal hand transplants over the past 7 years, what have we learned? Well, in terms of indications, we believe that distal transplantation is indicated in patients who have an amputation distal to a competent native wrist with preserved forearm rotation. If this is combined with a competent first copper metacarpal joint, particularly with preserved thenar motors, this is a strong indication for distal transplant and offers the potential for a really excellent functional result. To the contrary, a poor native wrist, as we see in this patient who sustained a crush amputation with extensive ligamentous injury, dorsal degloving, and fractures in the retained bones of the proximal row, a patient with extensive soft tissue loss, or with a proximal nerve injury would all be relative contraindications to distal transplant, and we would expect the patient to be better served by transplantation at a more proximal level. We find that distal transplant carries a number of significant advantages. Coaptation of donor to recipient nerves beyond the level at which the ulnar and median nerves separate into motor and sensory component offers, in combination with the tacrolimus effect, extremely rapid sensory recovery and reinnervation of the intrinsic muscles. And this can be reflected in some return of intrinsic function within a year of transplant. Rehabilitation and return of useful function are enhanced by the tenodesis action from the intact native wrist. And on a more technical level, the lower volume of skeletal muscle in a distal transplant is also less vulnerable to ischemia reperfusion injury, with obvious benefits not only for the transplant, but for the overall health and recovery of the patient. And finally, we find there's tangible psychological benefit to preservation of native tissues where it's possible to do so. These benefits can support some quite remarkable functional recovery in these patients, as we see here in the third of our 3 distal transplant patients at just 5 months post-transplant. There are, of course, disadvantages, and these come largely in the form of complexity, both in the planning and in the execution. Surgical time for these cases has certainly been longer than for our more proximal transplants, but our experience has been that this is a burden carried chiefly by the surgical team with a knock-on effect on department logistics, but has not significantly impacted patient recovery, well-being, or complication rates. In sum, distal hand transplantation is a technically demanding affair, but one which we believe is deliverable by any competent hand transplant service. Objective outcome measures in our cohort compare positively to distal forearm level transplants, and our patients report important psychological benefits. I would go so far as to say that we now consider this the allotransplant procedure of choice for a patient with metacarpal level amputation in appropriately selected patients for whom toe transfer is not appropriate or not available, particularly when there's preservation of a functional thumb. And I'll leave you with a few more seconds of our first distal hand transplant recipient during his latest therapy review. Thank you very much, and hopefully Professor Kay will be available online to join us for the discussion.
Could all the speakers come up onto the stage, actually, because it might make it easier for us to have a discussion. Is Simon? Oh, there you are. Hi, Simon. Yeah. Okay. So, does anybody, have we got any questions? I might start the ball rolling then. Christian, you raised and Dr. Nahese both raised the issue a little bit about the social and funding aspects in different countries, I think, with regard to timing and what options we should be thinking about. What do you think? Do you want to elaborate on that a bit?
I mean, to be honest with you, our service is slightly more different because it's a private practice service. We are not with my colleague Alkis is there in the audience, and we run a purely private practice in Cyprus. So we receive a lot of work from the government, which is sent to us. And I think, because we have our own team, set up, we can plan these more easily when it's necessary. So timing-wise, our only restriction really is when we consider that the patient is ready to have the procedure done, whether from a point of view of wound healing and being able to accept the transfer, or from a psychological point of view. I think the other thing to raise as well is that we're talking about Cyprus, so it's a different culture maybe. And people, our experience, because I worked in the UK for many years as well, and I trained in the UK, it's a different it's a different psychology of patients. Our patients are really demanding there. They will come and they will say, I want to have the smallest defect reconstructed in the best possible way. And if we can offer it, we will. So we want to be sure that they are willing and they are aware of what this involves. So I think, as Professor Jones said as well, they need to realize that it's a big procedure. They are going to lose a toe, and they don't quite think about that. It's nice to think you're going to get your hand back, but then they come and they say, oh, but I didn't realize, for example, that it would look like this. Obviously, if it's a second toe, you can't see the difference really. But with big toes, trim toes, all of those, yes, they do come back. And we often provide psychological support as well to them.
Okay. Dr. Nahete, I know, Simon, I'll bring you in just in a second. Did you want to say anything about yours? Because you mentioned the fact that part of your decision-making was kind of financial or access to.
Yes, in India, the situation is different. In most of the government hospitals, the facilities are inadequate, and most of the work is being done in the private hospitals. And many of our patients are not insured. They pay from the pocket. So we always have to think about whether the patient can really afford what we are going to do. In a setups like us, where I have a 30-bedded own hospital, where the economics is in my hand, many times I can discount the services and make them happy. But in majority corporate hospitals, that also becomes difficult. But we get a mixed population where some patients are really poor, some patients are good, some patients are insured. So at present, the situation in India is, on the other hand, we are leading into hand transplants also. So we have a very mixed situation. If you think about the social acceptability, almost 50% of my patients, they will not accept toe transfer for anything, even if they have disability, because they don't want to lose their toes from the foot. So, but yes, 50% of them say yes to toe transfers, and they're very easily convinced, and they easily accept. On the opposite end, we get, as doctor said, we get patients with distal fingertip injuries. They want to do toe transfer, or they want to even do a microvascular flap for a better cosmetic result. So we get all types of patients, and we have to really customize according to their situation, financial situation, social acceptability, their psychology, and then treat them.
Okay, thank you. Simon, did you want to come in there?
Yes, thank you, Gordon. These are very good talks and very interesting, but I'd like to make a couple of comments. One is that very large literature available on the benefits of immediate and delayed breast reconstruction. And it's worth looking at that literature because many of the problems that you discussed have been discussed 30, 40 years ago in that context. I was interested to see that Neil employs the same mechanisms we do to introduce the patient to other patients who've had toe transfers as part of the preoperative advisory and counselling service, albeit in children. The problem with immediate reconstruction for some units, and I realise cultures are different, is that it's very difficult to obtain truly informed consent in the presence of acute trauma. It's very hard for the surgeon to make an assessment of the capacity for understanding the patient. And choice, particularly where these sophisticated choices are available, making the choice between no surgery, one toe, two toes, great toe, double toe, are very difficult choices to make. I'm unconvinced myself about the benefits a delay or even of immediate or semi-immediate reconstruction. And certainly in our unit, we are very cautious about the degree of consent we obtain and how mature the consent is. In the hand transplant program, we've looked very closely at the issue of consent, more closely than in any other service. And I certainly think it's a very complex, evolving understanding, even for something that is relatively harmless as toe transfer. And that's maybe a cultural difference.
Neil?
I think Simon and I probably have the same opinions about timing. When I was training, I was told never ever do something in the middle of the night that you can do the same 24 hours, 2-3 days later. And I think it's very important that most things do not need to be done in the middle of the night. And especially doing a toe transfer in the middle of the night or the next day, the patient really needs to understand their injury and their deficit, rather than suddenly having an injury and then waking up with a toe transfer. They will never be as satisfied as seeing what they're unable to do for several days or several weeks afterwards, and then see the amazing difference in hand function that they get from a toe transfer or a tendon transfer. So I think there are very, very, very few indications for an immediate toe transfer in the middle of the night. And I just showed you, I think, just 1 or 2 immediate toe transfers. But it's really important that they understand their injury and the deficit they have, and then they'll actually be much more thankful once they've had a very, very good reconstruction. Simon, you're grinning.
No, it's great. It's great to have a patient thankful, I agree. But I think I would recommend going back to the literature on immediate breast reconstruction. And I speak as somebody who was a keen advocate of immediate microsurgical breast reconstruction in the past. But actually, the psychological complexities are really quite sophisticated and complex.
Okay, any questions from the audience? I wanted to ask you, Neil, about the DASH scores that you had for the bilateral hand transplant patients and any other outcomes that you measured. So did you have any other outcomes? Any other outcomes or just tell us a bit about those patients.
No, we did. We haven't really. It's very difficult to get scores on patients with hand transplants or, for that matter, toe transfers. And so what we tried to do is to do an amalgamation of the various scores that are done by therapists and try and bring them all into one number. But it's almost impossible. But I think the DASH score is pretty useless. We use the inverted DASH score is just an inversion because most other scores go from 1 to 100. The DASH really starts at 100, so it's better to invert it. That was the reason for doing it. Yeah. Maybe that's as much as I'd like to say. No, perfect. David, do you want to come in just a little bit about why we're using the Canadian? We've got a fabulous therapist, Joanna Burden, who does our scoring, and Sarah Taplin. But David can give an overview.
Absolutely. I think I'll probably struggle to do justice to what Joanna and Sarah would say about the scoring. The thing that we find a positive with the COPM is is the split of a performance and satisfaction measures, so you do get some element of the sort of patient-reported satisfaction with their hand function, but also the mapping to patient goals we find adds some value. But I'm very glad to hear, Professor Jones, that it's not just us who struggle with how to amalgamate these scores and how to present this as a totality that does justice to the complexity of what these patients experience and what their outcome really is. And a concern that I always have discussing this is that it can tend towards the reductionist and leans into this argument of toe transfer or hand transplant or advanced prosthetics being in competition, and I think that's a fallacy. It's more a case of the right operation, the right choice for the right patient at the right time, and I think that's how we should be thinking about this.
Can I make a point?
Yes. Yeah, you can. Then Neil wants to talk as well. Yeah.
Sorry, Neil. Well, first of all, I think that we prepare and consent our patients over a period of 1 year. It's a mandatory 1 year of consenting and understanding. And then when we evaluate them, that goes on for 4 or 5 years. And we don't evaluate them just on therapy measures. We evaluate them. The thing about COPM is it evaluates them against their own goal. And there's a dense psychological evaluation also. And I think we've held our transplant service to the highest standard in terms of consent and evaluation that I've come across in surgery. But of course, it's very expensive. You can't do that for everything.
What I wanted to say was that I think way back in 2016, we brought together at the American Society for Surgery of the Hand meeting what I considered at that time, it wasn't Simon hadn't started doing his hand transplants, but I brought together, were we there? Anyway, we brought together what I thought was the best hand transplant patient in the world at that time, a man from Austria. And then we brought the boy with the 6 toe transfers, and we brought a patient who'd had bilateral amputations and was fitted with the sort of state-of-the-art generation prostheses, and we actually had them on stage, and we set them to do various simple tasks on stage, and we also allowed the audience, obviously all hand surgeons, to interact with them and also examine them. And it was very interesting to understand the psychology behind their decisions. And for instance, the man that had the hand transplant was single. He was maybe in his 60s, and he had no real relatives. And he said, you know, I don't frankly care if the immunosuppression kills me, because I've got no relatives. I just want to try and last out a few more years. The man with the bilateral prostheses said, there is absolutely no way on earth that I'm a 32-year-old guy, I have a young wife, I have 2 children who are under the age of 10. There is no way that I'm going to risk dying in 10 years from the risks of the immunosuppression. And the boy, the 8-year-old who is now, I think, 18, looked at these other 2 and looked at their function and said, there's absolutely no way on earth that I'm going to be better off having a hand transplant or prostheses. I'm far superior to these guys in terms of my function. But they all had their individual opinions, and I think that's very important.
I just want to say to the audience, I understand all that, Neil, and I go back very fondly to the memories of the meal you and I had in Paris, where you kept telling me how hopeless hand transplant would be. And I understand. Let's be clear. First of all, most of our patients weren't suitable for toe transfers because they didn't have feet. The second thing is that most patients with hand amputations are best served by prostheses. We're not in competition here at all. Toe transfers are effective, but all the toe transfer speakers have shown monoblock toes today. And Fu Chan Nai years ago went head-to-head over this, because you do mutilate the foot with a great Koan monoblock, there's no doubt about that. But all of these modalities have their place. And I think only a very small proportion of patients will be suitable for hand transplantation. But when they have a hand transplant, their function is, I'm sorry to say, I have to correct this, their function is fantastic. In selected right patients, right transplant. And comparing them in this kind of on-stage way doesn't do justice to the communities of toe transfers, communities of plasticity, communities of transplantation. It's a much more nuanced system than this. Let's have them evaluated.
Thanks. Thanks, Simon. I think one of the things I was going to say about outcomes is it's interesting having all the different measures, and we're all very skewed on that now, having patient-related outcome measures. But actually, in everybody's talk, everybody puts up videos and photos, and I think that actually gives us more of an indication. So that's only a pictorial guide. It doesn't give us a psychological side of it, but kind of you get the idea of functionality because of what they're doing. So I don't know that we've got a functional outcome measure that kind of replaces that for me. Personally, maybe that's just the way I see things. I just wanted to, David, I wonder if you could give us a little overview about the immunosuppression, because I know people are quite always would like to know about that aspect of it. You know, just for the people, if you have patients who you maybe think might benefit from being seen, but that's one of the drawbacks that you're kind of thinking is a negative thing. David could give us a bit of an overview. Just.
Sure, absolutely. I think the first thing I'd say is if you have patients that you're considering that maybe candidates for transplant, is please just reach out to us and send them to see us. Where there is no inappropriate referral as far as I can tell. We're happy to see everybody and discuss the options with them. The second point I'd make is just to catch on Professor Jones' story from the American meeting in 2016. And the concern that there's no way I'm going to take those immunosuppression drugs, it might kill me in 10 years. I think that concern has been, I think, over-egged over the early part of this experience. And we can look out beyond hand transplantation to very large populations of solid organ recipients who are on the same cocktail of drugs, often more intense regimens, and they have the disadvantage of being significantly comorbid going into their transplant procedure, whereas a lot of hand transplant patients are immunosuppressed from a position of good health. Yes, there are side effects, there are risks, but I think they are much less significant and scary than we perhaps thought at the outset of this 20 years ago. So the regimen that we use is essentially split into two phases. Induction of immunosuppression, which is delivered at the time of transplant. We use alemtuzumab, which is monoclonal antibody, also as Campath, targeted against CD52. And what that does is it deletes mature white cells, effectively, leaving behind the stem cell population from which they can recover. Other units around the world will use broader spectrum, so anti-T cell agents, essentially equivalent. The idea is to take down the active part of the immune system in the acute setting to facilitate safe transplant. We combine that with a big dose of steroid, and then on the first morning after transplant, the patient starts onto their maintenance regimen, which is a switch over to oral steroid on a rapidly tapering dose, combined with mycophenolate mofetil, which is an anti-proliferative agent, which helps with avoiding the sort of expansion into plasma cells and reactive T cell clones. And then finally, tacrolimus, which is really the mainstay. And it's a drug that has been talked about a lot in terms of its risk profile. It undoubtedly impacts renal function. We do see some level of post-transplant renal impairment in all of these patients. A large part of that is driven by afferent arteriolar vasoconstriction in the kidney, and that is correctable. So provided you're not running it at too high a dose for too long, you can actually recover some of that initial hit on kidney function, but there will be a longer-term chronic fibrotic effect from it. In our patients who have normal, healthy kidneys going in, this effect really is very modest, but we have noticed that our post-sepsis cohort, specifically those who required renal replacement therapy at the time of their septic illness, are much more susceptible. And this is something we've come to be very careful of, because they can actually look normal in terms of blood biochemistry during their workup, but the kidneys are very susceptible to the tacrolimus hit. So we now put all of the sepsis cohort patients through a nuclear medicine formal assessment of renal function before going ahead.
Okay, great, thanks. I think one of the other things is the compliance of the patients, which we assess through the psychological assessment at the beginning, that they have to take the medications. That's a commitment from them. I think that's very important to say as well.
Absolutely, and I think the year of waiting that we use is a key part of ensuring that. And I think with one or two notable exceptions, we've been very fortunate with our compliance. There haven't been great issues with it at all, I don't think.
Great, thank you. I just wanted to, did anybody else from the audience have any questions? Sorry, I hogged the whole questions myself.
Thanks very much. Just wanted to ask all the speakers to give us a flavour of what the patient journey is like when they come into hospital. How long is the operation, the length of stay, the kind of how long do they tend to have rehab for, that kind of thing? I know they're all very different, but just a rough guide. Thank you.
Dr. Nahete, do you want to start off?
Yeah. So in my hospital, when the patient comes, I don't do as even Dr. Jones, I agree with Dr. K, that we don't do any primary toe transfers. We always wait for 2 to 3 days and explain the family. In India, most of the time it is the family, the grandparents, the parents, the relatives will come and they will discuss and then they will decide. So it takes around 2 to 3 days what we do. The surgical time for a single toe transfer, I take around 4 hours. So, and patient stays in a hospital for a week. After a week, then we discharge them. We follow them up on OPD basis for rehabilitation, because if there is a very poor patient who really can't afford to come from far off place for a rehab, we many times sponsor their rehab from our side and get them functional. So for example, for the 3 toes which I did with the flap in one go, the first right hand I did it in 14.5 hours and the second one in 11 hours. So we do quite quick, and that is why we can attempt to do this toe transfers like this. And I do for the finger reconstructions. I will talk about it in mutilating hand injuries. But for us, getting a toe transferred, I think, is much easier for us, for the patient.
Okay, thank you. I think that's very important about the efficiency of time, from a patient safety point of view. And the other thing is, obviously, for toe transfers, like, they're very special. They're not like another cutaneous skin flap and things, like, it has to work because you only have that option. I think that's, so the pressure probably is higher as well, but you want to make sure the case works. Yeah. Christian, have you got anything to say about timing? Thanks.
I mean, I think, again, it's not really how fast someone does an operation. I think the most important thing is the preparation of the patient. So, I mean, again, for an acute trauma, we will give time to the patient to understand their commitment and what this entails. I mean, we have our surgical setup, and it takes us around maybe 3 hours to do a toe transfer like that. Just because we have everything, as we said, we do a lot of these and we try and get them planned in a specific way. Obviously, some cases may take longer or shorter. They stay in about a week. We support them throughout that time. We have psychological input. And then their rehabilitation, we do spend a lot of time, and we have a specialized unit, 2 physiotherapists who are very experienced, and they take them through this journey of, it can take anything up to a year, 6 months to a year of intensive training. Yeah.
Well, I cannot do a toe transfer in 3 hours. That's all I can say. I mean, some toe transfers are incredibly difficult, and they can take 6 hours, 8 hours, 10 hours, 12 hours, especially if there's a problem, and especially if you have to find, or do tendon grafts or nerve grafts.
I mean, as I said, this was not meant, the timing that we gave is not meant as a, it's done better or worse or whatever. But in our experience, and I worked with Dean when I first went to his unit many years ago, and he used to say to me, I used to tell him, no, we've done 2 or 3 toe transfers. And my colleague Alkis, he's in the audience as well, he's a senior member of our team. He brought microsurgery to Cyprus, so he's been doing it for around 35 years now. And, this is, our timing is around 2.5 to 3 hours for a toe transfer. And we can do maybe 2 or 3 in a day, just maybe because we have planned it in a specific setup. One of us will prepare the donor site, the other one will get the other, the recipient site. Of course, if there's a problem with the anastomosis or if there's any intra-op problem, then of course things will change. But roughly around 3 hours is common for us.
Dr. Nahdi, yeah.
Whenever I'm doing a primary toe transfer, maybe 2 to 3 days later, in a trauma patient, it is much easier because the structures are in place, you have done a good debridement, and it is very easy to dissect. However, when we do it secondarily after the flap cover, then we have to delicately dissect all the structures, so it takes around 6 to 8 hours also. So all the secondary patients, we take longer time than the primary surgery.
Yeah, I think one of the things is, toe transfer, that's just a very generic term. That can be just a very distal transfer. It can be something quite complex that needs quite a lot of other input in the recipient hand and things like that. So I think overall what we're saying is, in expert hands, it can be done very efficiently, but, that's why we've got the...
Can I just add something as well? Because we use, as Professor was saying in his talk, skin grafts over the pedicle to have no tension, and that's something that we often do. Yeah. The other thing as well is that in the last year, we have been shortening our pedicle, the arterial inflow. And I was interested because you were saying, Professor, about the plantar vessels, that they are bigger but shorter. And we have had good results in going right onto the proximal digital artery. We always leave a long vein stem because that's usually where the problem is. It's not usually the artery that is the issue.
Okay, thank you. Simon, did you want to say something?
Can I have a quick word about that?
Yeah, go for it. Yeah.
Do you mind?
Yeah.
I just want to say that I know most of my toe transfer experiences in children, but I compare whether I use the dorsal or the plantar system. And the plantar system can be dissected right back to the dorsalis pedis artery. It always connects. So you get the sesamoid sink with a great curve, and you can dissect it back. So we don't do any imaging or Doppler or anything beforehand. We explore it from distal to proximal, and we go whichever way is bigger. And you can get all the pedicle. The other thing about the distal toe transfer, I say to Christian, is that for the very pulp and so on, we exteriorize it. So we don't put the little pedicle down the barrel of the finger. We put it across the outside and divide it into 2 weeks. Of course, you can't do a big part, but if it's a pulp or a nail, very nice little technique.
Sounds good, thank you.
Yeah. Okay, I think we might wind it up there now. We've had a very good session. Thanks so much to the speakers. It's been really good, and thanks for joining in the discussion, and thanks to the audience for listening. Thank you.
A nice full lecture theatre. I think we've had some, I think we've got about 380 registrants for this meeting, which is a bit of a record, I think. So thank you very much indeed for all coming. So a good and warm welcome to you, especially our friends from India. Namaste. You'll note the hands of friendship on the bottom right. They were painted by the sister of Pankaj Ahire. Pankaj is a friend and a wonderful hand surgeon from Mumbai who couldn't unfortunately make it this week. And we've had some really amazing artwork for this conference. When the programs eventually come this morning, you'll see that the artwork on the front is painted by James Henderson, a similar picture of friendship and handshaking. And the picture on the right was painted by Vigneshwaran, and it illustrates Adi Mudra, which is the first gesture or primordial mudra, which is a baby's first hand gesture. It indicates calmness and stability of mind, which I really hope we will have over the next 2 days. The history of BSSH and ISSH is intertwined. Guy Pulvertaft attended the first ISSH meeting in 1973, and UK and Indian and hand surgeons have often visited each other to train, to teach, and to learn. I think a major milestone was the setting up of the Bruce Bailey Fellowship by Raja Sapapathy with support from David Elliott. And over 150 UK trainees now have been enriched by visits to the Ganga Hospital, and many friendships have been formed and flourished as a result. We regularly swap guest speakers at our meetings, and in 2008 we held a combined meeting in Bangalore, and in 2021 we were honoured to be guest society at the Indian Society Conference, albeit only virtually during the COVID pandemic. And a young Indian surgeon, Dr. Vigneshwaran, who painted the Adi Mudra, was due to become one of the first BSSH International Travelling Fellows, but this was postponed due to COVID. But that was to our benefit in Swansea. He was able to travel as one of our IFSSH hand fellows last year, and I had the great picture of hosting Vignesh in Swansea. Like many of the Indian hand surgeons that I've met, he was a credit to the specialty, extremely humble, highly knowledgeable, and brilliant at what he does, usually under far more challenging circumstances than we face in the UK. And you can see here he's a very polite man. He's very tactfully bending his knees here for his photo of me in Ganga Hospital earlier this year. I'm tall for Wales, honestly. Our friendships as societies was very much cemented last year in Jaipur. Jonathan was president, and I know he was really looking forward to going to Jaipur, but he came across a formidable adversary, and that was the Indian visa application process at the time. Due to a dispute between Boris and the Indian government, it was almost impossible to get a visa. So all these colleagues, including John, were unable to travel, leaving a smaller delegation, including myself, to carry the BSSH banner in India. And we were given a fantastic welcome by everyone that we met. But despite my enthusiasm, I couldn't really get the hang of the dancing, but as you can see, I gave it a good go. Apart from the welcome, what struck me about India was the amazing depth of colours wherever you looked and wherever you went. And these are all photographs that I took. And like Scotland, they have their own pipers. But I doubt tonight's Highland pipers could charm a king cobra in the way this guy does. That's a pretty mean-looking snake. So finally, what I want to say, Santosh, as president of ISSH, is welcome to you and the ISSH. Thank you for travelling so far. We're truly honoured by your presence. We're looking forward to learning lots and forging new friendships and alliances. And to commemorate your visit, we have a small gift from our society for yours. I don't know if you'd like to come up and receive it. It's an engraved Scottish communal whiskey cup. I'm told it's called a ceich. I think you have to be Scottish or Welsh to be able to say it. But I hope we get the opportunity to use it.
I just do my slides?
Yeah, I think it'll be on. Could we have the main slides now back, please? I'll take that.
Yeah. As we wait for the slides, can I request Dr. Anil Bhatt, Secretary ISSH, to come and get the the Golden Jubilee medallion as a present to President of the British Hand Society. So we celebrated our Golden Jubilee, and this was the medallion that we have given to our past presidents. And this is a great honor to present this to the President of the British Hand Society. Let me thank President BSSH and members of British Hand Society to invite the Indian Society of Surgery Hand to visit, to participate with the autumn meeting. It is a great honor for the Society as we celebrate our Golden Jubilee. As Dean has mentioned, that the beginnings were our, this was 1973. As a part of our Golden Jubilee celebration, we were looking at our history and trying to collect the photographs as a historical documentation for the Society. And this was in 1973 that we had our first meeting. And the friendship between Dr. Pulvertaft and Dr. B.B. Joshi was the foundation of the Society, and lots of exchanges, lots of community, members going to India. And from 73 onwards, that the Society has had 46 annual conferences. And I fondly remember during my fellowship time with Dr. B.B. Joshi how fondly he used to talk about Guy Pulvertaft and all the various hand surgeons who to visit MGM Hospital in Mumbai and discuss how best to deal with hand injuries. In 1973, there was hardly anything available in terms of surgical facilities in the industrial hospital, no access to splint. But from both sides, from the Indian side and from the British, it was an amazing collaboration that propelled hand surgery in India. And this is some of the archived photographs we're very happy to retrieve for the Golden Jubilee celebration, which we showed to our colleagues. We've had 4 combined meetings. The first, 73. 1990, those of you who had been to Goa. Anybody who remembers Goa? No, I think, yes? No, I don't see. And Professor Lard, who was the secretary then, remembered the participation and the fun everybody had in Goa in 1990. And of course, Dean's shown you the pictures of Jaipur, which was after the COVID pandemic, and we're sorry to miss quite a lot of people who couldn't travel. But those who did, I'm sure you can recognize some of these faces here. And the moves to Bhangra, which was part of the evening entertainment. So Dean, you did very well. You know, this is something which we have as fond memories of all of you, including your spouses, that we had an excellent time, and we talk about the friendship and fellowship that has always been there as part of our combined meetings. And Mark Pickford was the last B.B. Joshi orator. So we've had innumerable number of orators from the UK for our R.V. Venkateswamy oration and B.B. Joshi orations. And that's been a forum of continuity in terms of exchange of current practices. And this is some of the figures that we have, is that we've had nearly about 170 trainees from the UK visiting Ganga. We don't have figures from the other hospitals. But we know that most of us have come to train in the UK. So our principles of care, our principles of hand surgery, the entire population, our entire cohort of current hand surgeons, those who are in mid-career, they still come to the UK for training. So the exchange has been very useful in terms of the care systems in the UK and in India. And we are very fortunate that we touched 50 years of the Society. And it was a great time to recollect what we've achieved, get all our past presidents, pay them respect for all they have contributed to the society. And it was great that everybody, all the living past presidents, arrived, enjoyed the ceremony, and gave their memories of how the society has formed. However, what we know, we've got over 800 members in the society. More than half of them are active, and more than half of them are very young. So the future of Indian hand society is in very competent hands. But when we talk in terms of where is hand surgery available, it still is limited to the Class 1 and Class 2 cities. It's not going down into the district level. And as we stop at 50 years, think where do we go for the next 25 years, it becomes obvious that the challenges for us is not about surgical techniques or the expertise which we are at par with across the world. There are so many hospitals, especially in the private sector, are providing excellent quality of care. But the present problem is accessing the huge numbers of people who actually have hand injuries at the district and the sub-district hospital. And and people who are treating it, they are not hand surgeons, although we have about 20 formal training positions for hand surgery, 3 years programs, and we hope that these trained people will start new hand units across the country. But the numbers just don't tally. We don't know at what point can we provide a proper hand surgical service to the districts. Much of what is provided is by general surgeons, plastic surgeons, orthopedic surgeons who do not have foundation knowledge of hand care. So our aim is to see how do we proceed over the next 25 years and meet the current generation of younger hand surgeons. It's not the problem of that they need further education in new techniques, because these are conferences we pick up, we go and practice wherever the facilities are. But the major is how do we take it down and with the limited training opportunities. The initiative that we have taken in the ISSH executive is to take a cohort of mid-career surgeons and train them to become leaders for the next coming decades. And this was our first program. We took 12 mid-career professions, hand surgeons, certified, practicing hand surgeons, to give them the skills of education, soft skills, but also for them to become leaders, support them in research capacity building, in looking into how they themselves, in the place of practice, they can influence the services of, say, a few million of people around. So our trajectory of the senior members of the executive is that we're thinking how do we reach for essential hand surgery care to people at the district level? And how do this cohort of 12, and we're going to be doing that for the next 5 years. We've got funding for 3. So by the end of 5 years, we're going to have about 50, 60 very strong leaders within the Indian Hand Society that will lead the future, the provision of care in India. And this is the first group of enthusiastic, they are practicing surgeons, came there for an entire day for education, and they are so enthused. And we hope the future lies in improving access to essential quality of hand surgery care in India. And the way to do is learning from others. How have you done it? Innovations, not only in techniques, but how do you deliver quality hand surgery, essentially at the level of districts level and below? Collaboration is the only way we take from experience from developing countries, the UK. You have your own problems, but then how do you overcome? How do we reduce the waiting list? You've got the problem waiting list here. We have the problem of people not having access to care. So they come late. They need more procedures. Their results aren't very good. But at the end of the day, it's learning and knowledge dissemination is the way forward. And we look forward to these meetings across with our friends, those who have held our hands for the last 50 years. And we look forward to this collaboration from the UK surgeons, from the UK, the British Hand Society, to continue meet in each other's territories at least once in 5 years, exchange ideas, but the focus being how do we reach people who need hand surgical care at the time of the injuries, specifically injuries, in that the district levels or in the industrial hospitals. Thank you for inviting the Indian Hand Society to participate. This is the first one, and we look forward to the future invitations. Thank you.
Thank you, Santosh. Some of the most highly skilled technical surgery I've seen in my career has been in India, but as you say, the challenge is getting it out into where the people need it, really need it. So yeah, it's a difficult challenge. So now we split up. In this room, we'll be carrying on with a session on value-based hand surgery, and in the other lecture theatre, there is a session on randomized trials, the NHIR studies that are happening nationally for an update. So make your choices.
Could we have the first slide, please? I think we'll start. We've got a very packed session between now and lunch, and we're very keen that there is an opportunity for some questions at the end. So we will crack on if we may. If the trialists could leave quietly, that would be very good. So a very warm welcome to you. I'm Hamish Lane. It's a great pleasure to be co-chairing this session with my colleague, Jeremy Rodriguez. And we have a number of speakers talking to you about the subject of value-based healthcare and value-based hand surgery, including colleagues from abroad. And it's a bit multimedia. We have somebody dialing in, we have some pre-recorded, and some in-person presentations. So we will start. So it is striking from the program for this meeting and from the abstracts that there is, and indeed the discussions that already happened in this room this morning, that value-based healthcare is something that is on the minds of many of you. But we thought it was just worth just setting the context at the beginning of the session for those of you who are less familiar with it. Why do we need a value-based approach in hand surgery and in healthcare in general? Well, you will know that there is a growing demand for healthcare, and there are finite resources. And in a way, it doesn't matter what those resources are, there is an edge to them. And we have to try and get the best value from whatever resources we have, be that in a low-resource country or in the UK, where we're struggling with shortages of staff, and we feel like we're struggling with a shortage of money. The current system is clearly unsustainable. And that is not just true in the UK, that's a phenomenon that's seen very widely. And it is restricting access to good care, and it's restricting access to innovation. And certainly in the UK, those of us who've worked in the NHS for many years will know there is a relentless focus on cost improvement, trying to go for the cheapest option, driving down cost, without any system focus at all, really, on the outcomes. Of course, as clinicians, you are doing your very best to measure outcomes, and we've seen examples of that again in the amputation and transplant session this morning. But the NHS measures two outcomes. Did you die, and did you have to go back into hospital within 30 days of someone doing something to you? Those are the only outcome measures the system is measuring, which would suggest that that is the focus of the government and managers. And we know that health systems carry out many activities that add little or no value to patients. And if we could only stop those and release the resource from those, we could invest those in the things that are of high value. Striking again in one of the abstracts for this meeting, you know, the variability of patients about having nerve conduction studies or trials of conservative management in carpal tunnel syndrome, for example. So value was described by Michael Porter and Elizabeth Teisberg in the States, of course, this is a standard economic definition of outcome over cost, but they tweaked it to suit the healthcare setting. And they said it's the outcomes that matter most to the patient or the person receiving care, divided by the cost of the pathway of care that resulted in those outcomes. So we're not just talking here about clinical outcomes, total range of movement, many of the outcome measures that have been presented in this meeting so far, but we're also talking about patient-reported outcomes. As many of you will know, Jeremy has done a lot of work on this, but again, already in the early session, focus on different types of measuring what matters to the patient. So I would suggest to you that patients in general are, of course, interested in clinical outcomes. They want to know if their replant works. They want to know if they have an infected wound. They care about that. But they care about a whole range of other things, about being able to do the things they want to do with their operated hand. And, of course, technical efficiency or technical value is important as well. In Europe, we've taken the Porter model and identified 4 types of value. Personal value, that's the outcomes divided by cost. Technical value is efficiency. Allocative value is, well, where are we putting the money and the resources, the people? Are we putting it in the right place to get best value from a pathway of care? And then what's the wider impact of illness and therefore treatment on society? People not requiring benefits, people paying tax, being productive, and so on. This is not just a Welsh or a UK phenomenon. This is an increasingly global approach. These are just a small number to show you the countries that have their own value-based healthcare strategies, and it's now pretty global. So we didn't want to make this a session about the theory. The theory is what it is. We wanted to give you an opportunity to think about ways you could put this into practice in your own hand surgery practice. And so the rest of the session is devoted to examples of using it in practice with a particular focus around a common procedure, carpal tunnel release, to look at different elements of value in that and how we can increase the value for patients and the system from that. So with that, I'm going to invite our first speaker, Professor Brigitte van Geeten. She's a plastic surgeon in the Netherlands. She's the Secretary General of FESH, and she's kindly going to talk to us about PROMS and hand surgery. So Brigitte.
Yeah, I want.
You're looking for the notes there.
Okay, thank you, Chair, organization, the British Society. I'm very honest to get the invitation and to tell something about value-based healthcare. The next speakers probably will talk about carpal tunnel syndrome. I will have a more general talk, and it's actually based on the article of Reinier Feits. Maybe you know him. He is the inventor of the expert clinics in the Netherlands and of the HandRisk group. Furthermore, I have nothing to disclose. Okay, value-based healthcare, as already said, will become more and more important in the near future and also in hand surgery. And for instance, currently in the Dutch government, they have introduced or instructed the healthcare authority to allocate the limited capacity solely to value-based healthcare. So other care will no longer be insured. But from multiple perspectives, it's worthwhile to invest in value-based healthcare, which I will explain in this presentation. And a way to implement value-based healthcare is the uses of PROMS, already told. It's patient-reported outcome measurements. And of course, this is a lot of work, so why bother? I hope I can explain. Wonder. Don't we all want to get the best out of ourselves and reach the highest level possible? And don't we want to spend a lot of time to exercise and feel fit and challenge ourselves, improve our results and push our limits? preferable with a very nice personal trainer. And we use all kinds of methods to measure the results. So why shouldn't we strive for the same at work? Improve patient care by an ongoing learning curve and outcome measurements. So value-based healthcare is becoming more and more important to improve both patient care, manage the limit capacity wisely, and reduce costs for healthcare and society. And to be able to do this, we actually have to answer two questions. Are we doing the right thing? And are we doing it right? One way to find those answers is by performing patient-reported outcomes measurements, or PROMs, and these are validated questionnaires especially designed to measure healthcare outcomes based on the patient's perspective. But how can we achieve this? It's important to implement routine outcome monitoring in daily care. So each patient is asked to fill in questionnaire at the first consultation and at fixed moments after treatment. And in this way, baseline and follow-up data are gathered prospectively. Besides PROMs, other outcomes can be measured, like pain, hand function, return to work, but also complications and reoperations. And of course, informed consent must be asked to use the data for research and education purposes besides for healthcare. So to have really impact on healthcare, it's important to implement the routine outcome measurement in a PDCA cyclus. So the plan is to perform value-based healthcare, and therefore we measure PROMs, among others. Subsequently, these data must be analyzed and interpreted, and this provides information that can be used for patient counseling, education and research, which in turn leads to new ideas and improvement of value-based healthcare. By closing the feedback loop, in the end, this might result in improvement of patient care, the health providers itself, and the clinical practice. Patient care can be improved by directly returning the data to the patient during patient consultation. For instance, graphs can be shown to show the average outcome and variation in results of a certain treatment, but also that results can depend on baseline scores, so expectations of patients can be managed. Also, the progression of outcome and return to work in the weeks following treatment can be shown. Shared decision-making can be based on showing these results. The outcome data can also be used to educate the surgeon. Results per surgery and per healthcare provider can be shown. Journal clubs can be based on literature combined with outcome data of provided patient care. And last but not least, research can be performed of which results can be published. Publication of outcome data serves many purposes: to increase knowledge of hand community, to compare healthcare outcomes of different treatments and clinics, but also to gain recognition of hand surgery, which is very important, and to convince authorities of the value of hand surgery. Like everywhere, the adagio is publish or perish. So, in conclusion, with PROMs we can really make a difference and perform value-based healthcare and improve not only the patient care, but also the professional and organization. But it is really important to realize that outcome measurements are an instrument and not an end goal in themselves. Outcome measurements must be performed on a routine basis and as part of the feedback loop. And it's very important to realize that patient-reported data are given by the patients and should be returned to the patients. Thank you for your attention.
Thank you very much, Bridget. And between Hamish and Bridget, we've got an overview of what we're talking about with value-based healthcare. But what we wanted this session to be about is to be applicable to real-world practice. So what we want to walk through is some ideas about how we deliver carpal tunnel syndrome pathways. So let's split it into three parts: before, during, and after surgery. So how many people here, as a routine, would say you probably have got to see a carpal tunnel syndrome patient before the day you are going to operate on them? Just be curious to see. So that may be perfectly reasonable. We'll maybe look at that and see if there are other ways to challenge ourselves about that. Who's doing most of their carpal tunnel releases in a main operating theatre, fully staffed with ventilation and so on? We'll look at this. And who is routinely seeing carpal tunnel release patients back face-to-face after surgery at some point? Okay, good. I was worried there'd be no hands up, and then we maybe all go for lunch, because it will kind of be over. But we've got a couple of talks. It may not be that what comes up is going to be acceptable, and I want you to think about whether what is proposed is going to improve or maintain outcome and maintain or reduce cost, because that's what we're talking about. So we've got a pre-recorded talk from one of the trainees who's done some work around this.
So good morning, everyone. Thank you for the opportunity to present, and apologies for not being able to attend in person. My name is Luke Gagan. I'm an academic clinical fellow based at Imperial College and a plastic surgery registrar at QVH in East Grinstead. Today I'm going to be sharing the results of previous work conducted at University of Oxford in conjunction with NHS Fife, which aimed to determine whether it's possible to predict who needs a carpal tunnel release without physically seeing them. So carpal tunnel decompression is a very common operation. In the UK, 1 in 1,000 people will undergo carpal tunnel decompression each year at a cost of around £50 million. This is in the hope that they will experience an improvement in either sensory or motor symptoms. Carpal tunnel decompression is generally considered safe and effective, although 25% of patients don't experience a meaningful improvement and around 8% actually feel worse following surgery. Identifying who will benefit has obvious implications at the patient and societal level. This is particularly relevant given the fact that carpal tunnel decompression has been dubbed a procedure of limited clinical value by NHS England. Our study aimed to develop a range of machine learning algorithms and determine whether they can predict which patients will report a meaningful improvement in symptoms and/or function following carpal tunnel decompression. We also wanted to understand how these algorithms make predictions. Using this information, we then aim to develop decision trees that can be immediately implemented in clinical practice. We developed a range of algorithms using a regional database of around 2,000 patients who underwent carpal tunnel decompression at a regional hand centre in Scotland. Our dataset contains 61 predictors, including demographic factors, comorbidities, quick-dash item response scores, and EQ5D5L scores. All patients underwent open decompression. Surgery was performed in patients with neurophysiological evidence of carpal tunnel syndrome, or in those with clinical features that had not improved following non-operative management. Improvement in symptoms and function was defined using quick-dash response scores. Previous work from our group has demonstrated that the quick-dash has a two-factor solution. This means that items 1 through 6 measure the same underlying construct. We've labelled this hand function, whereas items 9 to 11 measure a different underlying construct, and we've labelled this symptoms. Patients were said to have improved function or symptoms if their quick-dash score was greater than the minimally important change score. We define the minimally important change as half a standard deviation of their baseline score. We developed 5 machine learning models of increasing complexity. Here we can see the receiver-operator characteristic curves for each model, which demonstrate both the sensitivity, i.e. how good the model is at identifying people who improve following decompression, and also the specificity, or how good the model is at identifying people who did not improve following decompression. The graph on the left demonstrates model performance in predicting sensory improvement, and the graph on the right demonstrates model performance in predicting function. Our best performing model could predict who would get sensory improvements in 77% of patients, and it could also predict who would get functional improvements in around 72% of patients. Now, these results demonstrate that computer algorithms can accurately predict who will have improved symptoms and/or function following carpal tunnel decompression. And on the surface, this sounds fantastic. We can rely on these algorithms to identify suitable candidates for surgery from simply primary care referrals, meaning that patients do not need to wait to be seen preoperatively in clinic. Now, this is very wishful thinking, and we're not quite at this point yet. Our algorithms use 61 predictors which may not routinely be available for all patients treated within the NHS, and the IT infrastructure of the NHS may not be able to support immediate application of our algorithms in clinic. Now, to address these problems, we sought to understand how our algorithms are making these predictions and simplify this right down into easily interpretable flowcharts. We did this by performing CHIDE analysis, and CHIDE stands for Chi-square Automatic Interaction Detection. This type of analysis enables us to produce these flowcharts. These do look quite difficult to interpret, but they're relatively simple to navigate once you break them down. Each of these grey circles represents a question within a patient-reported outcome measure. So this one here, dash 11, this is the question within the quick dash, which looks at whether or not a patient has pain in their hand when they're sleeping. Each of the lines coming out of this node represent the different response levels for that question. So, very little pain when sleeping up to severe difficulty sleeping because of pain. What we can also do is add in further nodes, i.e. the responses to different patient-reported outcome measured questions. So this one here, EQ5D VAS, this is the visual analog scale that comes with the EQ5D and looks at someone's overall or general health and well-being. And you can see here, coming out of this node, you've got people who generally have suboptimal health, those with an EQ5D VAS score of less than 90, or those with otherwise good health, those with an EQ5D VAS of greater than or equal to 90. And at the bottom, you can see the percentage chance of improvement following carpal tunnel decompression. So let's break this down and navigate this right-hand side of the flowchart. Now here we can see that a patient with severe pain when sleeping, so someone that responds quite poorly to quick dash item number 11, who is otherwise in good health, indicated by an EQ5D visual analog scale score of greater than 90, has got a 93% chance of symptom improvement following carpal tunnel decompression. And this is very intuitive. If someone has got classical features of carpal tunnel syndrome and is otherwise in relatively good health and doesn't have any other potential reason for getting pain in their hand at night, it is likely that they're going to improve following carpal tunnel decompression. Now, this is a very simple flowchart that can be put up in clinic to counsel patients and make data-driven, patient-centered management decisions. Now, our findings have been published in PRS Global Open, and if you are at all interested, I'd encourage you to go away and have a read of the full paper. So in summary, we have developed algorithms that can predict clinically meaningful improvement in either hand function or symptoms following carpal tunnel decompression. We can accurately predict who will benefit from a carpal tunnel decompression without physically seeing patients in clinic. However, a number of barriers preclude implementation of our algorithms in the NHS. To address these, we've developed a heuristic decision support tool that can be readily implemented in clinical practice to identify patients who are likely or unlikely to benefit from carpal tunnel decompression using only 2 preoperative questionnaires. Combining contemporary psychometrics and machine learning in clinical decision support tools can support the delivery of patient-centered and value-based healthcare through a data-driven approach. Our algorithms can be used for expectation management and also to rationalise treatment risks and costs associated with carpal tunnel decompression. Thank you very much.
Fantastic to see an opportunity to identify the 32% of patients we heard in the first paper who get no benefit from this surgery. And we described the value equation as being the outcomes divided by the cost. So what is it costing to do these procedures. So I'm very pleased to ask Natalie Blesley-Redgrave, Registrar in my old unit in the Welsh Centre for Bones and Plastic Surgery, to talk a little bit about some costing work that's been done in Wales.
Morning. So as a bit of a recap for those of you that weren't in Swansea with us earlier in the year, we talked in the last value-based healthcare session about these procedures that the BSSH has outlined as potential procedures that might be suitable for operating outside of the traditional operating environment, and that may help us to reduce the costs associated with these procedures. So these are those procedures that have been identified as potentially not needing the full main theatre ventilation that we're used to, and carpal tunnel comes as the top front runner in that category. So with our colleagues in the Welsh Value Centre and NHS Executive, we've built the Welsh Hand Surgery Dashboard, which we can interrogate to try and get a bit more information about what's happening at the moment in Wales and what the costs associated are. So these BSSH procedures currently represent around 40% of all the procedures in the Welsh Hand Surgery Dashboard, which is up to about almost 27,000 cases at the time of interrogation. And this represents about 56% of elective episodes and 48% of all day case procedures. So it's a huge proportion of our hand surgery that potentially could move outside of the traditional environment. In a year pre-COVID, we were at about 6,500 cases of these types of procedures, and carpal tunnel is the front runner, massive category there. So this is across all the Welsh health boards. The dark blue proportion is the proportion of those BSSH procedures that are made up by carpal tunnel. So it's a significant portion of the work that we're doing. So how much does it currently cost in Wales? Well, patient level information and costing systems analysis has shown that in pre-COVID era, 2019-2020, the average cost of a procedure was between 780 and 1,500 roughly across the different Welsh health boards. And by 2021, 2022, so post-COVID, that significantly increased, almost doubled to up to £3,000 per procedure for just a carpal tunnel. And what this shows is that costs are variable across Wales, but also that costs are increasing significantly over time. And since we're doing so many carpal tunnels, this is something that we can potentially make a big difference with. This is true across all the different BSSH procedures, and the average costs, again, increasing over time quite significantly. Now, these numbers have been generated by quite high-level analysis, accounting for both the direct and indirect medical staffing, equipment, etc., used for the procedures, but also the corporate overheads, the facilities, and the big-scale stuff. So it's not necessarily things that we can impact ourselves on a departmental level necessarily. So we've delved a bit further into carpal tunnel with a time-driven activity-based costing exercise, mapping out the sort of standard main theatre pathway for a carpal tunnel versus what we believe would be the case in a procedure room setting. And through kind of mapping out every person that's involved in every procedure and all the costings for equipment, etc., we've come to these numbers. So the total cost of a single procedure in theatre, once we've taken out those corporate overheads, is around £300, and that can be reduced to around £140 per procedure in the procedure room setting. And a significant proportion of that is the time released. This is not theatre time, this is person hours. So by reducing the number of scrub nurses, the number of theatre runners, anaesthetists, etc., we can save a significant amount of time that can be assigned elsewhere. So on a case-by-case basis, carpal tunnel, as we've said, in a treatment room, £140, in theatre, £300. And that can be seen across all of the BSSH procedures, approximately double, sometimes more than that, to be done in a theatre setting. And significant time saving for people. We can allocate so many personnel to other tasks, and the people in the NHS are one of the key costs. So what if we scale that up a bit across Swansea Bay, so that's our health board, all carpal tunnel surgeries in 2018-19, so a pre-COVID year, we did 607 procedures. If we moved all of those based on this analysis, from a treatment room to theatre, the cost saving would be nearly £100,000, and we'd save over 2,000 person hours of time. If you then scale this up to the other procedures, we are looking at a cost saving of £250,000 and almost 6,000 hours of person time available to be reassigned elsewhere, still getting all those cases done. If we look at a post-COVID year, we all know that the efficiency has dropped post-COVID. The numbers are still big, although be it not as big, 162,000 and 3,700 hours. So what if we scale that up even further and look at the whole of Wales? Well, pre-COVID, that would have been looking at over £1 million saving in a year just on moving these procedures into treatment room settings, and over 26,000 hours of person time released. Post-COVID, again, the numbers are smaller, but still very significant, over £700,000 released. So, summarising that again, for just carpal tunnel surgery alone, we would be saving at least £70,000 in our health board and £350,000 across Wales. There are limitations to this. This is not assessing variations in practice. This is one surgeon's mapped out pathway. And so we do need to do further work to really formally map this out before this could be achieved, but the sorts of numbers that we're talking about have to be significant. And we've only done this for those limited BSSH procedures that have been provided, and there's certainly a huge number of simple emergency hand surgeries, for example, that could also be in this category. Theatre time saved is also very significant. We're all fighting for theatre space, and the hours that we can release in main theatres can be used for other plastic and orthopaedic surgeries, but also just for other, cancer surgeries that are being delayed. So we're releasing a huge number of person hours, but if you take a carpal tunnel taking 20 minutes, not accounting for transition times between cases, we would release between 95 and 150 standard all-day 8-hour operating lists simply by moving carpal tunnel alone into a treatment room setting. So definitely the benefits can be seen for patients who will likely get done sooner, but also for the health board with these significant time and cost savings. As I said, this is only one pathway that we've mapped out based on one consultant's preferences, and there's likely to be variation across the health boards, and these numbers don't take into account those capital resources required for establishing a treatment room and the infrastructure change required. But once that's done, we can see that the cost improvements will be significant. So we're going to take this forward, explore in more depth the variation in costs between the health boards specifically and what would be required to make this procedure room happen, and analyse the detailed costings of this in each environment. But we think that this is the way forward. Thank you.
These kind of data are just so powerful, and you may have your own perspectives, and you can begin to frame how conversations might go or your perspective on the matter, but having a resource like this to bring forward and discuss is so important. But at this point, what we were hoping to do is just spend a couple of minutes just pausing, zooming out, and looking with a little bit of the mechanics of how these kind of costs come together. I mean, that's such a brilliant data set. Where do you get these kind of cost numbers?
Thanks very much, Jeremy. And I guess just two very obvious points from Natalie's presentation. The first is if you can halve the cost and get the same outcomes, you've doubled the value. And the second is the variability in the costs between different organisations in Wales. So nearly double, 100% difference in cost at the baseline. And so there's some unwarranted variation in there, almost certainly. And if we could get rid of that, we would also increase value. Could we have the slides, please? To give a talk about costing in the NHS in 5 minutes is not possible, and it's even harder without the slides. But I was just going to give some really key principles about this. So I'll just wait for my slides to come. If not, I'll do it without it. It's a man putting his head... great, thank you. Really just some really high-level principles in 3 or 4 minutes. Actually, it's not about the money. We tend to focus on the money. And it is important just in passing to distinguish between cash releasing and cost avoidance. You don't necessarily get the money out, but you can get the time out. It's really about resources, be they natural resources, man-made resources, human people resources, and they're always going to be finite. And so the value is about making decisions. To get higher value, we have to make better decisions about how we use the resources we have. And Natalie gave a very nice example of that. And in healthcare terms, that can be people, staff, it can be medicines, devices, equipment, surgical equipment, and so on, and the premises, as you heard. In order to be able to understand the resource use of different activities and compare them, for example, using an operating theatre to using a treatment room, you need to have a common currency. And so what finance colleagues do is they use cost as the common currency across pathways, services, and organizations. But what they're really interested in is not the cost, it's the resources behind that cost. And I think that's important to keep in mind. The second question before you launch out on the sort of costing work that we've done is to understand why you're doing it. Perhaps you want to look at different pathways, for example, pathway in Health Board A compared to Health Board B, or between two surgeons. You want to compare alternative treatments, in this case, the setting of treatment, but you might have a number of different ways of doing it. Endoscopic carpal tunnel, I don't know if that's still a thing, compared to open decompression. Or you maybe want to be introducing a new pathway or a new option, and you want to understand the relative value of that. It's important to know why you're trying to do it. And you can do costing at two levels. You can do it at what's called program level. So a program in health services terms is something like musculoskeletal conditions, women and child, mental health, trauma. These are called programs. And in the NHS, finance colleagues do program budgeting. So they can tell you what percentage of the budget in the NHS in England is spent on mental health. Answer, it's the highest of all the programs, interestingly. And then you can do a thing called marginal analysis on that. So you can look at, should we be allocating more resources to mental health or to musculoskeletal conditions to improve the population health? So you can use it for that. But you're probably more interested, normally you're going to be interested in looking at a pathway of care level. And there are essentially three options here. There are a lot of off-the-shelf costs. Finance colleagues tend to keep those to themselves, but there are things called reference costs. These are standard ways that are reported into our respective governments every year in a standardized way of what things cost. And there are some assumptions in there, but actually they're quite detailed. So you might want to start by looking for the reference costs, the cost of a minute in an operating theatre, the cost of an outpatient appointment. These are things that have reference costs. You don't need to do anything special, you just need to get someone to give you those data. Or you can do what was done here, which is a detailed a program using a thing called TDABC, time-driven activity-based costing. And that is literally someone with a stopwatch going, well, on average, it takes 7 minutes of somebody of that grade to do that thing, and that has a cost. But it is quite resource intensive, so before you do that, you need to really understand if you need to do it. Do you need that level of detail? More commonly, people do a hybrid, so they use the reference costs for the outpatient appointment, but they might do TDABC for the procedure to really get the detail. So that's just, again, another principle. If you're interested in all of this, and it is actually quite interesting, there are two sources you might want to look at. The HFMA, Health Finance Managers Association, that's the thing that all the finance colleagues in healthcare in the UK belong to. They have a Costing for Value Institute, and they have a lot of resources on their website openly available, which may be of interest. And then if you're really interested in TDABC, there is a global consortium. Their meetings must be fascinating. And they also have a great website with quite a lot of resources, and they've published very widely, so there are some peer-reviewed papers there as well. So that's just a very quick overview of the principles of costing, but obviously there's a lot more to it. Thanks very much. And I'm now going to ask, no, don't need to applaud, I'm now going to ask Jeremy, who's going to answer the question, or help us answer the question, can we reduce costs for carpal tunnel release?
So, can we reduce the cost of carpal tunnel release? Here's a photo of Ryan Trickett, a resourceful and innovative orthopedic surgeon who has reduced the cost of carpal tunnel release by stealing the loops that you can see here from a plastic surgeon. But the core of all this is about outcomes and costs, as you've probably gleaned. Natalie's data are really fantastic about where our kind of costs are driven from and how we might end up reducing them. It's about how many bodies are in theatre and what kind of theatre you're using. But, as Hamish has alluded to, we've got to also make sure that we at least maintain, if not improve, the outcome you're delivering. If the outcome is disintegrating as the cost is reduced, then the equation stays at best at parity. So we did a lot of work trying to understand, if you make these kind of changes, can you increase efficiency and reduce costs, but without decimating your clinical outcomes? So the kind of thing that I'm going to just highlight as an example is we might be worried about the risk of an infection if you're doing a carpal tunnel release in a non-main theatre, perhaps without even formal air exchange, let alone without formal laminar flow. We've looked at the existing literature, pulled out 171 studies that looked at theatre locations, particularly around hand trauma, subgrouped that into operations performed in and out of main theatre settings and broke all that down. And this is where the devil's in the detail, because what is air exchange in a theatre? This varies whether you're in North America, where air exchange is at a higher frequency than in Europe. And then actually, whatever the publish rate is, we talked to some of the hospital engineers, it's never quite like that. If you actually sit and physically capture how much air exchange is going on, it is varying wildly throughout a single day, let alone across weeks or months. But we cannot identify any increased risk of infection in hand trauma performed out with main hospital theatres. Similarly, we've looked at the data around staffing and worked collaboratively with teams that have lower numbers of staff running and scrubbed, and identified whether they have any incidental increase in complications, and this does not seem to be the case. So the best available evidence we have seems to suggest that your outcomes are going to be maintained, but your costs are going to drop. So Natalie's data is sitting at a denominator of a maintained outcome and a better overall value equation. But I put this in as a graphical sort of allusion to a Gantt chart. This is where you might stack theatre cases one after another and actually analyse that. At the beginning we said, would you do your carpal tunnel releases in a main theatre? And while stacking a whole list of them like that may be expensive, you can also look for no added value time. If your main theatre list has a small gap when you map your cases, then slotting in a carpal tunnel release in what would otherwise be wasted time might be additional value. So what's important here is that we don't make sweeping wholesale changes, we work smarter, not necessarily harder. So it might be an all-day carpal tunnel release list in your minor ops theatre, and then some heavier cases with the block time or whatever's going on filled with the odd carpal tunnel release squeezed in between to maximize your use of both main and minor theatres. So I challenge you to think about where you're operating, when you're operating, and who's around in theatre when you're doing that. Thanks very much.
Thank you very much indeed. So we're now going to hear, I hope, from a colleague of mine, Professor Gregory Katz, in Paris. So I'm looking at the back in the hope that... good afternoon, Gregory. You can hear us?
Yes, I do. Can you hear me well?
Very well, thank you. So let me introduce you, Gregory. So Gregory is a professor of value in health at the Université Paris Cité School of Medicine, but he's also president of ProTime, a company that has a big focus on the capture of outcomes, patient-reported outcomes. And Gregory has done some fascinating work, which we wanted him to share with you, which is just what you can be doing to improve outcomes beyond your surgical talent. So, Gregory, over to you.
I would like to reflect a bit on the experience that we are currently running on Carpal Tunnel in France and the registry, the standardized registry that is currently deploying nationwide. The starting point of the reflection before embarking the Ministry of Health on the national payer, the Assurance Maladie, was first to understand how important is the unwarranted variation of hospital outcomes for cataracts. In Sweden, for instance, where you have a registry, you can suddenly realize that you have 3,100% more probability to have capsular complication for cataract surgery, which is a basic surgical procedure, depending on the clinician, depending on the clinics, etc. And this comes after decades of guidelines and good practices. Another starting point was the coronary disease registry in Sweden, where 69 teams were comparing and benchmarking head-to-head according to a quality index integrating so patient-reported outcome measures. And you can see that for the below-average hospitals in blue, you can nearly quintuple the quality index score just a few months or years after the scores become public. So the impact of transparency is tremendous to improve value. This is why Sweden is massively investing in outcome-based registries to reduce inappropriate care. So based on this, we launched for cataracts a registry with a decree published in the French journal Officiel, mandating or commissioning Promtime IT to standardize this registry with case mix adjustment to compare apples to apples. In short, this is a standardized registry where you have comparative audits based on prompt questionnaires for cataracts or visual comfort. And then you can see that these audits pave the way for open comparisons with two impact, remuneration and recognition. And suddenly there's a momentum, a dynamic, that attraction that is launched, and with concrete figures. The scientific governance is key because, of course, everyone wants to be on top, and this is why we work with some deontological guidelines. Also, we involve medical colleges and patient representatives, which is a key success factor for this kind of registries. We mapped out the health gain, and I'm coming to carpal tunnel because this is actually the same kind of tools that we are currently deploying. But most importantly, there's a community of practice with a Plan Do Study Act continuous improvement loops, iterative loops of improvement. And that's also an impact, not only on practices, but also on patient outcomes. So in short, does it work? Yes, for cataracts, 17% improvement after 2 years. 40% of surgeons have changed their practices after 18 months within the registry, so nearly half of them. And we can also isolate what are the low health gains, so low value care, what is high value care, and how can we measure and quantify these figures. But what can we do with this? Then we mapped out every single procedure, and we also presented some scores, statistically defined. Below 65, the prompt pre-op score would generate a probability of significantly improve the patient health gain, roughly 91%. But if you are above 85 as a prompt pre-op score, the probability of failing to improve the patient is 80%. So we have a predictive tool that makes surgeons accountable for the outcomes they deliver. In short, when you compare, you improve, and we have demonstrated that. So how can we apply these learnings for carpal tunnel? Well, we have objectives, we have indicators, TREM indicators, and also PROM indicators. Ultimately, in terms of cost, the cost of sick leave is nearly 80% of the cost, at least in France. The spendings is 3.5 billion euros of the upper limit for MSDs. And you can see that carpal tunnel represents 1.8 million days of avoidable sick leave. So that represents a huge amount. Treatment, the cost for treatment is only 22%. So we need to take this into account when we want to also work on value. So we decided to launch this nationwide registry helping surgeons to compare and improve value for patients. We have today, spontaneously, without any advertising, nearly 50 surgeons joining the registry, which accounts for nearly 10% of the overall number of hand surgeons in France. We have posters in the waiting room to speed up the process of informing the patients and getting the consent, the patient consent, through a QR code. We also calibrated a TREM instrument, so patient experience instrument, measuring the quality of patient-surgeon relationship with 4 dimensions: empathy, information, communication, and availability. This was published, it's calibrated, and we also found out, and we demonstrated in an article published in GBGS, that there's a very strong and clear correlation between the relationship and the quality of relationship and the duration of patient sick leave. So based on this correlation, we wanted to accelerate functional recovery and return to work. So this is why we blended not only the relationship score with the QPAS-REL, but also the functional score with a quick dash. And the idea here is to digitize the collection of both questionnaires, so 11 questions both, and that's it accounts for nearly 6 minutes per patient, so reasonable. And then we deployed a digital platform with the relationship score, the functional score, with team benchmarks and surgeon benchmarks. It's on a voluntary basis. No, there's no obligation here, but you can see that in short, the champions are stepping out of the row and are volunteering to compare, and it creates, of course, attraction for the others. So this is real-time and real-life data. We benchmark against the national average, and you can also isolate which type of items are actually important to improve. The dashed line is the national average. You can see for vocabulary, for instance, you can lose the trust from the patient if you use too much jargon. So the teams are benchmarking. We can see significant difference across the teams, and we invite the leaders to speak in e-tutorials with podcasts to the rest of the group, the rest of the community. So it's continuous medical education. It's also item stratified. And in terms of financial sustainability, it's a fantastic return on investment. Given the financial crisis today we are witnessing, it's very nice not only to see that it's beneficial for the patient, but also for the health system at large, so you can, of course, reallocate resources for valuing the work that these teams are doing on the ground. The last message, it will be tremendous. We'll be super excited and honored to collaborate with our British colleagues and with the ESSH. So please reach out to Amish or myself if you want to pursue the discussion further. Thank you so much.
Gregory, thank you so much, and thank you for posting your details. Please do contact Gregory at an individual level if you have questions about his presentation. Lots of information in there, but maybe as an association, you might want to team up with the French Society and Gregory's work. Fantastic that something that costs nothing, which is being nice to patients, gives you better outcomes. Really interesting to see. So, Jeremy.
So thank you very much. And there's one thing that Gregory alluded to there is the comparisons to normal population data sets. And it's a pleasure to introduce Dr. Anil Bhatt next as Associate Dean, Professor and Head of Hand and Microsurgery at Manipal who's done some fabulous work in building normative data sets, particularly in the Indian population, because these are often what's required for comparing and contrasting. So thank you very much.
Thank you, Jeremy. Well, I come from a different planet in terms of value and prompts, but yeah, I've come from 5,000 miles, and the cold is really biting. Well, we do have warm beaches back home. You're all welcome there. Well, maybe I'm an outlier here in terms of the carpal tunnel and the value-based healthcare, but what we're talking about is the data sets which we developed recently for the Indian normative data and how it can be used for our own patients. And this was the President's theme in the last year, 2022. And well, it is crucial as a benchmark for us because for clinical assessment, treatment planning, and research, the data sets we have should be country-specific for you so that we can customize the treatment approaches. And all of you know how diverse India is with the amount of ethnicities. So it becomes very, very important and crucial for us to ensure diagnostic and treatment options, which is much more relevant for our population here. So it all started off in 2021. We had a great, we have WhatsApp group, and we had a case discussion, and we were talking about metacarpal length for screw fixation. And that's when the whole argument started, what is the correct screw size for an Indian population? And very informally it started, and then this theme emerged that we should have our own normative data. So these were the steps of that, the planning, the execution, and the implementation. So after a preliminary brainstorming, we had a task force, ISSH research wing. I'm in charge of that. And this entire project was given to us to conduct. And we had a lot of online meetings. What we set up was basically a project proposal template for all our ISSH members so that whoever is interested in being a part of this project to develop the normative data sets, to submit this so that they're part of this project. And these are the projects which we took up in the last 2 years. One of the thing was for the radial club hand, the radial longitudinal deficiencies, where one of our own papers went for a review from JHS, and they asked us, what are your normal ulnar length in Indian population? We were trying to see if the ulnar growth on the opposite side for a particular procedure. And again, so the normative data of ulnar length in pediatric age groups was one of the projects. Carpal measurements, upper limb measurements with correlation with grip and pinch strength, adult carpal measurements, active range of motion in fingers, and 2PD measurements in pediatric hand, normative data on radiographic scaphoid measurements, and absence of palmaris longus and functional FDS in little finger Indian population, the normative data in grip and pinch strength, data of first web space measurements, and data of nail growth in the hand. So these were the projects which were given by the ISSH members who wanted to participate in these projects. At the same time, I remember Dr. Raja Sabapati calling me up and putting up this, and he sent me this article of how to actually go about it, the steps of, he was part of this ISHOM group for the outcome measures, and he advised how to conduct these kind of projects. So we had these protocol presentations initially. We wanted people to review the literature, especially of the Indian and the world data for sample sizes, their aims and objectives. The methodology was what we were very, very particular about in terms of measurements and calibrations. And what is the justification for your study? Why did you choose these normative data sets? And that was very, very important for us. And of course, sample size. And we wanted, obviously, multicentric kind of participation because of the diversity here. So we asked people to be part of this from different areas of India, northeast, southwest, and central. This is just an example of different methodologies. This is about carpal measurements, which we talked about, and what is their inclusion and exclusion criteria, very, very specific, and we're very particular about the sample sizes. A lot of these data, or rather projects, didn't have a previous kind of reference values, even in the world literature. So we had to do some of these sample sizes with difficulty. Everybody had ethical clearance from all these institutes, whoever is the multicentric partners here. And we also signed MOUs between the centers so that there's no problem with authorship for data sharing or any of these things. All these measurements, the instruments we used were calibrated very, very scientifically. And we had almost 17 online meetings, rounds of online meetings for us to, scrutinize the methodology itself. And one of the institutional ethical committees said, this was during COVID time, and they said you have to train all your multicentric partners especially for the way you measure things or the way you do the methodology. And this was done online for all the participants, how exactly to do. So the entire training was done online for all the PIs. And some of the things were like blinding the patients here for 2PD measurements. This is another example of metacarpal. So these data sets were like complete. I mean, it's not done till now, even in the world literature, some of these complete parameters are being done for these. This is a CT scan-based metacarpal length. This is the ulnar length. These are the carpal measurements here. And these were the data collection charts. Again, we were particular on the methodology in terms of inter and intra-observer reliabilities. So everybody were asked to present this after a pilot study so that the measurements are not going wrong. So the preliminary study results were asked to be presented by all the PIs. And if there was any course correction to be done, it was done after this pilot study results. So this was a pilot study for scaphoid measurements after 100 X-rays. And any problems or any methodological corrections were done at this point of time. Again, this is an example of a PI doing about the FDS. So she had a sample size of 200, and this was the test being done here. But then we also came to know, somebody suggested during one of the presentations that the ring finger FDS could have a connection with the FDS of the little finger. So even though 86 participants were assessed, we broke down all the data and then went back and reassessed the entire data again for this with the new methodology. Well, normative data in carpal tunnel. Well, we recently published this 3-dimensional silicon mold analysis of the shape of the carpal tunnel itself in terms of the volumes, in terms of the shape, in terms of how the length of the carpal tunnel recently. But then when we saw the normative data, especially the cadaveric dissections, the extent of the carpal tunnel is itself defined differently in all these studies, till now, whatever is available. So what we did was we just took out the contents and just took the carpeted area of the soft tissues of the carpal tunnel. So we think that that's a better way of doing this. And we came out this elliptical truncated cone tapering distally towards its outlet is the shape which we saw in our data set. And also the new thing we found was that the ulnar side was significantly deeper on the radial side. So this is again a new finding in our study. What we're now doing is to assess the morphometric assessment of carpal tunnel using a 3D reconstructed MRI with patients and controls so that we get some normative data of the carpal tunnel. So this is about 72 carpal tunnel patients and 72 controls. These are the segmentation of the MRI images of the carpal tunnel. And these cross-sectional areas were measured. And one of the things which stands out, especially in MRI, is the palmar bowing, and that's the difference which gives between the controls and the cases itself. So the study right now is showing that the presence of palmar bowing with significant increase in volume ratio in patients compared to the control, implying a possible reduction in the tunnel space. MRI also collaborated our cadaveric study of a truncated elliptical cone shape of the carpal tunnel, especially at the outlet. Well, possibilities for normative data in CTS. Earlier, the previous speaker has shown about the AI prediction models. So this is one of the things which can be layered on to the previous speaker spoke about the symptoms, but the normal data sets like BMI, the shape of the hand, especially the square shape of the hand. If you look at these, delayed carpal tunnel distal radius fractures. If you look at these angles and measure these and then put it on the AI models, probably these are the ones which will predict the carpal tunnel syndrome in these patients. contralateral carpal tunnel release at the time of unilateral surgery. Again, these are the data sets, the normative data sets which can be used through an AI prediction model. This is a very interesting study where you don't have to do EMG when you have the CMAPs in the NCV. So this is, again, these are the things where, I think this is where the value comes for the patient, where patient doesn't have to undergo EMG if you have a particular NCV study or NCV finding which you can see, and they don't have to go through the EMG and the painful EMG for it. Well, these are the PIs of our Indian normative data of upper limb, and I thank Dr. Mukund Tate, his presidential team last year for this huge effort of ours. Thank you so much.
Thanks very much. So we're going to round up our journey with one final talk. So we've thought a bit about how patients are referred and assessed. We've thought about what happens in theatre, the theatre episode, and how you can get a data set and costs together. What about after carpal tunnel release surgery? What can we do to either improve outcome or reduce cost?
Hello everyone, sorry that I can't be there today. My name's Conrad, I'm a plastics reg from Oxford, and Jeremy's asked me to talk about making carpal tunnel release follow-up cheaper, yet better. What does better follow-up look like? Well, from a research funding perspective, what the government really wants are fewer DNAs. NHS England estimate that the average outpatient clinic appointment costs about 120 quid, and as we came out of the COVID pandemic in 2022, there were 7.5 million missed appointments across the NHS, which scales up to about £900 million of taxpayer money spent on clinic appointments that patients don't show up to. Patients might miss appointments that they don't feel they need, so we should try to avoid inviting patients to unnecessary appointments. So to directly quote the NHS long-term plan, this would be better for patients, support more productive use of consultant time, and enable the capacity of outpatient clinics to be used more efficiently. I'd also add that if we didn't see people in person unnecessarily, that might also reduce our carbon footprint and limit the spread of communicable disease. Conversely, patients might be unable to attend appointments that they do need. So people with financial difficulties, caring commitments, mental health problems, addictions, disabilities, or language barriers may all struggle to attend appointments, and that drives healthcare inequality. Better follow-up means lowering barriers for those with access needs. Follow-up should be timely, and by that I mean we should be detecting complications and other issues as they arise. In general, catching problems early is better for patients and cheaper for health services. And that's another reason why we need to lower access barriers, because otherwise you end up with groups of people in society that have problems which are bigger than they needed to be. You might have heard our team talk about MCAT and the MCAT study. This is a smartphone app that we've built that uses algorithms to pick and choose questions about a person's health. And from that, we can measure things like hand function. And this is just as accurate as using full-length research questionnaires like the patient evaluation measure, but only takes a median of 8.8 seconds for a patient to complete. So this graph shows one of our patients recovering from a metacarpal fracture. A high score means that they've got bad hand symptoms, and a score of -2 means that they've got no problems with their hand. Over the 12-week study period, you can see how this person's symptoms have gradually resolved, a bit like watching someone's CRP come down after infection. This patient happened to have a hand fracture, but I think we'd probably see something fairly similar as someone recovers from surgery like carpal tunnel decompression. If we could see people's recovery trajectories remotely, perhaps we could decide whether or not they really need an in-person appointment. 93% of households have internet access in the UK, and 87% of adults own a smartphone. That's not everyone, but for many people, the barriers to engaging with an app for 8.8 seconds a day are lower than making an in-person clinic appointment. What we need to do next is map out the flight paths that we expect patients to take following an operation. And that way we could quite easily see when someone drifts off course. That could trigger an automatic alarm and maybe a phone call from the team. There might even be the possibility to explore problems and triage further using automated chatbots, as these are becoming more and more sophisticated each year and could quite easily be built into our app. We're in the process of setting up a multi-centered study that will capture recovery trajectories after carpal tunnel release and other common hand surgeries. That will hopefully generate the normative data we need to start building AI-driven complication alarms. I'm very grateful to BSSH for contributing funding to that and for supporting the early development of the MCAT platform. If you're interested in joining our research and following some of your own patients up with the MCAT platform, please do reach out to us. This QR code links to the pilot study paper, which has a lot more information about the platform. I'm sorry that I'm not there to answer any questions, but I'm sure if you can catch Jeremy before he disappears off to the distilleries around Glasgow, then I'm sure he'd be very happy to take any. Thank you.
That will teach me to make sure that I should listen to my trainees' talks all the way through before they upload them. So, egg on my face.
Ex-trainee.
Yeah.
Good. So that kind of ends our potpourri of presentations covering all aspects, or many aspects of value in hand surgery, particularly with a focus on carpal tunnel. Amazingly, we do have a few minutes for questions. And so could I invite anyone who's got a question to put their hand up? And we'll get a microphone to you. Or there are some fixed mics if you want to walk to one. David.
Hello, David Shuring from Cardiff. So I'm actually one of those surgeons in one of the Welsh hospitals that has apparently been assessed. And I really don't know where you got the costing from. But if they were trying to assess whatever it costs to do one of my carpal tunnels, I really cannot understand how you could work that out. So at the risk of making myself unpopular, I think you are focusing on all the wrong stuff here. I did enjoy it all, but I think unfortunately, I think you've missed the point from my point of view. So in my working day, I get there at 7:30, I draw up all the locals, I see the patients and mark them, and then I do 3 carpal tunnels or similar cases whilst the anaesthetist is seeing the patients. So by the time I've done those 3, she's got a block in one and a GA into one of the others. And I'm on my 5th case whilst the theatre next door to me is still doing their debrief. And then I usually do 1 or 2 locals in the middle of the day when she sees the afternoon patients, and then I do a couple, 2 or 3 when she's gone home, generally finish the day by about 5 o'clock. And I get through about 14 cases. Now, I think what you should be focusing on is the gross inefficiencies in theatre, which I see all around me, and it's really depressing. You know, I've striven very hard to make my theatre as efficient as possible. The patients don't get undressed for locals, they walk around in their clothes. I find that is much more preferable for the patients. Putting a gown on, from personal experience, is the most depersonalizing experience in being a patient.
David,
it makes no difference to the effect.
I think we've got the point. I'm just conscious we've only got 4 minutes
Okay.
left. So a general point, which is how do you translate the costing into a different model of delivery? Which I don't know, Natalie, do you want to respond to that?
I think, as sort of alluded to, we know that there are areas in Wales that are more efficient than this data would suggest. And certainly, similarly in Swansea, we have a very efficient day surgery unit that gets through the similar cases that you describe. But we know that in the other health boards, they're probably even worse than the data suggests, because they're trying to do it in main theatres, competing with everyone else. So there's definitely inequalities. So not meaning to offend anyone by suggesting that people in Wales are inefficient in any way. But what we think the data will help when we start looking at it in more detail, interrogating each individual pathway, the ones that are working and the ones that aren't, we'll hopefully be able to develop a procedure room setting that maybe mimics the efficiency that we're seeing in some of our theatres, that we can then free up space in main theatres for other things. And what that may look like is certain hubs that do it really well, taking the carpal tunnel work so that the main theatres can do other stuff more efficiently.
So it would be very interesting to cost your model, David, and to demonstrate that it's of higher value. Now I'm going to, David, really, okay, the point is well made. Thank you, John Hobby.
So thank you very much. Proms are a very powerful tool, but I remain concerned that there is a danger that proms will miss important differences, particularly in terms of symptoms, and that many of them are designed predominantly to assess function, and we know that human beings adapt. So people may return to functions, but not be the same between two interventions, but you may miss that with a prom.
No, I think that's a very valid point, and I think this is why we've got to be very cautious and careful in our use of contemporary psychometrics to understand how well our proms are performing, and that's why we've split the DASH and the quick DASH, because actually psychometrically you get better measurement that way. I think part of it will depend on the context you work in. If you're being pressurized to discharge all carpal tunnels without routine follow-up, SOS follow-up only, then potentially what we are talking about here is some attempt to safety net people back in more than you are being otherwise allowed to do. But yeah, otherwise, I think we do have to look quite carefully at this. The other point to make, I suppose, is also understanding what the patient perspective is. Because we as surgeons are often interested in finger joint angles, what the exact range of motion, what the performance is. But if the patient is functioning society, then at one economic level, a perspective may be that that is what we need. So it may, there are different perspectives besides the surgeon perspective, but I think it's trying to integrate and get the best for the context that we're working in. But it's a well-made point. I completely agree.
There's a question right at the back. I think you're going to need a microphone. I think you're going to need kind of you to shout.
Going back to your costings on carpal tunnel talk that I enjoyed very much, thank you. Did you try and understand why the cost post-COVID was basically half as much again as the cost pre-COVID? What was the reasons for that? Did you explore that?
We haven't explored that in any detail yet. I suspect it's to do with the more global inefficiencies that we're seeing, lack of theatre staff, lack of theatre time, and that raw materials are costing more, but I can't say that for certain because we haven't interrogated it.
Thank you.
It's a very striking fact, though, wasn't it? Alarming, in fact. And it will probably relate back to David's point in a way about inefficiency now and the technical value of the pathway. Question at the front.
Thank you for some excellent talks. I've been trying for years to get proms going, and I've had a lot of difficulty with patient buy-in, so they don't fill them in before they turn up for the appointment, and they certainly don't fill them in afterwards. I was wondering if the panel had any help to get patient buy-in so that they'd fill out all the proms.
Brigitte, you want to?
Yeah, thank you for this question, because that's actually the most difficult part. And mostly of the time, patients are willing to fill in pre-operatively, maybe after 3 months, but not after 1 year anymore. I think what is important is that we make the list as short as possible, what we are already doing. You are also doing research on that. So we have a lot of questions, and we should shorten the questionnaires, of course. And nowadays, we are making it more personal, and we are also telling the patients that we need those data, because otherwise there is a risk that it will be taken out of the insurance. So people are becoming, yeah, but that's the problem in the Netherlands, what's going on. So we really, and if you make it personal, then people are more willing to do it, and make it as easy as possible. So make an app or whatever, and then you still have the problem of protection of data. That's another issue. But you are absolutely right, that's the most difficult part. But yeah, convince people that it's needed and make it as easy as possible and shorten the questionnaire lists.
And just to add to that, I think that if patients, if they can see that there is a point to it, if they can see it's part of their care, not a was this parcel delivered effectively type questionnaire, then they are more likely to keep filling it in. If they can see you're using it, you're reading it, maybe you're changing their management on the basis of it, they are more likely to fill it in, I think, is our experience in Wales. We've collected about 1 million PROMs across lots of different things. One final question, and then we will have to stop. The lady there.
Thank you very much. So one thing that was concerning me is, as we're looking at the requirement for improvements to demonstrate value, do we risk penalising that cohort of patients where actually they're not likely to improve, but they're likely to get worse if we don't intervene? And so because they don't improve with their intervention, they might then suddenly be excluded from funding. My example, thinking of carpal tunnel, is the patient who's got quite severe advanced disease but still has some protective sensory function might then not qualify for a carpal tunnel release if we're looking at only patients that are going to improve. But by having that intervention, they retain that critical sensory function, accepting prior to their surgery that they're not going to get better, but it's going to stop them getting worse.
That's a very good question. Who'd like to answer that? Jeremy.
Yeah, I think that's a really well-made point, and I think this has been a challenge in the UK in the National PROMS programme, which collects data on hip and knee arthroplasty, but also varicose vein and hernia surgery. Not everybody's having a hernia repair to improve their function. They're having a hernia repair so they don't strangulate and fall off a cliff at some point in the future. I think there's 2 points about that. I think we need the kinds of normative data sets that we've talked a little bit about here, but of trajectories of what's happening in the absence of treatment, potentially captured when that's not harmful. I know there's people in the room here, Jay McEachin's talking about this kind of work, and I think that's going to be critical. This is what happens if you do not intervene, because then you can model against the decline rather than against stasis. So we need the data to do that, and then we also need to be around the table making the decisions, because I suspect one of the problems in the National PROMS programme is that a sensible hernia surgeon has not been able to engage and explain why the modelling they've used would never show an improvement necessarily. So it's a really well-made point.
Jeremy, thank you very much. So I think that is bringing the session to a close. I've got just a couple of messages. If you've enjoyed the session, please do tweet about it or put it on LinkedIn. There is a hashtag, which is capitals BSSH, autumn with a capital A 23. There is a session in here now for people who are interested in hearing about a trial or a multi-centre trial on patient-specific carpal spacers and osteotomy plates. That Sovereign Medical are running that with Chris Little and Nick Riley. They're looking to set up a multi-centre project, so if you're interested in that, please do stay here. You will still have time to have lunch, which is about to start. If you're interested in value-based healthcare and you want to know more about it, please do come. We have a stand out there. We run courses, and you can even do a doctorate in it with us, so please do come and talk to us at the stand. But can I just ask you to thank all the fantastic speakers we've had for a great session. Thank you very much.
we'll get going. The interesting bit's the clinical stuff. So I'll introduce myself. My name's Oliver Morgan. I'm head of upper extremities at Meshworks Implants. Meshworks is an Oxford-based medical device company that was spun out of a larger company called Alloyd. Alloyd was started in 2016 and was conceived by two companies to start a company that would create better 3D printed parts and metal alloys. Today, Alloyd works with some of the top tech companies in the world. That's to develop F1 race car engines, components for aerospace and aeronautical travel, and even the next generation of augmented reality glasses. Now, this technology is filtered through to Meshworks, which is the medical arm of Alloyd. We've developed three primary areas of custom orthopedic implants. The first are cages for orthopedic oncology, limb reconstruction and trauma, spacers, which the brilliant Chris Little and Nick Riley and Sumed Talwalkar will speak to you a little bit more about. These are primarily indicated for avascular necrosis and treatment of the talus, lunate, scaphoid, and other carpal bones. Finally, we also provide custom plates for correction of multiplanar deformities of the bone. These technologies have led us to develop a cohesive upper extremity product line spanning a range of disease and symptoms, from simple 3D planning with plastic guides all the way through to treatment of failed wrist replacement with cages. So we see ourselves as special in orthopedics because of four main pillars: our 3D printing technology, our design platform, our collaboration with surgeons and data collection, and our materials. The first pillar is printing, and we're proven best in class in this area. One of the issues with 3D printed parts is they break very quickly. They fatigue because of impurities in the material. What we've done is develop intellectual property around the printing methods to make these impurities much smaller, as you can tell from the image on your right. This means our fatigue life is much higher, and the implants are much less likely to break. In terms of design, we invest in software specifically for automation. This is to make sure that our design process is as fast as possible and that you can get your custom implants as quickly as possible to surgery. The third is data collection, where we try and work with every surgeon who uses one of our devices to collect data and make sure, firstly, that what we're doing is correct for the patient, and secondly, we're optimizing those outcomes. Here's a small study from Ferin Wu, who is our expert in distal radius correction, compared to a much larger study of off-the-shelf implants. Finally, the fourth pillar is materials. So at the moment, Meshworks has created a new type of metal alloy, which is shown to be half as stiff as Ti-6-4 and much closer to the Young's modulus of bone. This is currently undergoing sheep study and will be published in 2 months. The study has found that this material is 33% more osteoinductive, meaning that the bone implant integration is faster and much better. So while we talk about design and automation and all of these buzzwords, really the first thing we want to do is get these implants to you quickly. At the moment, we can provide an implant in about 2 to 3 weeks. We want to get this down to 72 hours. In the video you see there, this is a wrist plate configurator that we've developed and is in use currently. Within minutes, we can develop a guide, a plate, exactly as it will look for surgery, and also provide you with the pre- and post-op biomechanical information so you can assess what alignment your patient will be corrected to and the expectations of that correction are as you would like. So really, the philosophy of Meshworks is an easy surgery. That's a surgery that's pre-planned and right first time. And specifically today, we're going to talk about that with respect to total lunate replacements, partial scaphoid replacements, and total scaphoid replacements. And while I talk about the technology, really the most important part of what we do at Meshworks is collaborating with surgeons. What we try to do in every design and development that we have is get a large team together that is multi-centered and can create a device that is custom, but will still provide the best outcomes for your patients. So with that, I'm going to hand over to Chris and Nick to talk a little bit more about their input into the project.
Ollie, thank you very much. Did somebody mind just loading up the next talk, please? There we go. So, just want to run through where we see the role of patient-specific implants and the design principles which have been, to a large extent, covered by Ollie. The design process from our perspective as budding or working surgeons, and then some reasons why we think that this is a good group to be working with. Talking also about the indications. So, the obvious indication for a custom implant would be those unusual pathologies, those niche indications, but changes in the availability of implants through MDR has meant that some of the things we were very used to using off the shelf are no longer available. That produces both access to those components problems, but also provides opportunities to think about designing things that would be specific for a patient and more appropriate for their anatomy, rather than 3 sizes don't really fit any of them. There are some patients that have complex anatomy, and that's a particularly important group in the adolescents that have been injured, where you're not just dealing with the consequence of the injury and potentially some not so successfully executed procedures, but also the fact that growth will have occurred with the patients in a deformed position, and so there will be very hard to predict degrees of correction or modeling in a bad way. PSI, yes, we all like to think that we can do these things very well and we don't actually need these jigs, but by making you have that preoperative plan that you've thought through, not just to your own satisfaction, but also bouncing ideas off peers and off the design engineers, means that you come into theatre with a very well-constructed surgical tactic. This will reduce surgical times, should produce better patient outcomes. The evidence for that is limited, but one of the advantages we see with working with Meshworks and Sovereign is that they are committed to ensuring post-marketing surveillance universally, and so we will gain those data. And it does also give you the confidence to intervene, particularly with things like intra-articular corrective osteotomies, where otherwise you might find reasons to perhaps not step in because you think, I don't really know how I'm going to do this.
Thank you. So we have to be honest with ourselves. The opportunity to start implanting bespoke prostheses is attractive, but we need to maintain the fact that the patient is at the center of everything that we do. So we need to think about what the patient needs and what our goals for surgery are in order to be able to deliver these bespoke prostheses and implants successfully. We then come down to whether it's actually possible. Do the soft tissues enable us to implant these prostheses well? Does the skeleton enable us to do this? And then finally, are there any manufacturing constraints that mean that actually this prosthesis or this implant is not deliverable? And that's where the conversation with Oliver or another engineer begins. And that conversation requires a CT scan, and if you're requiring to compare with normal anatomy, bilateral CT scans. That can either be uploaded via an online portal, but we've been able to liaise with our PACS team who have come up with a way where we just send Oliver a minimal clinical data set, the data of the scan, and then PACS send it directly to him. For me, this is a game changer because it reduces yet another administrative burden for me in a context of increasing NHS administrative burden. And then we sit down and we have a design review meeting. The benefit of working with Oliver and Meshworks is that they have experience. Now that experience is predominantly lower limb at present, but that's translating well into the upper limb. Both Chris and I have worked with multiple 3D printing companies, and sometimes it's difficult to have the conversation because sometimes English isn't the first language, and I've also received an implant that wasn't quite right and not what I expected based on the planning. Both Meshworks and Sovereign have engaged with the regulatory bodies. This is really important. Hand prostheses at the moment are precarious. We're going to probably lose more implants. So when we're establishing this kind of system, it's important that we engage early with the regulators. Sovereign and Meshworks have really supported and helped to establish a multi-user group. if we're going to do these implants, it makes it much more sustainable if we stand as a cohort of surgeons, as a group. And it's not just one surgeon getting a 3D scan of a lunate and deciding that they want it to look this way and it goes in like that. If we stand as a group with some key core tenets, we'll be much better protected. Meshworks are pretty quick, and Sovereign are pretty quick in turning these round. So Ollie's looking at 72-hour turnaround. For the prostheses, at the moment it's 6 weeks, but because manufacturing processes will become entirely UK-driven in the new year, you can get a bespoke prosthesis probably in around 2 weeks. As I've touched on, having a cohort of surgeons to provide peer support is absolutely key. If you're having a post-surgical complication, it's useful to have friends to talk to who are collaborative and supportive.
So now to talk a bit about some of the more specific things. I think we all have patients in our practice whose proximal scaphoids haven't quite turned out how we'd have wanted. They've not united, they've collapsed down, and yes, there are some alternatives. But all these biological reconstructions do have downsides, both donor site problems, and also takes quite a long time once you're trying to put that many Liga clips on the small vessels. Arthroplasties exist, but there are 3 sizes, and most of the patients aren't quite that size, and it seems a shame to be going in, trying to thumb something in if you can design something that's bespoke to the patient based on their normal anatomy. And this needs to reflect both the soft tissue reconstruction and also the anatomy, and they'll be coming with upsize and downsize and tending to err on the downsize in order to minimize the tensions. The precise positioning of the soft tissue reconstruction holes is very much something to work through in your design meeting. As a group, the people who you saw earlier, we're going to be looking at these things in a CAD lab to try to see where we think the best places are, both from a biomechanical perspective, but also from a practical perspective. You're the guy that's got to be drilling the hole. You're the surgeon that needs to be making the reconstruction. So it's important that it works practically as well as looks good on a model. The principles will be to have a jigged resection so that you know how much bone is left and you're replacing, and then work off a cannulated instrumentation system such that you can both prepare the bone to receive the implant and then impact it along that wire, followed up with the soft tissue reconstruction. There are salvage options that you could use as an alternative, but this is something that shouldn't be burnt by the surgery. Many of these reconstructions, be that limited salvages, be that limited risk fusions or PRC, may well be preserved even having tried a partial or a total scaphoid replacement. Because there are some situations, albeit rather more niche, perhaps tumor, perhaps post-infection, where you might want to be considering a total scaphoid replacement, where again, the issues of soft tissue reconstruction are critical, although you haven't got the same problems of getting integration of the implant into the remainder of the scaphoid. The principles will be very similar, except here the ability to up or downsize slightly on where you're modeling to is quite important, and there'll be feeler gauges with built-in pilot holes to enable you to mark where your reconstruction tunnels should be placed into the lunate, which should facilitate the whole process.
So the indications for lunate replacement are pretty much Keene box disease alone. We've looked at modeling this pretty much based on the pyrocarbon Integra implant that was used prior to a couple of years ago. And I was pretty content with the 6 patients that I put a pyrocarbon lunate into, and it was a shame to lose that implant. The benefit of being able to match the lunate to the patient's contralateral side is strong, and the secondary ability to site soft tissue reconstruction holes wherever you want is also attractive. And whilst this diagram demonstrates a pretty similar reconstructive method to that pyrocarbon implant, if desired, we could put oblique holes in so we could create dorsal and volar reconstructions within the implant. So the fact that we have the ability to construct 3D bespoke implants is very useful in these niche indications. this would be done in a very similar way to the Integra. You have a jig, you mark where you're going to put your soft tissue reconstruction anchors, and then the lunate would come in 2 or 3 sizes based on what you preferred. So in summary, and we're looking to engage discussion and questions, so please don't all disappear off to lunch. Sumed should be coming to talk about his lunate reconstruction methods. But in summary, we feel that patient-specific implants and instruments in some ways are a game changer. It enables you to pre-surgically plan in greater depth so that you don't need to improvise intraoperatively as much. We don't think that these options burn bridges for established salvage options. And the key thing here is that we're going to deliver this collaboratively. So we're not delivering it as single users. This is a multi-user, multi-center group. And finally, given the precarious nature of hand and wrist implants at the moment, it is important that we continue to engage with the regulations. So thank you very much for listening. we're happy to take questions.
As I'm sure is Ollie.
Ramesh.
Is that? Thank you very much. Like Chris said, correcting a distal radius malunion is hard enough, sort of on the go. But what I found even more hard to treat is forearm malunions, especially if it happens in a child with rotational malalignment. So those are the ones I really struggle, and I think bespoke instrumentation is critical for those. In fact, I think it's harmful to even try second guess what's going to happen when you refix them.
The both bone forearm malunions are particularly difficult, and especially when there's a rotational component to them. Chris, you've done one or two both bones?
Yeah, a couple of both bones, but also ones where there's been a fracture subluxation left out, so radial head deformities, distal radial sigmoid notch deformities, because it's very hard to appreciate that. And you're not just trying to put something back where it started, you're trying to put something back where its current position in terms of its shape dictates it should go. And that's something you can't really eyeball.
Yeah, so in those cases, do you need a CT of both forearms, or is it just the affected one?
Yeah, so actually I can talk to that because we did one of these very recently in a younger patient at Portsmouth Hospital with Louis Martel. No worries at all. And you're completely right. Using patient-specific devices is a game changer, both in terms of surgery time, but also in correction. So yes, we do take contralateral CTs because actually you're going to get a more accurate biomechanical alignment of the healthy limb and therefore the expected alignment of the unhealthy limb. But really what we saw with a two-placed approach was the patient was cured instantly once it was corrected. They really had full range of motion, supination, pronation, flexion extension. And not to say that, standard plating systems are no good, but you really can see the difference in terms of how range of motion is affected by biomechanical alignment that is unique to the patient. John.
Hi, I, as you know, do a lot of distal radial osteotomies, and most of them don't need this jig system, but for the forearm, the difficult ones, I certainly do use it, and it's brilliant. And I'm completely taking it. Because I normally would get the 3D CT and spend hours looking at it to try and get the angles right. But if I can do that with one of the technicians, it's wide. But there's also the important thing that you have to do that, because what it doesn't show you is where you can put the plate in the best way according to the soft tissue. So if you're doing the ulnar or something, you have to be so careful about getting in a bad position. And that's more where your expertise needs to go. And so it's a combination. So when you're doing these things, it is very much a joint affair to do it.
Completely agree, because the CT doesn't show you where the soft tissues are. So I've done one scaphoid malunion. I'm not recommending it to do lots of times, but I've done one scaphoid malunion. and I used a jig to work out where I wanted to cut the scaphoid. But then once I'd reduced the scaphoid, the second jig wouldn't sit where it was supposed to because the soft tissues were constraining it. So I completely agree. You've got to, this isn't kind of fire and forget. You've got to sit down and really carefully pre-surgically plan, because if you execute that pre-surgical planning well, it makes your intraoperative experience much, much better.
And things like the ulna, it's difficult to know exactly if it's a curve, particularly in the developmental malunions over time, when you're correcting those, is putting the curved implant onto that and then capital the jig on. It's very difficult to know exactly where it is. So you also have to have distance markers on that jig and this sort of thing, and also be able to put it in through the incision or out of the incision. And there are all these sort of things which is why you have to be very careful. We've found with, say, in the scaphoid and things, it's often hard to get the jig in because of the soft tissue. And so it's easy on the CT scan to look at these things, but there are other factors which are, I'm very taken with it, and unfortunately I spend most of my time with one of your competitors.
Well, I totally agree with you, and before I hand over to Sumed for his more clinical talk, which will be very interesting, I will say that actually for these kinds of devices, the engineer-clinician collaboration is the most important part, where I can see how an implant from a manufacturing and engineering perspective will need to be built, both in terms of thickness, size, shape, whatever. Actually, the implantation section, engineers typically aren't very good at. They don't really understand the soft tissues, they don't really understand the anatomy, they don't understand locations of nerves, arteries, any kind of vessels that might cause issues. So that input plus the engineering really is what makes patient-specific that useful. I would agree. Before we take another question, Philip, if you don't mind, I'll let Sumed talk, and then if you still have the question.
Yeah, great. So thanks for inviting me. What I'm going to do is talk to you a little bit about lived experiences. So what we've learned over the last few years doing patient-specific implants. We know that spacers as such work. We're not entirely clear why they work. So this was a 20-year follow-up of an interposition arthroplasty. It's done really well, absolutely no issues, just coming out of COVID, a little bit of grinding, a bit of pain, and then that progressively got worse following a fall. And all I did really was, after seeing her, we spent a little bit of time trying to see if the pain improved, but when it didn't, we just went in and took this out. Now, unfortunately, I don't have her videos. She promised to come and see me back after we took it out, but she didn't turn up. But from what I've heard over the phone, on virtual follow-ups, she's done very well. So we know that these implants do end up doing well. Now, the purpose of doing these replacements is firstly to restore the gap, so you need to do the replacement. The second thing you have to do is to correct any deformity that may be present. Actually, I would probably reverse that. So say, for example, if you were doing a knee replacement, you would correct the deformity first, and then you would think about doing a replacement. And once you put your replacement in, the third objective is to do a ligament reconstruction. So what you have to make sure is that whatever you've put in continues to be stable, because that will contribute to survivorship, stability, and better outcomes. That's the theory. And what you mustn't forget, that this is not a cliche, and this is something that applies more so for the wrist. And it's going to be really difficult to address this particular issue going forward, even using patient-specific implants. So this is a paper by Mark Henry. So this chap, he's written 2 or 3 excellent papers on the subject. His cohort is 13 patients, so that's a fair bit of experience. And he's been quite honest about his complications. So whenever we look at papers, we like to look at people's complications. And the minute you have a paper that has no complications, don't read it. That's my feeling. Anyway, so things that we are afraid of when you do these, particularly in the wrists, is avascular necrosis, because you're going to make a lot of holes to the carpal bones. There is the danger of a fracture that can occur. A consistent theme that I've found, particularly with lunate replacements, is a failure of the scapholunate tether. So you have these patients who've been carrying this problem in their wrists for a long period of time. Over a period of time, the scaphoid has almost become vertical, and it's fixed. And it becomes really hard to reduce that. So whenever you see one of those, when you do your four-corner fusion, you have to press really hard on that proximal pole to derotate it. And that's exactly the sort of situation you have with your Kienbock's patients. So essentially, correcting that deformity, the most important part of your joint replacement surgery, when you say, for example, you're doing a knee, which is a valgus or varus, is something that we do struggle with, particularly with the wrist. And the other issues, obviously, are stiffness and pain. So what he does is something not dissimilar to Brunelli. 2 holes in the scaphoid, a very distal entry point from volar to dorsal using an FCR graft. He dorsalizes the FCR and then pulls on it. So effectively what happens, because the FCR is distally fixed, you're pulling the distal pole dorsally. And by doing that, in theory, what you're doing is you're making the you're deflexing the scaphoid or de-extending the scaphoid. So it's flatter and it comes close towards the lunate. And then he does some black magic there. Now, I've read that paper many times. I have no idea what he does with that second hole. But he then uses that to thread his graft through the lunate graft and into the triquetrum. So you have, it's like pearls on a chain. That's the sort of thing that he uses. But essentially, what I like about this is that he's paid a lot of attention to correcting that deformity correction, because that's the serious issue. David Bodansky looked at our cases. Lardon's in the audience. So it's a group of 7 patients. So since then, we've done 8 and 9 over a period of time. And we use a similar sort of weave. It's the original method was something that we borrowed from Geisler. The same concept, 2 holes in the scaphoid, 2 holes in the prostheses, 2 holes in the triquetrum, and then you use a synthetic and a piece of graft, and you roll it over. So we do something called as a triple lock. Now, thanks to Ollie for sharing this. This is just a video of what you can do. So we do CT scans of both wrists, compare one with the other, and then plan for creating a lunate, a customized lunate, to restore carpal height and try and restore carpal biomechanics or kinematics, whatever you want to call it, in order to ensure that you firstly treat pain and take care of stiffness. So this is what it looks like in the immediate post-op. The distal part is where you see the mid-carpal joint. You can see the weave on the dorsum. And the worry, obviously, is that the weave can then slip into that mid-carpal joint. And once it does that, you lose length and your scapholunate tether comes apart. So I'm sorry about the quality of the video. So this is, in the past I used to use fiber wire, now we use suture tape. So that's the first part of the triple lock, synthetic. The second part is using, I think we used ECRB or FCR here. So we tie that, pulvertaft weave over the back. The synthetic is just a simple knot, not very elegant. And the third part is a dynamic sling, the ECRB sling. So this is something that Carlos taught me, where you take a split ECRB and with the help of an anchor, you push it into the distal part of the scaphoid. Very effective. The one thing you have to be careful with this is that if you put this in too tight, a lot of these people can end up with tennis elbow. You know, you get ECRB pain. So just beware of that. This is what it looks like. Everyone's very happy. After a few months to years, and then over a period of time, this is what can happen. So a recurring theme, which I've found. Perhaps others haven't found this, but this is what I've found. This is at 8 years. This is L1, first student. So she came to us as a junior nurse. She was seriously thinking of what to do with her career. She was going to get married. I couldn't do any x-rays because she's pregnant with a second child. She works with us in theaters. She was in orthopedics. Now she's moved to ophthal. So pain-wise, she's done extremely well. You've seen that x-ray. I don't know whether it'll go back. Radiologically, I don't think in your remotest dreams, you'd call that a success. But she seems to have done fairly well. So there are certain challenges that we will need to face going forward. And to an extent, because these are not cases that we do on a regular basis, a multi-center approach is something that we would favor. You know, you have like-minded people who have lived experiences of how this is done. We need to collect PROMs and registry data. It's an absolute must if we want to continue. If you know, it's a survival thing. So if we don't have PROMs data, if we cannot demonstrate that this works, it'll be taken off our hands. So for the purposes of beyond compliance and ODEP, please try and attend the session that I'm chairing tomorrow with Keith Tucker, who works for ODEP. We have the view of ODEP and industry as well, so it's crucial that you listen to that because it once again exemplifies the importance of using the registry. At Wrightington, I believe in multiple patient encounters. You know, you really need to get to know these people well. They need to know that you haven't done a lot of these procedures in the past. So I just look at them straight and I tell them that, look, I've only done 7 or 8 of these. I'm not necessarily the see-all and know-all of this particular procedure. Don't hold anything back. Make sure that they're aware. Now, Natan has put this together for us, our current fellow, which is a patient information sheet. Again, remember, when things do go wrong, and unfortunately, if you're involved in a medico-legal problem, the consent that you have is just one part of the journey. What the judge, what the patient, what everyone is looking for is the process that you followed. And from the point of view of what our patients do, what our patients like, I think it's really important that they're aware of all the complications, particularly when you do surgery like this, which is not done very often. And one of the things that you do need to explain to them is that they are most likely to require further surgery going down, further line. And the other thing is that they have the option of not having surgery. So very often we forget to make that statement. And it's a very, very important statement. This isn't cancer, this isn't something that's going to kill you, but we can give the reason why we're doing this to you is to improve your quality of life. I'm not sure whether Nick's spoken about his concept of this being one of those procedures which are done in order to tide them over a period of time so that later on, if they do need some reconstructive work by way of either a fusion or a replacement, that very often forms the current role. So there are lots of unaddressed challenges which we hope to work through with the help of our partners. So thank you.
So I'd like to thank Nick, Sumed and Chris, and just say that I hope what this presentation has demonstrated to you is more the collaboration that we intend to develop with all of our UK surgeons to develop these devices and make sure that A, everyone is supported, and B, the outcomes are as expected and should be expected with customs. Thank you. We haven't got a lot of time, but maybe one question if Philip still wants to ask it.
Scaphoid implant, is that a press fit or is that temporarily held in place while the integration occurs? Thank you.
So it's press fit with a very, very beautiful lattice that Oliver has spent a long period of time perfecting. So it will be press fit, and there'll be a soft tissue reconstruction we envisage that comes through the distal pole of the scaphoid, through the implant, and you can then reconstruct it onto the lunate, or you can do a Brunelli type procedure with it. So that's how we envisage that working.
So if you are interested, there are some samples at Sovereign's table. So please do go speak to them. They're very knowledgeable and they have a lot of interesting custom devices for you to look at. Thank you very much and go enjoy your lunch.
Thank you very much.
Good afternoon, Mr. President, Council, ladies and gentlemen. It's a real pleasure to be introducing a Hunterian lecturer to you today. I understand we haven't had one at BSSH for some while now. And my name is Vivian Lees, for those of you who may not know me. I'm a Vice President at the Royal College of Surgeons of England, which hosts the Hunterians. And we're here to hear the lecture from Mr. George Murphy, who is one of our consultants. Full stop. Now, George was a medical student, first at Cambridge for his undergraduate, and then at Barts for his clinical. After his earlier jobs, he then went on to the Oxford training rotation as a registrar in plastic surgery. And during that time, he incorporated a PhD. He's also spent time at Great Ormond Street on fellowship and has undertaken a hand fellowship at the Chelsea and Westminster hospitals. I was very pleased to see you also graduated from the hand diploma, so well done for that. Then proceeded to take a locum job at, a fellowship job at the Chelsea and Westminster, and a locum job currently at Guy's and Thomas's. So with a major interest in children's hand, which he's going to talk to you about, but in his spare time, he has 2 children of 11 and 8, but he also finds some time for singing, I understand. But he's not going to sing today. No, only metaphorically. So if I could invite you to step forward and give us your lecture on radial dysplasia, bedside to bench and back again. Thank you, George.
Thank you very much, Madam Vice Chair. Mr. President, Madam Vice President, distinguished colleagues, ladies and gentlemen, it's a pleasure and an honour to give this lecture named in honour of John Hunter. So, John Hunter is often described as the father of scientific surgery. He promoted an iterative approach based on observation, experiment, and review of surgical results. And one of his most famous cases, in fact, you could almost say he was obsessed with a series of these cases, was the treatment of popliteal aneurysm. This was obviously a common condition at the time, and being reasonably superficial, was often treated surgically, but in a pre-antiseptic age, often also led to the patient's demise. So there was often a chance for rapid and early review of the effect of your treatment. Hunter treated many aneurysms, and those who lived longer, he managed to get hold of the bodies when they died of other causes, dissected them and injected the vessels, and showed that tying off the aneurysm in the popliteal fossa allowed a collateral circulation to grow. And this bedside to bench then reinforced his conviction and the conviction of many other surgeons that tying off an aneurysm was a safe thing to do. His curiosity extended to congenital anomalies, and he was the first to describe a number of these. In his collection, still in the Royal College, there's a horse with an accessory forelimb, one of the survivors from the Blitz bombing. And his casebooks also describe many other anomalies, including accessory kidneys and also anomalous dentition. I'm going to put it to you today that a modern formulation of Hunter's approach is what's been described as the bedside to bench and back again paradigm. Now, traditional clinical medicine holds this bench to bedside view. Clever academics in the lab will invent new drugs, and then the clinicians have to go and work out how to actually use them and whether they're safe. Around the time I was an undergraduate at medical school, some clever physicians, including Sir Keith Peters, the Regius Professor of Medicine at Cambridge, recognized the shortcomings of this and coined what they felt was a new paradigm, bedside to bench and back again. And this consisted of careful clinical observation by a clinician to frame a problem, then taking that problem into the lab to try and work out the solution, and taking the answers back into clinical practice. Now, I know we surgeons are perhaps renowned for being sort of quiet, humble types who don't really make much noise about banging our own gong, but John Hunter got there 250 years earlier. So, radial dysplasia. Many in this audience will know it's a congenital upper limb anomaly. There are spontaneous and syndromic forms, and it can be unilateral or bilateral. It has a hugely variable phenotype, and when you look at the whole population data, it affects about 1 in 8,000 live births, not, as was frequently quoted from Douglas Lamb's paper, 1 in 100,000. But one of the problems, or several of the problems with this, are that whatever you do, there is recurrent radial deviation as the child grows, along with poor ulnar length and poor motion at the wrist or pseudo-wrist. So when I started my PhD, I began by doing a systematic review, like any good modern scientist. This is a slightly busy slide, but if you look over here where it says final results, you can look at the hand-forearm angle, so how deviated, how radially deviated is the wrist on the end of the forearm, the ulnar length, and the wrist motion. I put wrist in brackets because the wrist is, of course, a radiocarpal joint, and if you have no radius, you can have no radiocarpal joint. Patients who are treated non-surgically end up with a deviation on average about 90 degrees. Their forearm length is about 2/3 of normal, and they have a floppy pseudarthrosis, which has some mobility, but may lack stability, and this is one of the ongoing arguments. The classical centralization operation, described over 100 years ago by Sayre and modified by many people since, gives a much stiffer wrist and much better correction of the hand-forearm angle, but at the cost of sacrificing potentially even more of the length of a short forearm, because as you may recall from that previous slide, you cut a bloody big notch in the carpals in order to balance them on the end of the ulna. And then modern versions of that with soft tissue distraction beforehand and then doing a secondary operation preserve more of the ulnar length, a surprisingly large amount of wrist motion. And lastly, at the bottom, you can see both the soft tissue release championed by Mary Beth Ozaki and Scott Oishi, which doesn't give much hand-forearm correction but preserves lots of motion, and Simo Vilke's procedure from Tampere, which is a free second MTP joint transfer. That preserves an excellent range of motion because you're importing a joint, albeit only a toe joint, and gives pretty reasonable correction of the hand-forearm angle. But you can see there are lots of different approaches. There are arguments about whether we should operate at all, and all of them still have poor forearm growth and some degree of recurrence of the radial deviation as the child gets bigger. And this project set out to work out why. Very briefly, and I promise it's only 2 slides, we have to return to the embryology. You might remember from either FRCS or hand diploma exams that the limb develops from a limb bud between the 4th and 8th week of life. There are 3 axes, which are signaling centers, which signal to the surrounding cells to grow out, to pattern themselves from ulnar to radial, and also to pattern from dorsal to ventral. The proximal distal one, the zone of polarizing activity, has a feed-forward loop of FGFs, fibroblast growth factors. That interacts with the zone of polarizing activity on the ulnar side, which ulnarizes by the secretion of sonic hedgehog. And they also interact with the dorsal ectoderm, which secretes Wnt7a and is antagonized as well for the dorsal ventral system. These 3 signaling centers interact in 4 dimensions. So there's both the integration of where they are in 3 dimensions and over time. So the same signal at different times can cause different events to happen. This is made even more complex when you then look at the different tissue types migrating into this. So muscle in the upper limb embryologically comes from within the somites next to the limb bud. and migrate in at a later point. A classical experiment demonstrating this cut the limb bud off a chick and put a quail limb bud on, and demonstrated that you still got chick muscle patterned by the quail fascia. So we knew from these experiments, which again are 30, 40 years old, that the connective tissue extrinsically patterns the muscle. So those muscular changes you see in radial dysplasia are due to cues from the fascia. That suggests that the soft tissues have a distinct developmental pathway from the skeleton. And in fact, you can see these two little mice here, developed by the lab I was at. The one on the left is a wild type, and you can see he's got straight paws. The one on the right, you can see, has a radial club paw at the front. This is a pure soft tissue phenotype. This one's a copy of Holtorum, which is a TBOX5 mutation. The gene is only knocked out in the fascia in this mouse. It's got normal, completely normal skeleton, but it still recapitulates the phenotype. So putting all this together, are there these intrinsic changes in the connective tissue in radial dysplasia patients? Do those changes affect the muscle patterning? And could they therefore contribute to recurrent deviation in radial dysplasia? Unlike Hunter's Day, we had to start by getting full UK ethics and R&D approval, which is not a short process, and we had full informed parental and, where appropriate, patient consent. We took fascial biopsies during planned surgery, whether that was hand trauma for our controls or radial dysplasia patients having their corrective surgery. And then the samples were either flash frozen or dissociated and cultured, depending on what was being done with them, and a number of assays were done, which I'll go through now. They always say if you want to make a condition go away, do a trial. So despite recruiting from several large London hand trauma centres, in the course of the several years we were recruiting, we only managed to get a handful of controls and only managed to get cells to grow from 2 of them. So I'm limited to 2 control patients as my comparator. And for this, we have 6 of a variety of different types of radial dysplasia, some syndromic, some spontaneous. I started off then by characterizing these cells. They've got a typical fibroblast morphology. They express typical fibroblast proteins when you stain for them. So we know the cells are fibroblasts. And there were no nuclei that didn't associate with these fibroblast markers, so we're reasonably confident these are a homogeneous population. So any difference in what they're producing is not down to the fact that we've got different cell populations, it's down to the fact there are differences in fibroblasts in radial dysplasia. A second quick check. Standard assays are that you test a fibroblast by seeing can it stick to a dish, it's an adherence test, and can it move, it's a migration assay. And these are good tests of whether or not the fibroblasts have been so tortured in my harvesting that they've had a near-death experience and are no longer working properly, or whether actually they're viable fibroblasts. And there was no difference when you compare the fibroblasts from the control patients versus the radial dysplasia patients. They were all healthy fibroblast populations, and they grew and passaged multiple times. So our first test, a fairly simple one, is an extracellular matrix assay. That's what fibroblasts do. They secrete extracellular matrix. So we simply grew them in a tissue culture dish with a slightly special media for a couple of weeks, and then decellularize the dish. So you just coat it in ammonium hydroxide, and it dissolves away all the cells, but it leaves the matrix behind. You can already see, if you look at the control versus the radial dysplasia ones, these were stained for collagen 1, that the control sample has an organized pattern of matrix. Radial dysplasia has a disorganized cobweb. But you can then do some clever computing to try and work out how messed up this is. The little panel at C, you might not be able to see, has a series of little squares, each one with an arrow. So the arrow is a computer program that sums the average vector of the lines within that square. And it does it automatically, which is great for the researcher because you can feed hundreds of photographs in and it gives you a spreadsheet at the end with some numbers. When you do this for a large number of these samples, you get a slide that looks like this. Over on the left, R001, R002, those are my 2 controls. The others are the radial dysplasia patients. So the collagen 1 from the control patient fibroblasts was vastly more organized than from the radial dysplasia patients, hugely significant. Okay, that's fine for collagen 1. What about the other fibroblasts or other connective tissue proteins? Well, you get a pretty similar result for fibronectin, which is one of the other common connective tissue proteins. And when you look at some of the other collagens, you find some really dramatic things. Collagen 3 is hugely downregulated in most of the radial dysplasia samples, whereas in the control patients, it's very much there. And when you quantify that, again, you see quite a big difference. It's slightly clouded by the fact that the longer you grow these cells for, the less collagen 3 any of them secrete. But there are quite significant differences in the amount of collagen 3 produced by radial dysplasia cells. Some of the other organizing proteins as well, if you think of the collagens as being long chains, like a scaffolding pole, there are other proteins called the small leucine-rich proteoglycans, which are like the scaffolding clips that organize those chains into a useful structure. And again, those are turned off in radial dysplasia patients. Well, that's very well with cells in a dish, but what happens in the patient? When you go back and look at the muscle histology from actual patient tissue biopsies, there's a striking loss of collagen 3 in the epimysium around the muscle in radial dysplasia. So at the bottom two there, RDX20 and X40, you can see in that first one, collagen 3, it's basically not there, whereas in the control patients, every muscle fiber has a collagen 3 envelope around as part of the epimysium. Okay, so there's no collagen 3 there. But does that actually lead to abnormal muscle? So the next experiment we did was take that dish with the decellularized extracellular matrix there and seeded it with a normal human muscle cell line. We were able to track this in real time thanks to a colleague of mine, James Paget, who was at Cambridge with me, who was doing his PhD at the same time. I happened to run into James in Waitrose, where we were both queuing for the coffee machine when they were giving free coffee. We got chatting about our respective PhDs, and he very kindly said, when I said I needed a way of tracking cells in real time, I've got a lentivirus that can do that for you. Conversations overheard in Waitrose. So the moral of that story, if nothing else, is make friends. But returning briefly to what this matrix does, the muscle, when you grow it on this matrix, is again very disorganized. It organizes much faster and it matures much faster on normal matrix than it does on matrix derived from radial dysplasia fibroblasts. Since I've finished my PhD, my prof has actually gone on to get a full MRC program grant for this, and now has a postdoc and a couple of PhD students working on ongoing work, of which this slide is one of several I'm going to show you. And she's done much cleverer experiments than I, as a mere surgeon scientist, could do, tracking these cells as they grow. And you can see these were slightly Van Gogh-esque live cell tracking pictures here, but the control ones and the co-culture at the bottom is very organized, whereas again, in the radial dysplasia, it's really disorganized. They've also gone on to grow these cells together with what happens if you put control cells and radial dysplasia fibroblasts together. Is it just that the radial dysplasia ones are missing something, or are they actively blocking something? And actually, it looks like they're not just incompetent, they're malevolent. They actively block the control cells from laying down a normal matrix. You get these holes. And when you look back at the histology from the radial dysplasia patients, these holes are there in the connective tissue as well. So it's not just a lab phenomenon. This recapitulates what happens in life and with the messed up fascia that you get in these patients. It probably won't surprise you to know that if you've got problems with the matrix, you have problems with matrix homeostasis, with matrix metalloproteases. So these are downregulated in, or some of these are downregulated in patients with radial dysplasia. We also tried, and I think they've now had rather more success doing this on a slightly smaller scale, to get a 3D co-culture together of muscle and connective tissue. And when you do this, again, the ones at the top, R001 and R002 are the control ones. they've actually managed to produce viable muscle which was sufficiently strong to pull the construct apart, whereas the radial dysplasia ones, the bottom two rows, were reasonably indolent and nothing much happened. And when you look at the co-culture again, all these cells are there, but they just weren't doing anything in the radial dysplasia patients. Now that they've got some more money from this MRC project grant, they've also gone on to look at the what we call proteasome in proteomics, the individual proteins secreted by these cells, and the genome of them. And unsurprisingly, given those earlier findings, it turns out that when you look at the proteasome of these cells, they are producing less collagen 3. Now, collagen 3 is what's called a heterotrimer. It's 3 equal pro-collagen proteins together in a triple helix. Plenty of pro-collagen is being produced by these cells, but it can't get out of the cell. It gets stuck. So there's a failure of collagen 3 trafficking in these cells. And that, again, gets recapitulated when you look at the fancy proteomics, which I won't bore you with. The same proteins also pop up in when you do a screen for the proteasome of the whole population. And when you look at which genes are switched on and which are not, again, on the left you can see blue are the control patients, fairly similar genes turned on. Red, yes, some are downregulated, some are upregulated, because they're different types of radial dysplasia, but they're clearly different and they're clearly more similar to each other, which is one of the most surprising things for such a heterogeneous group of patients. And the genes involved, again, are matrix matrix homeostasis genes like the TIMPs, which are inhibitors of metalloproteases, and the collagen genes as well. Now, this was a limited study. The sample number was relatively small, especially the controls. I did only in vitro culture work, although we've now subsequently got, as I've briefly shown you, experiments using other techniques which have confirmed the findings. And there may be a selection bias in the sense that these are all patients who needed surgery. There was also quite a lot of clinical heterogeneity. There were different ages, different sexes, different conditions, and some of them may have had previous surgery or did have previous surgery. But we've managed to show that radial dysplasia fibroblasts are significantly different to control fibroblasts. The matrix they produce is less organized, and functionally that matters. It matters because it can't pattern that muscle as it migrates into the limb bud. That leads to abnormal muscle development. It leads to abnormal muscle growth. It leads to an abnormal response to the corrective surgery we do. And these differences then highlight the role of the soft tissues in radial dysplasia. So how do we take this from the bench back to the bedside? Well, firstly, it shows us that surgeons like Paul Smith, who've been banging on for years, in his own words, about doing a wide, deep fascial release when you do a radial dysplasia correction, are onto something. The fascia is abnormal, and releasing it is a simple thing as a surgeon you can do. Potentially, in the future, we may have druggable targets, or even more future, gene therapyable targets, so we can modify how these patients respond to their surgical treatment. We're probably not going to get to them at weeks 4 to 8, so we're probably not going to be able to solve radial dysplasia at a purely genetic level. But modifying how patients respond to their surgery, and also being able to select patients for how their fascia is likely to respond to centralization or radialization or free tissue transfer, might help us in more rational patient selection. Lastly, it would be remiss of me not to express some thanks. Firstly, my thanks to BSSH, who funded my PhD, and without whom most of this would not have happened. Particularly to my supervisors, Malcolm Logan, a basic scientist of some considerable renown, who's based in the Randall Centre at King's College London, at Guy's Hospital, and to Bran Sivakumar and Jill Smith at Great Ormond Street, who talked me through all the clinical aspects. Also to my other colleagues at Great Ormond Street, at King's College London, including all many scientists who gave up their time to help a rookie surgeon learn how to vaguely master some of these techniques. At Chelsea and Westminster, particularly Max Horwitz for some of the patient recruitment, and at the Royal Free, also for colleagues there for helping with recruitment. My family for putting up with many a weekend of Daddy's going to be in the lab this weekend, and most particularly to the patients and their families for their generosity in taking part in research and allowing us to take small tissue biopsies, which is always a scary thing to put to a patient when they're already having surgery. So with that, I hope I've shown you that bedside to bench and back again, whether in the context of something relatively esoteric like congenital hand surgery, or in the more common problems many of us will see every day, is a model pioneered by John Hunter, and one that we should still embrace today as the way surgical research should be done going forwards. Thank you very much.
So I think I probably speak for all of us in saying that was an absolutely fascinating exposition of your thesis and how you went about investigating it. Indeed, I think it was a masterclass of scientific inquiry and asking your series of questions and being able to generate those answers. So for me, it wasn't just understanding the what goes on, but why and how it all happens. So it really took that leap from embryology to clinical and populated part of that important bit in the middle of it. And I think John Hunter, who was fascinated himself in embryology, if any of you do visit the new museum, you will appreciate just how true that is, would recognize the tradition that you've followed. So thank you very, very much for your talk, and it's my pleasure to give you the Hunterian Medal, and from this year going forward, you are Hunterian Professor for the year.
Mangled limb perspective from the military and conditions like India and Ukraine. I think this mangled upper extremity is a very interesting topic in the sense of all the things in hand surgery. I particularly feel that this requires on-the-spot decision, and decisions mean everything. I think from the final outcome, what is obtained, I think what this really means is that it depends on who makes the decisions, and it should be followed by appropriately implementing those decisions. And if it is not done, the outcomes become very, very far different from what could be achieved and what is really got. And in that perspective, this achieves a lot of importance. And we have a good set of speakers on this. And to start with, I'll just define as to what we are going to talk at the mangled upper limb. And while we're writing many chapters, I used to find out what's the real definition of a mangled limb. I could best come up with what was given by Campbell Reed, who said a mangled upper extremity has loss of substance and has lost prehension. I think that's a very nice word. There must be a loss of substance. Either it's a soft tissue or a bone, and because of that, the hand has lost prehension. So that also gives us the goal that we need to get, that means to regain function. So we start off with my co-chair, Ms. Stapley, who is going to talk on the initial management of major trauma.
Good afternoon, ladies and gentlemen. My name's Sarah Stapley. My reason for standing here is I was in the Navy for 33 years and was the Emeritus Defence Professor of Trauma and Orthopaedics. So I'm going to give you a quick gallop through the initial management of conflict-type major trauma injuries. So this is my disclosure statement. So briefly, covering adequately initial management of major trauma in 10 minutes is impossible. Hence, I'm going to just provide a very few comments that may give you some thoughtful ideas which can be utilised in the major trauma management wherever and whenever you may be. So this will cover briefly wounding patterns, initial assessment, a step-by-step approach, and planning the next steps. So wounding patterns in armed conflict in particular are different. They're not that complex necessarily, but the numbers of casualties involved is often overwhelming, and frequently you have limited resources. A basic understanding of the different patterns and mechanisms of those wounds, of what's caused those wounds, is absolutely fundamental, and in particular, the principle of energy transfer. Weapon types are generally classified by the amount of energy transfer there is available into directing your tissue you're hitting. So let's look briefly at the gunshot injury. It's 3 areas of ballistics that you really have to understand, even just a tiny amount. Internal ballistics, the behavior of the weapon, the bullet itself. In general, in standard conventional warfare, the concepts are overall similar. The differences being made up of by the size of the weapon, the shape, and its kinetic energy available for transfer. And fundamentally, the velocity at which the projectile leaves the barrel of whatever weapon it might be. The next area is to think about is the external ballistics, and that's the flight of the projectile from the end of the barrel to when it's just about to hit your target. And of course, this depends on how fast it leaves that barrel, whether the weather conditions, whether it's gone through water, whether or not it's hit anything first. As it flies, it loses energy. And the final part is the terminal ballistics. That's what happens to that projectile as it hits the patient or the casualty. So just looking at this, the pictures at the top, so a very small entry wound. So your projectile has hit very quickly, but as its energy has dissipated, it's made a very large internal wound, and its exit wound has, as you can see, is very large. And the bottom 3 pictures demonstrate what you might see if that projectile goes through some medical style gelatin with the formation initially of the trajectory, then the cavitation effect as it passes through the gelatin. And as you can see, that cavity falls at the end, but it will have sucked in all the rubbish from around the outside. So factors affecting tissue injury are its residual, the residual kinetic energy of the projectile, the stability and its entrance profile, the caliber, size, construction and design, and its tissue penetration, and the type of tissue it actually hits. So for example, and I'm not going to go through all of these, muscle and liver have very similar densities, but they react hugely differently when a projectile hits them. So moving swiftly on to blast injury. Blast injury is occurs when a material produces an explosion by its own effect, and it develops a huge shock wave as there is a huge overpressure initially. Behind that overpressure is a blast wind, and that is made as the pressure falls and a vacuum occurs, sucking around it all the types of debris and projecting your casualty across the room. This gives you 4 different types of injury effects, and these include, as you can see above, primary blast injury affecting the air-containing areas such as the lungs, the gut, and the ears. On the bottom right, fragmentation injury. The middle of the pictures, that's a traumatic amputation, which we can't do anything about. And on the far left, burns as a tertiary type injury. So from that, what I want to get over to you is you've got to understand and know the weapon that your injury has come from. You've got to understand the potential injury that might give you, and that will help you plan your initial management. So, initial assessment and resuscitation has to be with a multidisciplinary team for these. And hopefully, if working practices allow, this should be horizontal, via ATLS, for example, and go through all the aspects that are listed here. Specific extremity injury, really consider your time from wounding. Of course, it needs care if the time from injury is over 6 hours. We are all fully aware of this. Full examination is hugely important. Vascularity, neurological status must be documented. And I can only stress to you the importance of documentation, photography, so that later down the line, these patients can be managed consistently. And communication is absolutely the key at all times when managing these patients. Have someone in charge. Feed them the information so that they can dissipate it throughout. Communication, communication, communication. So then we're going to move to a stepwise approach in managing these and your general preparation as you go to theatre. Very obvious and straightforward to everyone in this audience. Prepare the patient, checklist, ensure that you all understand what you're trying to achieve. Positioning of the patient so that all extremities can be accessed at all times. But be careful, please don't put them out at crucifix angles because remember the potential for brachial plexus injury. Using a pneumatic tourniquet, of course, that allows you so much easier to manage bleeding if necessary, and also allows you to see whether your revascularization has helped. Teamwork, teamwork, teamwork. I can't stress to you enough, you can see multiple surgeons working on multiple limbs at any one time. So you have to have a plan. Each person in that team must know their role, and that role then can be managed very quickly and succinctly to an overall positive aim for the patient. So debridement, why do we need it? Of course, we're identifying any zones of injury, decompressioning viable tissue, removing foreign and non-viable tissue, and fundamentally to reduce the bacterial contamination. And that will help us in the very much the long term. It's potentially difficult. It's not quick. It often results in a lot of blood losses. But I can tell you, it makes a huge, huge difference, as you can see with this mangled extremity. So further washout, again, reduces your bacterial count. And of course, your stepwise approach. And I'm not going to go through these. Fasciotomy, nearly always required in high energy. You're going to address the bony injury, preferably simply. There is still controversy whether or not you do the bony injury before the vascular injury. Discuss with your colleagues at the time. Make the decision together so there's no anxiety, and dressing the wounds. If you do have a vascular injury, make sure you put that on the outside of the dressings so that the next set of people to look after that patient knows there is a vascular injury and needs to be looked after well. So planning your next steps. These will always be complicated surgeries. They need often several returns, and we're going to hear all about that next. Use microbiology to direct your antibiotic usage. We always took samples after the end of any debridement and sent to the lab so that they could guide you later. Use of external fixators may be the definitive bony surgery, but they may not. And if you're considering internal fixation, please consider doing that within 14 days. And still involve the multidisciplinary team from day one. And again, I say to you, documentation, photography. I can't stress to you how important this is. And please, may I ask you, don't forget this simple hand injury. We've just reviewed a number of our casualties at 10 to 14 years, and the simple hand fracture that's not been looked after properly has made a huge difference to some. So in summary, understand your injury mechanism, plan your resus pathway, work as a multidisciplinary team, identify your initial management aims, plan your next steps, and communicate, communicate, communicate. Thank you.
Thank you, Mr. Stapley, for this, starting this symposium with giving the fundamental first steps. Now I request Mr. Rayleigh to talk about managing infection, which in fact affects the, untowardly affects the outcome.
Thank you very much. John Penn Barwell is a military surgeon in Oxford, and he was supposed to be delivering this lecture. So I was asked to step into the breach at reasonably late notice. My name is Nick Riley. I am a hand and wrist surgeon who provides hand and wrist service to the bone infection unit in Oxford. I have consulting agreements with Acumed, Arthrex, and Meshworks. We will discuss the principles of managing infection, and I'll touch on the anatomical vagaries that are specific to the hand. We truly stand on the shoulder of a giant when it comes to managing infection of the hand. Alan Carnarvon printed his first book in 1912. And when we take into account that that was before penicillin had even been discovered, let alone used in a human, it goes back to the tenet that the key step in managing infection is a thorough and appropriate debridement. It's obviously key to take a history and to examine the patient. It's useful to have salient information as to how the infection has happened. What is the environment like? Investigations are useful, but certainly in the context of chronic bone infection, blood tests can be pretty normal. appropriately timed intervention in the context of a military conflict should be expedient, but in civilian life, it's sometimes useful to have an awake surgeon doing a thorough debridement rather than a sleepy one doing a suboptimal one. And when I say thorough debridement, what do I actually mean? I think there are 4 key stages to the debridement. So firstly, we want to excise all the dead, non-viable tissue, all the foreign bodies, and the aim is to leave a healthy bed of well-vascularized tissue. When we take this tissue away, it's really important that we sample effectively. It's really important that we try to prove infection rather than disprove infection. So I think sometimes there is a psychology, and I've experienced this, where I don't want a wound to be infected. But actually, what you want to do is to prove there's an infection there, and then you can manage it much more effectively. So the top right image is a sampling tray that we have in Oxford. We use fresh instruments each time we take a sample so that there's a reduced risk of contamination. They go straight into the pot, and they're sent off to the lab expediently to reduce further contamination of the specimens. We then do a thorough lavage, and we use normal saline or we use sterile water. There's no place for pulse lavage in infected wounds. All it does is propagate debris and infection along fascial planes. We don't recommend the use of disinfectants like chlorhexidine. If something is likely to kill a bacteria, it's likely to further traumatize the bed of the wound, which you want to be healthy. And then finally, and this is a really important step that's often not particularly well executed, is dead space management. For a lot of us, the first operation that we do is lancing an abscess, and we're taught that we need to manage the dead space. I remember putting the ribbon gauze in with that stuff that looks like custard. So you have to do that in the context of more complex wounds. In the bottom left image, you can see that there is antibiotic-eluting bone substitute in the wound. And that's helpful, it's valuable, it delivers local antibiotics direct to where the infection is. I also think it's important to state that the reason there's a plate in there is because I was happy that the wound bed was healthy. We shouldn't use internal fixation until we're absolutely certain that the wound bed is healthy. And then the final step is to consider soft tissue closure. In the context of military wounds, this is unlikely to be possible at the first stage. Negative pressure dressings are helpful, but shouldn't be considered definitive treatment. Because military wounds are much more contaminated, they often need multiple debridements. In a civilian context, it's useful to try to avoid the repeat debridement without a definitive plan, because all you'll do is make the wound bigger and deeper and make the reconstruction more difficult. There's no substitute for a good first debridement. And I personally feel that the individual executing the first debridement, rather than just writing second look on the operation note, should really deliver a plan of what that second operation should achieve. It's useful to plan definitive treatment early. You might not be able to perform it at the second look, but it should be planned for. Skeletal stability is key. So it's key in the context of treating infection, because a well-vascularized wound which is stable will be able to control infection much better. But in the context of the military patient, skeletal stabilization also optimizes their physiology. Often with a contaminated wound, we'll use an external fixator, either as a temporizing measure or definitive treatment. But as I've said, once the wound is healthy, internal fixation is a useful option. And only now have we talked about antibiotic use. It's important to separate prophylaxis and treatment. It's important to separate empirical treatment from definitive treatment. What you want to be able to do is to give your microbiologists the best opportunity to target an antibiotic at your patient's bacteria. That'll reduce resistance, and it's good antimicrobial stewardship. The AVIVA trial has demonstrated non-inferiority of intravenous antibiotics versus oral antibiotics. So wherever possible, following liaison with your microbiologist, it's reasonable with a susceptible bacteria to convert to oral antibiotics. We're also seeing in the context of hands that you can probably get away with shorter durations in the context of osteomyelitis. I'm sorry, my slide's not advancing here. So when we come to talk about the idiosyncrasies of the military, we need to be aware that each theatre of war is unique. Afghanistan is a different place to Gaza, so we need to take this into consideration. The injury patterns are much more severe than we see in civilian life. They're much more contaminated, there are much more blast injuries, and they've got a bigger soft tissue component, hence the requirement for further debridements. The environmental pathogens are different to what we're used to, and antimicrobial resistant patterns are different. There is a reason that different countries have different prophylaxis for prosthetic joints, and that's because their bacteria are different to ours and have different resistance patterns. So this is also true for the military. It's important to recognize the deep spaces and to ensure that they're appropriately debrided. These spaces can often communicate with each other, and a suboptimal debridement will just delay the recovery of your patient. It's important to remember that these two bursae will connect and can possibly lead to a horseshoe abscess in the space of Perona. And finally, my take-home messages are that there is really no substitute for debridement. If you suboptimally debride something and give antibiotics, it is unlikely that you will be able to treat infection expediently. Talk with your microbiologists. They're experts for a reason. We see lots of problems when surgeons play with antibiotic use. It's important, particularly in the hand, to know your anatomical vagaries. And as I've stated, I think the key thing to take from today is that antibiotic use should be used very, very carefully. Thank you very much.
Thank you, Mr. Reilly, for the wonderful points about the fundamentals of using antibiotics and how we should take care of infection, because we consider, if at all there is one thing which adversely affects the outcome, I think it's infection. Now I request my colleague, Dr. Praveen Bharadwaj, to speak about skeletal stabilization in such mangled injuries.
Okay, good afternoon, everyone. Mangled injuries can be very intimidating at times and quite challenging. You can have double-level injuries, multiple-level fractures with skeleton totally shattered, bone loss, comminuted fractures. There is no bone at all sometimes, such as severe injuries. Avascularity of the multiple fingers. So you will have a lot of work to do. And sometimes the hand would totally shattered and you will not know where to plan your skeletal fixation. There are a lot of things which we need to do for a mutilated hand, but my section would mainly concentrate on skeletal stabilization. And I have been told to answer these 5 questions. So now how we go about it? When you have a mutilated injury, you many times would be in the early time of your training and you would be doing it maybe first time or after some amount of experience, but we should not panic. First thing is to debride it well and then reassess the whole situation about the vascularity and then go on to the skeletal stabilization. It is basically to get the structure of the hand right, which will lead to a good form, and form will automatically translate to function. So it is something like a jigsaw puzzle. All the things are shattered here and there, but we need to just put it right in good position. That is about the skeletal fixation. And then we can build it on by doing a good tendon repair and then vascularity and other flaps. Before we go on to skeletal fixation, a good X-ray is a must. Most of these mutilated injuries would come referred from outside. The hand would be wrapped in a bandage or in a plastic bag this kind. So if you just take an X-ray like that, you would not see anything. So we cannot plan the skeletal fixation. So we need to take that hand out, give a on-arrival block, and then place the hand correctly and take an X-ray so you can very well plan your fixation and understand the injury quite well. So that is a very important thing which is not very commonly done. And this is one concept which was proposed by our hospital and is widely used these days. The skeletal stabilization, though one can choose any of the methods, but it needs to be a bit quick. We cannot take many hours to fix the fractures. It should be stable enough to allow immediate reconstruction in the form of tendon repairs, flap cover, or revascularization. It should not hinder the flap cover options and should be comfortable to the patients. At our institute, we mostly use K-wires for the fingers till the metacarpal level, and proximal to that, we go for plate fixations. A patient like this would require a combination of wires and plate. This kind, we have just put these two K-wires in the metacarpal. This gives enough amount of stability, and also it can be extended to stabilize the wrist joint, which would be unstable in many of these cases. Internal fixation has been done for the proximal fracture. Now, if we see the wire does not come in the way of the flap, it positions the hand nicely, and obviously you are going to get a good result because your initial structure and form has been nice. Now, many times there would be a comminuted fracture, there would be bone loss. One would not understand how to place the bones in different positions. So the basic mantra is the hand should look like the hand. A very disorganized hand, we have not even seen in the C-arm how it looks, but the center picture, if you see, the hand looks in good position, and it must be good because the shape is looking proper. So the basic mantra is the hand after fixation should look like a hand, and then the half work is almost done. After good debridement, there is no hesitation to do an internal fixation because if the debridement is well, internal fixation is quite safe. A very shattered fracture like this, a lot of implants have been put inside, which allowed early flap cover, and everything is healed quite well to get a good outcome. Yeah, so if the initial debridement is good, internal fixation is not an issue, and it will result in a good result. I think the slides not progressing. Sorry. In some cases of forearm fractures, if there is a segmental loss of bones, one easy bailout is to do a one-bone forearm fixation where the ulna forms the elbow and the radius forms the wrist. It really simplifies the reconstruction and gives a very good result because the hand, the wrist is stable and the elbow is mobile, and patient is going to use this hand quite well. When we are planning skeletal stabilization and treatment of the mutilated injuries, the final aim is to get a good function and not to get a good X-ray. So two things which have a detrimental effect on the eventual function of these patients is often they develop a first web contracture, often they will have a stiff MCP joint in extension. So right from the day one itself, we need to have preventive measures for these two things. One good way is you can put a spacer wire between in the first web, or whenever the fixation is being done, there can be a wire going across the CMC joint, keeping the thumb out in abduction. You can even have a wire going from the first to second metacarpal, but main aim is the first web should be separated out. The MCP should be in flexion. When we are passing the wire to the metacarpals, we should keep the MCP joint flexed and then pass the wire so that the MCP joints are not kept in extension. If these two things are taken care of, the overall result would be much nicer. Whenever there is very severe mutilation, we need to have another mantra is to preserve as much as possible, with the eventual aim of thumb meeting the finger. If thumb meeting the finger, it would immediately translate into a better function. Multiple level amputations like this, we can think of any of the best one to put it to the index finger in such a way that thumb meets the finger and it will translate to function. An injury like this, which would look as if nothing is possible to do. Bone is scattered. Just a little bit of planning, replanting this little finger on correct position in such a way that thumb meets the little finger will do the trick. When we are doing a skeletal stabilization, we can give an intentional rotation of the metacarpal of the little finger towards the thumb so that it comes and meets the thumb, and it will translate to a good function. Just with 2 digits, this old lady is able to perform all the activities and did not require any further reconstruction. So that was only one single operation. Not only very major injuries, for small things when you are doing a skeletal fixation also it is very important. In the injury like this, it would immediately look as if you can just close the flap. But look there is a small bone piece of the base of the proximal phalanx. If we are able to preserve that, you can just put a bone graft over there and get much good result with a mobile MCP joint. So when debriding, be careful about the small bone fragments which form the joint. Also, metacarpals and the wrist, our main important thing is to have stability. So mobilize the fingers and stabilize the wrist. In case more damage is there, we can put a fusion of the wrist primarily and have the fingers moving, and that results in a good outcome finally. Bone gaps can be managed primarily itself. So we generally put a bone graft, that is the iliac crest bone graft in the fingers and metacarpal just at the time of flap cover, and you can get a good union. However, overall, if the hand stability is there, the bone grafting can be done even secondarily, so there is no issue in that, and you can get good union. If the bone loss is in the proximal part, there we generally prefer a free fibula. So this is the flap cover done for the elbow, big defect there, and a free fibula done, get a good outcome. So what is essential on day 1? We need not do all the things on day 1, but yes, debridement, the most important. To restore vascularity, have a stable skeleton. Basic soft tissue cover if the vessels are exposed, otherwise it can be done later. If tendons and nerves are approximatable, we can approximate them. An example here, totally shattered hand, debrided, put an external fixator. External fixator is good in children's and also around the joint where we want an overall stability of the joint. At next stage, soft tissue cover, it should be done earlier the better and not later than 5 days. This patient, we could get a good result in him. He is still not finished reconstruction, but he is able to do all the activities still. Tendon reconstruction to get his fingers out can be done anytime. So I hope I have answered to all these questions. Damage control, surgery is fine. You can do most of the things at one stage, but stage reconstruction also is quite a successful way to do if you are not comfortable to do all the things at one time. So just to end with an example, this patient was 12 years of age at the time of surgery, underwent 5 secondary reconstructions, and finally she became a doctor. Thank you so much.
Thank you for the excellent talk. I'm now very pleased to ask Mr. Dominic Power from Birmingham to provide the Birmingham experience of the role of internal fixation.
Thank you. Good afternoon, everybody. Could I have the first slide, thanks. So I'm a hand surgeon from Birmingham, and as a new consultant at the start of my career, we were inundated with a huge number of military injuries alongside our civilian care, and it was a traumatic time personally. We were swamped. When we reflect back, we had very little data capture, and it's actually quite hard to put together a talk like this where you don't have consistent outcome measures. I'd like to thank the whole team. This is an amalgamation of pooled efforts and cases, and what I'm going to do is just illustrate some of the points that have already been spoken about and maybe bring out 1 or 2 more. So this is Birmingham. This is the hand centre. We've got a few other services there as well. It's a military centre as well as a civilian centre, which gives it a unique flavour in terms of what we do. Now, learning from conflict is very important, and conflict management of casualty has changed with a chain of care that's now very rapid. And what we've learned from previous conflicts is early evacuation of the the injury that cannot be returned to action expediently, actually early debridement and stabilization of the casualty and transfer back to the Roll 4 facility in Birmingham was the key to minimizing the risk of infection and complications. But we were exposed to a whole series of injuries, including the IED blast injury, which is far more severe than anything you would see in civilian life. Although the worldwide geopolitical instability means that we may all come across these sort of injuries in our practice at various stages. One of the things in warfare surgery is early rapid evacuation of the casualty, with effectively a flying intensive care facility to take the patient back. In Afghanistan was to the Camp Bastion facility, and then expedient transfer to the UK. Patients would arrive with these complex injuries, be stabilized on intensive care, and then back into theatre at the same time for a multi-specialty approach to assess the injury and decide on management. It's credit to the surgeons working in the difficult environment that these wounds were so well debrided, and we were often able to start making our definitive plans at that first planning operation. Some of the injury patterns that we started to see were for the unmounted patrol with the IED blast, with the ulnar-sided injury to the ulnar forearm, loss of ulnar digits, ulnar-sided forearm and elbow open injuries, as well as sometimes fragmentation wounds where the body was not protected by body armor, and these would include through shoulder and through hand, often central metacarpal injury and loss. And of course, we also had more isolated injuries with gunshots, and those casualties come with slightly fewer challenges than perhaps the multi-limb injured IED blast. Again, it was a difficult time for us, but it was actually the foresight of Jonathan and we who approached us and said, can we not, in terms of what's going on in the climate at the moment, learn from the lessons at the time? And with Sarah's direction, we rapidly assembled a group of individuals to try and put together these two papers, of which I'm very proud, which summarize the early management and then the later reconstructive strategies. And these were open access available for our colleagues across the globe and in Ukraine. These papers just allowed me to reflect and think about some of the lessons. And if you actually look at some of these lessons, they've already been covered today. Early removal of an external fixator, internal stabilization, robust soft tissue cover, surveillance. But it comes back to some very core principles. And the principles, or my top 10, were these. But I'm just going to concentrate on what's needed for safe internal fixation. And that's debridement. So early, adequate debridement is the key to infection control. Optimizing the patients. These patients will have multiple injuries, and that optimization is pain, nutrition, and so on. Don't fear internal fixation. Internal fixation is our friend, particularly in the hand where we want mobility. An external fixator often creates a slightly mobile situation, poor control of the skeleton, and a liability to persistence sometimes of infection, as well as compromising flap cover and rehabilitation. And you need robust soft tissue cover, and that again comes with its challenges. So these are the sort of patients that we were seeing, the complex injuries. Debridement is the key to infection prevention. And wounds are generally progressive as long as you have a plan in place and you move the patient forward on their journey. And you can go from very complex contaminated wounds through to stable soft tissue envelope. And in this case, you can see external fixation has been used to stabilize the pelvis. Don't fear internal fixation. This is an isolated special forces injury with an RPG fragmentation with vascular injury, neurological injury, and bone loss. But this was treated very aggressively with internal fixation, vascular reconstruction, and a contralateral radial forearm flap, all within 2 to 3 days of injury, and the patient returned to active duty after a couple of years. This is another isolated limb injury with a high-energy neurovascular injury involving the infraclavicular brachial plexus, the median nerve, radial nerve were taken out, as well as a vascular injury. But with infection control, it was a chronic wound when it arrived to us. Infection control, debridement of the bone, conversion of the external fixator to internal fixation, and then early nerve reconstruction. This patient did very well. Just a word on soft tissue cover. There are some nuances of care in the military casualty, particularly with an IED blast, with the need for vascular access in the groin sometimes to control life-threatening hemorrhage. The groin flap may not be available for hand reconstruction, and as such, we often resorted to chest wall or abdominal wall flaps, random pattern flaps. But we also use fasciocutaneous flaps to good effect to cover critical metalwork, then skin grafting the residuum, and using topical negative pressure dressings to stabilize wounds until they were granulating sufficiently for skin grafts. Of course, we have to talk about bone management, and sometimes with composite tissue loss, it's important to have a composite reconstructive strategy. Obviously, the skeletal shortening is quite effective in some sections of the upper limb, as you've already seen, creating a single bone forearm. But if you bring in a vascularized tissue, you need the patient to be optimized, and the risk is if yours have a composite flap and you lose your flap cover, you've now lost your donor as well as your recipient. So sometimes we end up stabilizing skeleton, shortening the skeleton, getting soft tissue cover, and doing early bone graft. Sometimes we'd need to do vascularized reconstruction. So this is the case we presented earlier. I don't need to dwell on that one. This was reconstructed aggressively, and the patient did very well with no infective complications. Isolated injuries or fragmentation injuries using bridge plate facility with locking plates is quite effective to get some skeletal stability. And then this patient had a radial forearm flap to cover the soft tissue defect. This is a slightly more severe injury. And if you have a look at the soft tissue components, we had a non-viable index finger, but we also had a gunshot wound that went through the ring finger MCPJ. There was also, just to make things more interesting, a humeral fracture with a radial nerve that needed grafting. And when you see the soft tissue defect and damage, you realize this is actually quite a challenging wound. So sometimes you have to be a little bit innovative, things that you haven't tried before. And in this situation, we did internal fixation, fillet flap of the index finger, and then a vascularized transfer of the residuum of the index metacarpal to reconstruct the ring metacarpal, and then soft tissue closure with local flaps. This went on to heal pretty well. Obviously, the hand won't have the full roll-up function, but there were 3 functioning digits. This is another case of thinking outside the box. The index finger was to be lost, but we used a vascularized bone Fouché flap, Fouché Plus we called it, to reconstruct the defect and restore the length in the thumb to good effect. But sometimes the injuries are just something you can't ever plan for. And this particular situation was stabilized initially with external fixation, serial debridement, some planning, a rather homeopathic wrist fusion plate, and some K-wires while we were asking friends for advice. And then eventually the patient went on to more extensive bone reconstruction with a derotation osteotomy of the thumb to affect the thumb coming down for some sort of opposition or key pinch function, as well as iliac bone graft to reconstruct the gap between the missing metacarpals. Throwing through fragmentation injuries to the hand are very challenging to deal with. Like-for-like replacement is very difficult. We did come up with some innovative strategies using serratus flaps with ribs, and we did this a couple of times to good effect. This was unfortunately a slight problem initially with over-lengthening of the metacarpals, which required subsequent revision surgery. And the second case that I was involved in unfortunately developed a pythium infection and developed mycotic aneurysms of the vascular pedicle, and unfortunately the flap was lost. So these patients come with significant challenges, but some form of functional reconstruction is possible. Finally, just the last few seconds, a couple more cases. This was a non-salvageable limb, but a sensate palmar flap was used to resurface the end of an amputation stump, and a vascularized pedicle transfer of the radius to lengthen the ulnar residuum was useful in creating a forearm amputation stump. Complex elbow injuries need complex reconstruction, and after debridement, fibula comes in handy. This was a fibular flap that was used with soft tissue cover for the elbow, and the patient went on to get some useful elbow flexion. And of course, this can also be combined in bone loss to affect an elbow fusion and an arthrodesis. So the last summary slide is, despite these complex injuries, we had actually relatively low loss of internal fixation and infection rates. It comes down to all the things that we've spoken about so far. But the last thing to remember in our military patients is the last 4. These are young, fit, motivated patients who've got good rehabilitation support around them and a good nutritional status and bone stock to start with. But thank you very much.
Thank you, Dominic, for the excellent presentation. I'm now delighted to ask Professor Sabapathy to discuss soft tissue management, including burns in these complex injuries.
Thank you so much, and I would like to take off from where 2 of my previous speakers have said. In Praveen's talk, he said in a mangled injury, at the end of it, the hand must look like a hand. I think that's our motto. And in Power's talk, he said, don't be afraid of putting an internal fixation, provided you debride well. I think that's the two things with which I would like to talk, and I'm happy for the slides. And injuries, mangled injuries that you could have, either you could have it as the soft tissue loss in the hand, or you could have in the forearm, or you could have it in the arm. I think the region could be different, and the amount of extent of things which you have to replace could be different, but the principles are the same. So in that, anything there, you need to have certain goals. I think what should be the goal whenever you treat a mangled injury? I think it's 3. First is that you must achieve soft tissue infection cover as early as possible. Second, there must be no infection, and the cover that you provide must facilitate future reconstruction. I think that's the 3 things which you should do when you first see the patient. So here, as was previously told, the first requirement is radical debridement. I think what normally we'd say is that we remove dead tissue, remove foreign bodies. Instead of that, I always used to tell residents, at the end of the surgery, you must think that everything that you leave behind is viable. One is the definition we are telling about what we remove. Instead of thinking as to what we remove, I think we should get to the next stage of thinking what we leave behind. I think if we think that everything that I have left behind is viable, that means we have won the job. So with this we are debrided well, and after that we have provided a flap, and then she has done well. The question number 2 is, when do you debride? So my question is as soon as they come, or as early as they come, provided they are fit for surgery. While there is no robust evidence to support that you have to within 6 hours you do, but then what shouldn't happen is that you mustn't make debridement an elective procedure. I think that we need to really take it on. So for example, in this case with Praveen Shore, this came as a really very bad injury. But then you need to reach a stage like this. It doesn't really matter how much of bone is lost or what is lost, but then you really must do it. But it's got all the principles. One, the hand looks like a hand, and then you have placed it nicely, and then we have provided a flap, and after that in the second stage we have provided a non-vascularized iliac crest bone grafts, and then she has done very well. But if you really ask me now, is it the flap that make the difference? No, it's the debridement before the flap cover that essentially made the difference. Do we do single-stage debridement or multiple-stage debridement? I think that's the next question. I think in our center we feel that barring electrical burn injuries, I think in most cases you should be able to do a single-stage debridement, should be enough. In our experience, 90% of the times the single-stage debridement is enough. But then we are not against serial stage debridement. I think going a second look, I think absolutely we are not against it. But it's only a question that we should be able to do that. But if ever, anytime you think, I'll come back again, there is always, all of us are human beings. I think what we tend to do is, I'm going to come back after 48 hours. I think, why not? I think we should look at that, whether it should. But if you really think, this is my only chance in my lifetime, that means, what happens is your mindset is a little different, and then you do a better job. Then when do you do a soft tissue cover? The answer is as early as possible is the answer, and certainly before infection sets in. The cover is an emergency if a vascular repair sites, veins, or nerve graft sites are exposed. In the rest, if it is not achieved, primarily we hope to get it done within 48 hours, that's the aim. And certainly before 5 days, I think that should be the goal in any of the units. How about VAC? I think what's the principle, what's the role that we have in VAC? I think VAC is a great option. I think it's a great modality, but I think it's very useful only in most of the times in polytrauma. We may use VAC in lower limbs, but not in upper limbs, where when you use VAC, it's not a question of VAC mustn't be used as a matter of convenience. I think that's the most important thing. We use it in polytrauma when the general condition does not allow the soft tissue cover surgery. In the upper limb, we use it very less, and because we really don't want to form any granulation tissue coming up, I think that's the reason. Because we need gliding surface or remote. Then which flaps to use and what are the favored flaps? In upper limbs, we use skin flaps. Whether you've used a pedicle flap or a free flap, I think that's not really a question, because you should do whatever you are very comfortable with. I think that's the thing, because it must hit well. I think it must succeed, that's it. In our experience, we have found there is no difference in the incidence of infection and the ultimate outcome between free and pedicle flaps. I think what really has mattered is the quality of debridement before the flap cover. I think that's the only thing what has mattered. And as far as the flaps are concerned, I tell people, this repetition is the mother of skill. You please do whatever you are happy with, but then please do them early and please do them well. So then next question is, whenever you do a soft tissue cover, you must work with the end in mind. I think when you see a patient, you should really ask him what's his job. And I always think him going back to his job. And then I think, how will he go back to his job? I think that's the way I think. I think you have to work with the end. The end is that he has to go back to his job. So that means working. So you have this chap. He works in a multinational company. Actually, it's a double hand injury. Other hand is a total amputation. I think we replanted the other hand. This is the right hand, and the left hand was the total amputation which was replanted. But then if you see this hand, he requires a soft tissue cover. But then the soft tissue cover is not the point. He requires a thumb. I think that's the point. So here you can't polysize, and the thumb has gone at the level of the carpometacarpal joint. That means you need anything you reconstruct, that means you have to come from there. So how will it come from there? So what we've done is we debrided, we are given a graft for the area, and then the only possibility we think is the toe transfer. So that means we need to give a toe which has got a metatarsal. So that means the flap that you would give could also accommodate a cover for the metatarsal. So that means you are given a groin flap, which is pointing in the direction of the thumb. I think that's very important. I think it is the pointing in the direction of the thumb we are given. After that, we are taken a toe, second toe with the metatarsal. And then you see how he does it. So we have made the other fingers do well. And then after that, the second toe. He is able to have a good grasp, and he's also having a good pinch, and he is comfortably writing it. So this is very important, because this has been made possible because on day one we thought, how are we going to get him back the thumb? I think that's very important. Otherwise, what will happen is you will give a small cover which will not facilitate a toe transfer. I think that's the point. So the same thing applies. So most of the times, it's not the toe, but then most of the times they will all require tendon transfers to make them functional. So here you find as a state hockey player, he had an accident, everything, the whole of the extensor compartment has gone. He requires a very major flap, but then we also understand that he will require reconstruction of his extensors. So what we have done is then how do we get his extensors back, because proximally the muscles are not there. It could only come up by a FCR or FCU transfer to the opposite side. That means the pathway of the transfer must have a flap. So when you plan a flap, we have planned it in such a way that the pathway covers the flap. So now after the FCR transfer, and it has been transferred with the fascial lata tendon graft, which has been made into slips at the appropriate place, divided into 4 slips. So from a hockey player, he became a hockey coach. But then this has been made possible because we had thought what will be the end in mind. The pathway of the tendon transfer has got a flap. So now I come to the last part of the talk is the thermal burns. I think burns to the hand, even if it is a single finger, I think it's a major injury. So whether it's a small injuries like this, where you shave them and graft them immediately, I think you get an excellent result. Or if you comparable to mutilated hand injuries, I think what could be compared in burns is the electrical burns injuries. They become a real big major challenge. For example, if you see this individual who is amputated on one side, and the other side has got a very major electrical burns. And if you see a close-up, you will find that means everything has been lost. So I think that when you debride, this fellow requires serial debridement. You cannot have one single band debridement, it cannot go. If you do a single debridement, you run the risk of losing the hand. We do not know the collateral circulation, how it is going. So you require this, and we serially debride it and give him a big bulky anterolateral thigh flap we are given. And again, now I'm working with the end in mind. That means your thumb has to meet the fingers. I think the next mantra we have. At the end of the reconstruction, the thumb has to meet the fingers. So here you find the first web space is very narrow. He has had a free flap he has had, and after that we are given a groin flap we are given, which is given for the first web space. And this one is simple way of we do it. We draw 3 lines and tell the attenders, you just have to match the 3 lines. That means, almost always, 100% becomes okay. There's a very simple way of maintaining the flaps. So a free flap, and after that a pedicle flap. And then we have done a nerve grafts. This is one way of pulling out the nerve grafts. And we use the fascial lata. We extensively use fascial lata from the proximal side. We divide it into various slips. And then we have done all the tendons have been reconstructed. And you find that after the time, so we are given a prosthesis for one side, and then is reconstructed, the right side has been reconstructed. And you find where we started from, if you find now he has got a pinch and a grasp. So because now we have worked with the end in mind, we have found the thumb has to stay in a place, and in the place where the thumb goes, the fingers have to go meet. So that should be all. So to conclude, the principles that you should have is that soft tissue cover in a mangled extremity is important to prevent infection and preserve critical structures. Radical debridement is the key to success. You must cover the wound as early as possible, preferably within 48 hours and certainly within 5 days. Choose the type of flap cover based on future needs and always work with the end in mind. And there is no, I don't think you need to worry whether you're using a groin flap, abdominal flap, or a fancy free flap, thin free flap. I think that doesn't really matter because there's no difference in functional outcome with either free or pedicle flaps when used as cover. Thank you so much, ladies and gentlemen.
Thank you very much, Raja, for a fantastic talk. Now it gives me great pleasure to introduce Audrey Lusak, a hand and nerve surgeon from Kyiv in Ukraine, who's going to talk to us about managing nerve injuries in severe upper limb injuries. I think we have a pre-recorded talk, but Andre is online and will be available for questions. Are we able to play his talk, please?
Hey, dear colleagues, and thank you for inviting me. Just like a Great Britain during the Blitz in the World War II in 1940-1941, Ukraine is experiencing almost daily bombing of our cities, while our soldiers are sacrificing not only their health but also their lives in the fierce battles for the protection of their homeland. Specifics of the warfare with use of modern military equipment determines the severity of injuries. Timely and adequate medical care at all levels is a guarantee of preserving the quality of life for such soldiers. Out of 1,014 patients with gunshot injuries of the extremities who were treated in our department, 324 patients, it's about 32%, were diagnosed with the peripheral nerve injury, mostly of them upper extremity. Shrapnel injuries prevailed, 78%, and caused significantly more injury to the surrounding tissues. About 45% of injuries were without nerve defects, and the average size of the primary nerve defect was about 5 centimeters for the upper limb and about 6 centimeters for the lower. Gunshot injury can cause not only the direct nerve injury, but also damage to the paraneural tissues that leads to the dense scar formation, injury of the nerve microcirculatory system that leads to nerve ischemia, possibility of neuromuscular junction disruption, and also the direct or indirect target muscle injury. Features of the gunshot nerve injuries are frequent indirect injury of the peripheral nerve by the shock wave, which caused the conduction block, formation of the primary nerve defects in the case of direct nerve injury, formation of the tissue fibrosis that leads to the secondary compression, presence of various types of peripheral nerve injuries in one nerve, mixed injuries, and also injury of the same nerve in a few different levels, like in this photo at the level of the elbow and the wrist. Timing is crucial in the nerve surgery, but in the gunshot injuries, perfect timing is from 3 weeks up to 3 months. Before this time, it is not possible to determine the depth of microcirculatory changes in the damaged nerve, so we cannot understand the true nerve defect. And after 3 months, the chance of good function result begin to decrease. By this time, it is desirable to reconstruct the defects of the soft tissues and skin with different types of flaps, eradicate the infection, and achieve final fixation of bone fragments. We developed a treatment algorithm that, based on the time after the injury, acute injury, or the chronic injury, and also the presence of nerve defect. There are a few clinical cases. The first case is a Marine that have been injured during the defense of Kiev. He has the injury of his ulnar nerve. So it's the acute injury, nerve is in the wound during debridement, and we find an injured nerve, mark the epineurium, and perform the primary neuropatization, just like the distal neuropatization of the ulnar nerve with a branch of the anterior interosseous nerve to the pronator quadratus. He's back to the front line and helping liberating the Kherson region. This is his hand function, and he came back to us after 1.5 years, and we restored the ulnar nerve to restore the sensation of the fifth and fourth fingers by grafting. The next case is a young man, soldier, who was injured at the elbow. He has a median nerve injury that was confirmed by sonography. He has a chronic injury, nerve injury. We go for the revision and we find the nerve defect. So we perform the nerve grafting and lipofilling to restore the mesoneurium. This is his result after the 8 months after the surgery. So in conclusion, we can say that violation of blood supply develops not only in the nerve, but also in the paraneural tissues, which lead to the scar formation. There is a possibility of multi-level or mixed variant of nerve injury. Optimal timing is from 3 weeks up to 3 months after the gunshot injury. And the terms of nerve regeneration are significantly extended because of the violation of microcirculatory system of the nerve. Thank you for attention, and don't forget to support the Ukraine.
Now I'd like to call upon Dr. Rajendra Negate, a good microsurgeon from India. Currently, he's the president of the Indian Microsurgery Society as well as the Asia Pacific Microsurgery Federation.
It's really difficult to speak when my mentor, Dr. Sabhapati, has spoken, and that to people like Dominic and Praveen has spoken already about it. But I'll talk about some mutilating hand injuries distal to the wrist joint. So what is mutilated hand? If you see the literature, this paper by Paco Pinol describes different types of hands. But I think the last three, the crippled, mutilated, and metacarpal, they can all be considered as the mutilated hand. And a simple definition of a metacarpal hand has been given by the type 1 and type 2 by Fuchan Wei. However, I like this definition which Dr. Sabhapati always says: the mutilated hand has suffered a severe injury with loss of substance and has been lacking prehension. I think that is the best to describe mutilated hand. So our approach to manage mutilated hand is in acute stage, adequate debridement. There is no need to describe about it because already speakers have spoken about it. A salvage, whatever you can salvage by either revascularization or a replantation or a heterotopic replantation is best. And think about the soft tissue reconstruction as a primary stage or a definitive step. For a delayed presented patient, many times we get them as a secondary stage. So secondary procedures to improve the function are very important, and toe transfers for finger reconstruction or a thumb reconstructions form the mainstay of treatment for mutilating hand injuries. So let's say some acute injuries like this. It is better to avoid mutilated hand by replanting these fingers. And we did this, but we could save only the right hand fingers, not the left hand. Somehow, his hands were like this. He had an excellent function, so he didn't come for the toe transfer. Otherwise, we wished to do toe transfers for his left hand. But because he had thumb and the little finger, he didn't come for any toe transfers, and he is very happy with the treatment. This was a student of 6th standard with right hand firecracker injury. He had avulsion amputation of the thumb and avulsion amputation of the ring finger. And it's very important for a 6th standard right-handed boy to salvage these two fingers. So the problem was thumb and ring of finger. So this was an on-table post-op after thumb replantation and a ring finger revascularization. And however, there was a dorsal defect with gaps in the dorsal veins. So the transposition flap from the dorsum served the purpose of flap, as well as the veins in the flap were used as the conduit as the recipient veins to salvage the thumb. So he has a near normal hand, and in smaller defect, feasibility of local flap should be ruled out. He has an excellent function after the surgery. So he had a flexion contracture of the ring finger with radial deviation. So you need to do secondary surgery. We did the good tenolysis, and he had a final result like this. He had an excellent flexion of the fingers. So another factory worker with left hand machine crush injury, leading to devascularization of the thumb and amputation, subtotal amputation of the index, the middle, and the ring. So you need to keep calm. As Praveen always says, that don't panic. The thumb salvage gets the priority. So it needs a good debridement, revascularization, and will probably need a flap cover because there is extensive crush on the volar aspect of the thumb. And the index finger and middle finger, however, not salvageable because the extent of trauma was too big. So can the amputated middle finger be used for heterotopic replantation of the ring finger? And this will support the little finger to create ulnar post to augment the function. So that is what we did. And this is after the revascularization of the thumb, the tendon repair, the pulley repair, and the ring finger is replanted. The middle finger is replanted on the ring finger, and he has a defect. One of the prime important is you have to cover it with the flap because the tendons and the vessels and the nerves are exposed. Secondly, whenever you have an injury in the web, it has to be covered well with the flap cover. Otherwise, you will have a first web contracture. So many times when we are operating these patients under single block anesthesia, we use a lateral arm flap. It can be done in the same regional anesthesia, and it is quite thin in the manual laborers, and it has got consistent anatomy. And this was the on-table post-op. The non-critical area was covered with the skin graft, and you can see a fantastic good result, and this was his function at the end. He has a good span and a good range of motion in the fingers. This is a patient with left thumb subtotal amputation, index finger total amputation. So all the three fingers were good, but then it is very, very essential to salvage this thumb. Otherwise, it will be difficult. So you need to do a good debridement and revascularization, but whenever necessary, an emergency flap will salvage the replanted thumb and fingers to achieve a better function, and that is what we did in this patient. This was a patient with index finger and thumb avulsion amputation. So index finger volar defect was there. And in such situations, after the debridement, for a preparation for the toe transfer, we prefer to do a groin flap. He needed an extensive groin flap because the palm was also covered, need to be covered. And you always need to avoid the first wave contractures in these patients. And groin flap achieves the same result as the free flap, as Dr. Sabapathy said. And you can see one thinning of the flap. The patient was prepared for toe transfer, but he was so happy with this result that he didn't come for the toe transfer because it suffices his function. Another patient like this, bad injury, but then you need to think whether this hand can be salvaged and whether function can be given. So we did an anterolateral thigh flap. While inserting the flap, you need to insert in such a manner that you create the ulnar and the radial post so that you can do a toe transfer on this. But afterwards, when this patient was able to use it as supporting heart, this also didn't turn up for the toe transfers. And many of our patients, if they are using hand partially, they don't turn up for the toe transfers. There are patients who present secondarily. This was a patient, a defense personnel. He had a blast injury, loss of index finger. And you can see he doesn't have a great hand function. He has a first wave contracture, a flexion contracture of the thumb, flexion contracture of the middle finger, and overriding of the fingers. So you need to plan a good secondary procedure for this. So as I said, the first priority is releasing the first wave to have a good span and good grip, and release the middle finger contracture well. So we use a very thin skin flap in certain patients. It is almost 5 millimeter thick. And primarily, when you do this, it gives an excellent result. We always fix the thumb with the K wires to maintain the position. And you can see a final result, a good span, and he has an excellent function. His middle finger contracture is also released, and he has an excellent function in that. So the toe transfer, as I said, forms the mainstay of finger reconstruction, and it is one of the commonest secondary procedures done in mutilating hand injuries. Though this was a school-going girl, all fingers amputated, we had already covered it with the groin flap. She had, as Praveen said, she had MP joint contracture in extension, so we had to do first MP joint release by capsulotomies, and then we planned 2 toe transfers. However, we harvested one, and when we transferred it, we realized the vasculature was so bad that we didn't do the second toe, we did only the one toe. On table, when we fix it before cutting the KYS, we see to it that the thumb is touching the fingers. As Dr. Sabapathy always says, the thumb has to meet the fingers to have a good function. And this needed a vein graft, so we did not do the second toe, and she has an excellent function. She can write very well, she's right-handed. And the preserved little finger partially, it also helps her in all the functions. So we have published this in Challenges posed by delayed presentation of mutilating hand injuries where you face the different problems. This was a 23-year-old engineering student with bike chain injury. A lot of Indian students, they are favorite of Royal Enfield Bullet and they try to clean it themselves and they put their hands into the chains. And we replanted the middle finger, index finger could not be successful. The other fingers we did not have. And then he was a computer engineer, so he wanted an index finger so that he can use the mouse properly. So we did this second toe transfer. But you can see in a function, the finger is not flexing properly. So we do a secondary procedure of tenolysis, and you can see now that his flexion of the index finger is also good. And he works very well with the computers. And he can write well, and he can do his activities of daily living very well. This was a 28-year-old male patient, industrial accident, a minor patient working in the factory, and initially managed with debridement and a groin flap cover. So we did the toe transfers later. So after 5 months, we planned a combined second and toe transfer for reconstruction of the third and fourth finger. So whenever we are facing this situation, we don't try to reconstruct the index finger. 2 toes, we put it at the middle and the ring finger position so that they have an adequate opening of the palm. So this was the recipient side preparation and toes. So this was the on-table result, but there was large gap in the foot. So we used the free gracilis to fill that gap, managing the dead space. And this was the post-op result. He has an excellent function. There is a donor side morbidity, but not significantly. He can run with this foot. And at 2 years follow-up, he had a good function. But later on, he went on to become a teacher in the school, and he goes by bike, and he can use his hand very well. And the crucial function of folding and unfolding of the sleeves and even the buttoning, unbuttoning, he can do himself. And this was the case which I presented in the morning. I will not talk about it. So planning on day 1 is very important with respect to the debridement, salvage of the part by revascularization or replantation, and a primary definitive or a preparatory flap cover is very important. Toe transfer has a big role in improving functional results in mutilated hand, especially for those with loss of fingers and thumb. And ultimate result will depend on capability of surgeon in assessment and execution of the appropriate secondary procedures, as Dr. Sabapathy always says. Thank you very much. This was the last trick which I did, Annapurna circuit. And again, I would like to invite you for APFSRM. Thank you very much.
Thank you very much for a fantastic series of talks. Can I ask the panelists to come up on stage, because we have 10 minutes for questions. And just to get the ball rolling, a question for Andrei Lisak, and also probably for Dom. But if we start with Andrei, I'm assuming that neurotization extends the window for nerve reconstruction.
Can you hear me?
Yes.
Yes, we can.
Yes, okay. So about neurotization and reconstruction, nerve reconstruction, yes, because we, by neurotization, we have sometimes for the targeted muscles. For example, like I show in a case with ulnar nerve injury, when we have gunshot injury with the primary defect of about 4 centimeters at the level of the distal shoulder. So we perform the primary neurotization. We transfer the nerve from the anterior interosseous nerve to pronator quadratus to motor fascicle of the ulnar nerve, specifically for saving these targeted muscles of the hand that innervated by ulnar nerve for all this time, and we planned the reconstruction early, but the patient returned to his duty and he helped to liberate the Kherson, and so he came back only 1.5 years after the first surgery, after the surgery of neurotization, and as I show you, it works fine. We don't have any hypertrophy of the hypotenuse muscle or something else. He can use his hand, but he has no sensation on his 5 finger and half of the 4th finger. So we performed the nerve grafting of the ulnar nerve to reconstruct the sensation. The same thing I think we can use for other stuff. Why? Because in many cases there is bone fracture, there is a soft tissue defect. We don't have additional soft tissue cover to reconstruct the nerve, and of course this 3 weeks gap after the injury before we can reconstruct, because we don't clearly understand what is going on with microcirculation of the nerve after the injury. So yeah, I think that's primary neurotization, distal neurotization truly can save us some time and help us to restore the function in the gunshot nerve injuries.
Thank you. I don't know if this mic's live. Yes, it is. Perfect. Question for Dom and for Nick. Fungal infections, do you see much, and what do you do?
Civilian practice, no, not much. Difficult to treat, and I get the microbiologists involved very, very early.
So I didn't really touch on it properly in the talk, but the blast injuries from IED were contaminated soil deep into the wounds, and fungal infections were more common than not, and required serial debridement, muscle biopsies, and then use of antifungals if confirmation of hyphae on the biopsy specimens. So yeah, common in the IED blast from Afghanistan.
Particularly associated with the wetlands, and as Nick alluded to in his talk, you know, each area of conflict or wherever your patient has come from has a different microbiology pattern, and that's why it's so important to follow your microbiologist's advice locally.
I'm still waiting for someone to put a hand up. So another one, Sarah, and for the whole panel. Upper limb, lower limb, preservation and amputation.
So in our limited review of our casualties that have occurred over the last conflict periods, preservation of the upper limb is of paramount importance. We've looked back now, and we're out to about 10 to 14 years since our severe casualties in the military, and they tend to discard their upper limb prosthetic unless they are for a specific reason. They find ways around it. And the thing about the upper limb is it seems to be slightly more resilient to vascular compromise than the lower limb. And certainly in the military series, we saw that if they managed to revascularize in the operational theatre, nobody required amputation back in the UK. So I stress to you, preserve as much as you absolutely can of viable tissue, whether or not that's soft tissue or bone, because even if the bone is sticking out from the soft tissue, we may be able to use it back at home by extremely expert surgeons that as a tissue graft of some description. So please, please, please amputate only if you are in a life-threatening situation and there's no other option for you.
I'm going to ask a very unpopular question. If you do have to amputate, do you routinely do TMR in the acute setting? Is that something that is being done?
Can you explain TMR for the orthopedic
Targeted
surgeons?
muscle reinnervation?
It wouldn't be done in the military setting. I'll hand over to my civilian colleagues who may do it back at home.
We don't do TMR. But if you, about the last questions, the salvage of the upper limb versus lower limb, in our country the situation is different. The decision of amputation, what we take is always in the theater after we do debridement and after the realignment of the bones, whether the practical feasibility of salvage, whether it is a lower limb or upper limb, we always take decision in theater after the debridement, never in the consulting room or in casualty. That is one. However, if it is life-threatening because of the lower limb injury, which has a devascularized muscle for a long time, maybe after prolonged ischemia of 6 hours, we will consider to amputate the lower limb. In upper limb, we will further take this time to maybe 8 hours and try to salvage the upper limb. But when we salvage this, rarely it has happened that the patient goes into reperfusion injury dictated by the hyperthermia, the temperature raised, the tachycardia. So at that moment, we will decide and ampute, and anuria. So all three signs, if we get immediate decision of amputation, but we always prefer to salvage limb, whether it is upper limb or a lower limb. Sir.
So I think at Ganga, after the 3 decades of this thing, we try to articulate in a single word as to a single sentence as to what should be our goal. For the lower limb, this is what we have said. On day one, we should think whether we will be able to achieve a painless, independent, weight-bearing walking. Painless, independent, weight-bearing walking in a time frame and cost that the patient can afford. I think that's the thing that we have kept. All these 3 things are important. One, for the upper limb, we said that however be the severity of injury, provided you will be able to get a prehensile hand, go ahead and save the limb, because the secondary thing is go ahead and save the limb, provided you don't put the patient to undue morbidity. I think that's the line we have kept. So I repeat, however severe be the injury to the upper limb, if you think you will be able to get a prehensile hand, go ahead and save the limb, provided you will not put him into undue morbidity. I think that's the thing for the upper limb that we have kept.
Andre and Dom, a role for TMR, which as I understand it's muscle capping of a nerve end?
Target muscle reinnervation. That's when we have the painful neuromas, we can resect the painful neuroma itself and then make some connection between the mixed nerve that produces this painful neuroma to the motor nerve near the end of near it's going into the muscle to stimulate this mixed nerve to renervate this muscle, which means we give the nerve the target muscle so it can renervate it, and it shows very well in cases of painful neuromas, especially the lower extremity and then the upper extremity, and it firstly develops for bionic prosthesis to create some more these types of area where the sensor can give this electric signal to move the prosthesis. As I know, for primary amputation, here in Ukraine we don't use TMR. We use TMR only if patient came back after the amputation with the painful neuromas. And after about maybe 6 months of conservative treatment. And we start use this type of surgery, attached muscle neurotization, to create more areas for bionic prosthesis, because we have a few new great centers and many companies that develop bionic prosthesis are interested and helping our soldiers as volunteers. So we try to perform this type of surgery to create more areas for bionic prosthesis, so soldiers can use their bionic prosthesis. Dominic?
Yeah, from my position, so I know many in the audience won't be familiar with it, but effectively targeted muscle renovation is trying to make that nerve do something rather than form a neuroma with spontaneous and evoked neuropathic pain. I think that anything you do to a neuroma that's established has about a 70% success rate, and I think TMR is probably not much better than the alternative. I do use it in my practice. The evidence from larger studies suggests that if you do targeted muscle renovation as a primary prevention, then you may have less phantom pain than you would otherwise get. But we're not being referred patients primarily with the lower limb amputations for intervention, so it's much more of a secondary reconstruction option. We probably do three lower limb TMR cases a month, and then in the upper limb, if we've got a major amputation, then I will do TMR with the proximal mixed nerve stumps. So effectively, I'm rewiring into proximal musculature to rather than leave those nerves with nothing to do, and I do that prior to soft tissue cover. But by far and away, the largest numbers are secondary neuroma management, yeah.
In the setting of acute limb salvage, I'd be interested, do any of the panel make much use of vascular conduits? Shunts is what I was about to say, sorry. And if so, do you have any technical tips for using those, please?
So in our Iraq and Afghanistan conflicts, we weren't permitted to have standard vascular graft materials. And therefore, if there was a vascular defect, we kind of had to make do and mend. And therefore, we utilised just about any piece of tubing that was available. I appreciate this is not ideal and possibly not our best confession to make here. Anyway, you have to identify a piece of tubing that is appropriate for the size of vessel that you have, and if you can, manage to keep it in place adequately. The biggest issue is making sure that where the patient goes next, they know that what kind of shunt you've put in, and that they will have to explore it relatively well as soon as the patient gets there. And certainly we always wrote on the actual plaster or wound dressing to that effect, because that is the key, is to make sure down the line, as soon as they arrive in an appropriate institution with the appropriate materials, it could be managed. Otherwise, we did use vein grafts if they were appropriate, if the patient was well enough. And that was the key for our patients, because doing a normal vein graft often takes a long time, and our military patients were often so severely sick physiologically that you didn't have that time. So that was my experience.
Thank you very much. We're out of time. I'd like to thank the panel for a fantastic series of talks covering the principles of managing complex and sometimes bewildering injuries. Thank you very much.
Yeah, okay. I think if everyone's leaving, we'll just need to count the numbers, make sure we've got 30 people to make sure we core it.
Please, can the voting members or the fellows stay? And those of you that are staying and are voting members, could you please put your hands up so we can count you and make sure we're quorate? We're good, thank you. You can put your hands down. I stopped counting at 40, and I didn't count.
It's near the end, Robin. Good, let's get started then. First of all, we've got apologies for absence. Have we got any apologies, Charlotte? Okay. Then we need to approve the minutes. That's all to you, Ian.
Thanks, Dean. So hopefully you've all had a chance to read the minutes. We sent them around. They've been online for a number of weeks. So this is from our meeting back in April in Swansea. So just first of all, for any articles of any corrections, page 1, page 2, and page 3. I think it's a very good record. So if everyone's happy with that, we'll sign that as a correct record. And then we've not identified any matters arising that are not covered. Does anybody else have any matters they want to raise from the last meeting? Excellent. We'll move on then. So I'm handing back to Dean for his report.
Could we put the laptop up on the lectern? Great. Well, it's been a really busy year as President. It's difficult to put what we've been up to in a couple of slides, but well, first of all, I've travelled a lot, along with a few members of council. Spoken to represent the site in South Africa, in Fesh, in Rimini, Mumbai, which was interesting during the monsoon season. Ganga in Singapore, and in Ash in Toronto. And of course, the pièce de résistance was in Sydney. Many members travelled down under as guest society, and the team took the national dress, as you can see, and we won the hand surgery Ashes by competition. Would you like to show the audience the Ashes? There they go. And I promise I gloated as much as I could when I was there at every opportunity. In the UK, convened the BAPRAS hand surgery advances course. Went to Edinburgh, talked in Wrightington. I know I'm with Carlos there, but he was at Wrightington as well. Manchester instructional courses, represented BSSH at Biscos, at BESS, at Bowles, and next week BSSH have been invited to convene a combined session at BAPRAS in Newcastle, which a couple of us are convening. Now, some may say it's expensive and not great for the carbon footprint to be doing so much travelling. To reassure members, the President gets 5K in travel expenses for the entire year, which, as you can imagine, doesn't go particularly far. So the rest comes out of his or her pocket. But I really think that reaching out to other societies across the world is important for us as a society to remain up to date and relevant in the hand surgery world. and also to maintain the reputation, the presence of British hand surgery internationally. And that's why in Swansea we had the Swiss societies as guests, and this will be a policy of ours going forward. Next year the Scandinavians and the Germans will be guest societies, and that will be a continuing theme. So Swansea was great. We had Mike Tonkin, Caroline Leclerc, Stephen Horvius, Jimbo Tang, and we held the very first live operating session during the conference, which was a great success due to the planning of Dougie Russell. Is Dougie here? Take a bow, Dougie. Never worked with children, animals, or live surgery, but you made it work. Thank you very much. With respect to GIRF, BSSH over the last couple of years has collaborated closely with Ken Dunn, Tim Briggs on the GIRF report on UK hand surgery. But there appears to be a hold-up of publishing this report, basically because NHSE is not happy with its recommendations. So with the support of BOA and BAPRAS, BSSH is lobbying NHS England to insist on its publication. So far they're not agreed, so we can just carry on trying. There's been a lot of debate regarding hand surgery pathways. In particular, Tim Briggs wants the majority of hand procedures to be discharged to PIFU, straight from theatre, which BSSH doesn't particularly want because we think there should be at least a telephone call, if nothing else, to monitor follow-up of any sort of patient, whether it be carpal tunnel or trigger finger. And to be honest, I tried to get a question asked during the session earlier on, but can I just ask for a show of hands, just to take a poll? Who would be happy to discharge carpal tunnel, for example, to PIFU without a follow-up? So a good percentage of people.
And who wouldn't?
Difficult one. I think we'll have to poll the society on that because it's a bit of a stalemate at the moment. Yeah, you'll probably hear from us more about that in the next couple of weeks. We're also in discussion with NHSE regarding the establishment of an implant registry, a database for hand surgery. I'm sure this will happen in the next year and will be interchangeable with databases in the devolved nations. Andrea Lupu is putting together a working group on this, and I'm sure this will be complete actually within the next 12 months. BSSH is also issuing a statement, probably coming out this weekend, on single item screws and plates, which are in use in Scotland, not popular in Scotland, and we don't think they're in the patient's best interest. They prolong operating time, they cost the NHS more, and they create a huge carbon footprint. And again, we have the support of BOA and I think GIRFT so far in opposing this move. I think it'll be a difficult battle to win, but I think we should try. Hand surgery is having more success in the engagement of the NIHR in national studies, thanks to the work of Tim Davis, Joe Dias, Mark Gardner, Dominic Powers, and others. But many of these studies are finding it difficult to deliver on numbers. For example, there's a great study run by Mark Gardner at the moment called FLARE on flexor tendon repair, that unless it gets going, it's going to fail because of inadequate numbers, which would be a real shame. So what can we do to help? Well, we tried to highlight that with the session on NIHR trials during this meeting. It may be the case that surgeons don't think the research questions being asked are relevant to their patients, or that surgeons think that they just don't have the infrastructure to get involved with these trials. And the JLA topics are very wide, but it's logical if BSSH members have some say in designing the specific questions these studies are asking, then they're more likely to get involved. So I've worked with Alexia Karantana and a team to create an initial BSSH research prioritization project to identify which specific questions within these criteria BSSH fellows and members would like answered. This is the link to the survey, and I know there's a bit of a survey fest going on at the moment, but if there's only 2 surveys you complete, please complete this one, and also the BSSH strategy survey. So have a think and complete it. At the end of the day, it's hand surgeons in the workplace that are best placed to decide what research will benefit our patients. And I think they should be formulating the research questions. So many thanks to Alexia for doing this. Global Partnership Project in Malawi, the Lion Project, is up and running now in its new hospital and is doing well. Sue Fullilove is actually there at the moment. It was also a pleasure to welcome Boston, one of the local surgeons. He's come to our meeting. He'll be at the dinner tonight. There are 1 or 2 places, I think, left on the program for next year. So if anybody's interested in volunteering, you can approach Jonathan or Martin Wood or Steve Hodgson, and there's a desk in the industry room. The project was initially primed by BSSH. The plan is obviously for it to become self-sufficient, and so far they've raised £43,000. And they're just getting used, I think, now to fundraising. But there's a fundraising dinner on the 30th of November in Oakley Hall, which is near Basingstoke. If you can attend, then please attend. It's a very worthy cause, and I'm sure it'll be a good night. Now, Zaf will explain this in a bit more detail, but our finances as a society are under a bit of strain. This has been for a number of reasons. The office split from BAPRAS was expensive. Our secretarial costs have inevitably increased. Costs like venue hire are much more expensive after COVID. We've had a lot more asks for funding also coming out of COVID, which basically means that we're spending more than our income. So if you look at this graph, that is about 2017-18, when we did our last survey, or about that time. And the strategy at that point was to spend as much as we could, spend some of the money that we had in reserves. So we were quite good at that. And then COVID hit, and we stopped spending during the pandemic. And I think that probably masked the fact that actually we were continuing to spend, because currently we are operating at a deficit. So we need to review and we need to control our expenditure. We've taken some measures to mitigate this. About 18 months ago, we created a Financial Risk and Audit Committee, which now includes a lay financial expert to advise on our investments. We brought our accounting in-house, and we're modernizing our accounting so that we can record our funding streams more accurately. And modernizing really is the major drive behind our BSSH strategy, building on Gray's strategy document from 2017 to try to make our society fit for our current trainees and our junior colleagues in 10 years' time. But to do that, we need to establish exactly what we're doing. The activities of the society are now vast, and if we're going to reduce our spending, we need to decide what we're going to prioritize. To do that, we need to know what we're doing well, what we're not doing well, and what you as members want the society to be doing. And we need to answer some important questions like, what activities do we reduce our spending on, whether we go to one longer meeting a year rather than 2, whether the journal goes completely online, and when this happens. We've already sent out an online survey. So far, only about 20% of people have actually filled that in, so I'd encourage you to do so. We had a discussion day yesterday, which is actually really useful, and we'll be in touch for further online discussion in the new year. So I think that's probably been the priority of the last year, to try and empower members, or fellows as they're now called, to have their say, both with regard to the future of the society, but also with respect to the important research questions that people would like asked in future big studies. And clearly the completion of this project and strategy will continue into next year. I'd like to thank the Secretariat. They do a great job. Charlotte is the glue that holds everyone together. So I'd like to formally say thank you to you, Charlotte. You've really stepped up to the mark since COVID, and you run a really good office, great office. Being a president has been made a lot easier by working as a team. We have a sort of star chamber now with the presidential line. I've relied on the wise counsel of Grania, Jonathan and Carlos, who provided some great support during the year. Especially Grania has also done a huge amount on our strategy. But I'd like also to formally express my thanks to Jonathan. Jonathan has been a council member or a trustee or officer as long as I can remember. He's immediate past president now, so this will be his last role as an officer for the BSH. So I'd like to formally express my thanks to Jonathan. And that's all I've got to say. Any questions on that? Okay.
Thank you, Dean. So I get the pleasure and privilege of explaining to you the financial situation we are in the Treasurer report. And as Dean has said, that we do a lot of amazing things. We've done a lot of amazing things, and I guess we want to continue to do a lot of amazing things. But with the financial situation, which I will outline, we are going to have to do things differently. Probably sounds like a meeting at work, doesn't it? So let's have a look anyway. So this is a summary of a different way of expressing the accounts as of May this year. And what we can see is the income to the organization is or was 1.1 million, and the expenditure was 855,000, which therefore left us with 283,000 to spend if we were budgeting properly. But we spent 580,000, so therefore we lost just under £300,000 last year. There's different ways of expressing that, and there's issues around the accuracy of this data. However, we are losing between 200 and £300,000 a year in the current trajectory, which means because we've got investments and we've got assets. Currently, we're releasing those assets to keep solvent. And I guess my responsibility in the role that I have over the next, with the remaining 3 years, is to get us into a position where we maintain solvency, we maintain as many of our activities as possible, and we continue to do good work. And we also leave the society in a good position for the future to come. So that's the task at hand. So if we say roughly 200 to 300,000 pound loss year on year as it stands. So how have we responded to that? So as Dean has said, we do have a formal and very active committee called the Financial Audit and Risk Committee. And we have met a number of times, and our focus in that committee is specifically to look at our finances and our risk. And there's a lot of work ongoing there, and we have experts, financial experts within that committee. Specifically, I'm concerned about the financial governance structures and our financial resilience in terms of the back office functions. And we have appointed Stephen Ellerton to do our accounts in-house. They were being outsourced before, and that has been a huge help. And he's going to help us with the financial governance structures and the resilience. And that will take a little bit of time because we're going through things and assessing things as we speak. And I think, in the next 12 to 18 months, we will be in a better position in terms of our knowledge, our intimate knowledge of how the money is moving around, and have governance around that and a mitigation plan. He's already identified £60,000 a year of savings in the way we manage our money, and that is with immediate effect. So, as part of that, as Dean has said, we're going to restructure the accounts, and what we want to do is to be able to present you, the members, and the various committees, a committee-level budget. So it's really, really clear how much each project is actually costing or bringing in money. And we need that, otherwise it's all speculation. So we're going to, that's the new way of how we're going to do our accounts, and we're working on that as we speak. It's quite a bit of work going into that. And then ultimately we will be in a better position to rationalize and prioritize activities which will not just be based on financial decisions, but of course the strategy which Dean and Grania and the team have been working on. And of course the input from the members as per the strategy survey and per yesterday's strategy meeting. So when it comes to income, we've got income from industry, we've got income from our investments, income from the subs, the membership subs, and income from the journal. What we know, and it's been mentioned a number of times, is the income from the journal is going to go down because if ultimately the journal, due to a number of reasons, will go digital and we will lose income. So that's a cert. The investments we're going to have, we've got someone who has expertise in investments, so not a hand surgeon who's looking at our investments formally to see whether they're doing what they should do for us. Subscriptions, we have modestly increased the subscription for fellows to £350. We note that it's still significantly less than the membership fees for the BOA and BAPRAS, maybe half. However, we also note that we are a small society and a voluntary society, and we have to compete with the BOA and BAPRAS and other subscriptions. So we will keep an eye on that. There was some suggestion or consideration of including the conference fees in the subscription, but the feedback yesterday and from the survey was for that not to happen for various reasons. And we also do not want to really increase the subscriptions for the trainees and the junior surgeons. Industry is the interesting one, and with Dean's support, I've been engaging with industry. We're looking and talking to industry in terms of how they can help us. And that will lead on to some other things I'll discuss in the next slide. But essentially, the industry, we need to really completely rethink how we engage with industry. In terms of expenditure, nothing is off the table, and that includes the office and the office costs, and we're looking into that. And the last thing that I've put is the frequency of scientific meetings, which I think is an issue that is probably quite an important issue, and people will have strong opinions on the frequency of scientific meetings. So I want to talk about that because my recommendation, or where I'm at as a treasurer, is that we need to rethink our scientific meeting frequency and the nature of the scientific meetings. And industry has also influenced my position on this. Industry are far more in favour of what happens with BOFAS and BES and other organisations, where there is a 3-day meeting once a year on a set cycle in a major city, and it's planned well in advance, irrespective of who the president is. The city is booked well in advance, and there is a cycle. So if you look at the bottom of the slide, a typical cycle for BOFAS and BES is England, Northern Ireland, England, Wales, England, Scotland, for example. When it rotates, it's set, it's well publicised. We go to big conference centres because we expect big numbers, such as this one here in Glasgow, or such as Wales, where we were in the Wales Conference Centre. These are the centres that can accommodate much bigger numbers. The industry know the size of the floor space, they know what they're getting, and they can send their reps. We know from the survey that 2/3 of those who filled in the survey were in favour of this. And yesterday, on the strategy day, we also had the majority of people who were in favour of this. And that is my recommendation, that we should move to in a phased way. We've already got the next few years planned, but in a phased way, we should move to a 3-day meeting once a year. The other thing is also people are not, the surgeons coming through the ranks now are not getting the study leave we used to get. They're not just, the flexibility is not there anymore from their places of work, and they don't have the money either, if we're being honest. So any questions about my report, please? Anybody feel, I don't want to start, anyone feel very strongly about the scientific meetings? Okay.
Hi, Alex. I completely agree with you. I think we have to go to one meeting a year, personally. That's my strong feeling.
I think the other thing is we're having an increasing number of invitations to be guest society at an overseas meeting, and actually trying to do 2 meetings plus an overseas meeting is impossible. So a 3-day meeting with an expectation that most years there will be an opportunity to travel near or far is probably a good compromise. And that's what's planned for Carlos's year.
I know that bottom line is probably just an example.
Yes. It's just
but perhaps if you do adopt that sort of model, you could replace Northern Ireland with Ireland, because we do have a lot of Irish members that contribute quite a lot.
Do you need a proposer and seconder and pass it?
Well, yeah, that would make things...
Can I ask a question?
I think maybe that's still part of the strategy, John.
May I ask a question, please? If the switch is made from 2 meetings to 1 meeting a year, will that reduce the opportunities for trainees to present posters and to read papers?
So I discussed this with our research lead in terms of this concept of 2 meetings to 1 meeting in the 3-day. And her feeling was actually, if we want to improve the quality of the research, then 1 meeting for 3 days will probably, in the 12-month period, will give us better quality papers. And the size of the venue with the breakout rooms and the posters, etc., will give enough opportunity for trainees.
Alexa, do you have a comment on that?
Come.
I think infographics are more and more popular. They save a lot of time and are preferred by, well, the audience today that was polled said they preferred the kind of 1-slide infographic presentations than the multiple slides ones. So we can increase efficiency. I think even within a 3-day meeting, we can have parallel sessions. I think there's still space to put more than what we've got in now. We have the poster kind of setup at the moment is rather pointless. We can work with that. So we can maintain the opportunity as best we can. And the other thing is, it's totally inefficient to try and manage the free paper submission process and be fair and representative and allow people to opt for both an abstract and a poster if you have 2 meetings, because the lead times are too small, too short. Yeah, so we can do more if we've got more lead time. I'm not going to bore you with the details of that, but in an ideal world, we'd have 4 days, but we have to make choices as well.
Dougie, it's very sporting of you to run the mic, considering you've only just had your knees done.
Can I just ask if you could expand on the
the income, you had it as a lump, you had the investments, and then just the overall income of 1,400,000 or whatever it is, 1,000. What's that composed of? I assume it's composed of subscriptions, meeting income, journal income, and it would just be nice to know what each individual one is so that we can work out if your strategy is appropriate or not.
Yes, good question. The majority of the income comes from journal and subscriptions, and the journal income we know will start to go down. The subscriptions we don't really want to increase massively.
So I mean, I'm asking for figures.
Yeah.
What are the subscriptions? And the reason I'm asking is because to keep the society completely safe, your subscriptions really should be able to cover the secretarial costs. Everything else is froth. If everything else goes to shit, as long as the subscriptions cover the secretariat, the society remains. And how much does each of the individual meetings make us? That's crucial to making the decision.
Yeah. So
and the journal income, how much is that? Is it 700,000 at the moment?
Nowhere near that.
Nowhere near that. 500,000?
It's about between 300,000 and 400,000.
Right. And you're estimating it's going to go down to about, what, 300,000 or something?
Yeah, we don't know really, to be honest, Simon, because we don't know what the effect of open access will be.
Sorry to put you on the spot,
no,
but actually...
it's fine. And the thing is, what is happening is we're getting to a state of consciousness in terms of an awareness as council and as members in terms of we're in this space now where these which can be awkward questions in terms of our expenses, traditionally awkward questions, we're articulating, and with Stephen's help, we are going to break down the income and the expense as per activity, which we just don't have that clarity. There is not enough accuracy in the data for us to be able to display that. But I think come next meeting or come Leeds, we'll be in that space where we can be far more accurate. Meetings, for example, they have fluctuated. On some meetings, we've made a £20,000 profit. On some meetings, we've lost £50,000. It varies massively.
So, Simon, the subs are between 2 and 250,000, and council over recent years has made a conscious decision that the meeting should lose money in order as a benefit of being a member. But times have changed, and that may need to change.
Thanks.
Any other questions?
No. Okay.
I just wondered if you could give us a little bit more information about the journal and what changes are planned and are they definite? Because we're all sitting here thinking we'd quite like to keep getting a paper one. I don't know if that's something...
Sorry, what was the last bit? You want to...
We want to know what's happening with the journal, what the plans are. Is it definitely going all electronic or is it staying paper?
We sat right next to you there, so you could perhaps grab the mic or even drop the mic afterwards.
So I think there is a plan for the journal to go digital because of mainly the concerns over climate change, sustainability, and all that. We're still in discussion about what is the best format. We discussed that at the strategy day, whether if you don't get the print journal, whether you will stop reading the journal, whether there are some lesser physical reminders like a postcard that can still be posted out, better ways to use the media to remind people that the new issue is out. So all these are currently under discussion. I'm not really sure the income will go down. I think the idea is that the cost savings from printing will be used to offset possible loss of earnings from industry We don't know how industries will handle the change to digital. So there's some uncertainty, but I think that the income from the journal should remain the same, if not go up. That's kind of, that's what I think. But there's no certainty. So it's probably better to plan for a slight drop.
Just to, anything else on that? So just for Simon, I've put the this sheet, which doesn't actually break down the income because we weren't happy with how the income, you know, how it's recorded at the moment. But just an example for you there is income from investments, 74,000 or 75,000 pounds. Investment losses and management fees, 150,000. So on paper, we lost 75,000 on our investments in the last 12 months. So that is also being reviewed. And we've not done this before where we're going to get to a point of hard budget setting. And it's going to be awkward and difficult because if we get down to committee level, then we will be having to make decisions. But what we need to do, as you say, is keep the society solvent and running. And then we'll have to pick things which are core activities and things which are nice to have activities until we get to a better position. But I've got 3 years in this role, and I would like to be able to leave at the end of 3 years with the balance being in equilibrium rather than leaving the, you know, at this rate we would burn all our investments within 4 years. We'd be done.
Possibly a stupid question. Is corporate sponsorship out of the question?
No, so that is absolutely in the question. And as I've said, what we're doing, what I'd like to do, and I have engaged with industry, and what industry have said, the difficulty we've got with the BSSH is you have 2 small meetings, and we don't know where you are the year after or the year after, and other organisations such as BESS and BOFAS have 1 meeting, and we know where we're going 2-3 years in advance, and they're big conference centres, so we're not going to the small cities or towns. They're big conference centres, established conference centres. We will send our reps, and we know the square footage already because, you know, there'll be places like this or where we had in Wales, which are established formal conference centres, and we can then commit to you for a number of years. And then, you know, so that I think is the way forward. It would mean that the history that we've always had is of the 2 meetings, which I imagine traditionally was London, and then a meeting of the choice of the president. That kind of stuff will have to go. And that's a change, and, you know, there's an emotional, historical aspect to that. But you know, we have to modernize, and we have to think about the environment we're in. And ultimately, more than that, we have to leave the society in a good place as we leave the stage.
Hi, Zaf. Just regarding the location and wanting to take the example of BESS or BOFAS. I don't know if you've been to many BESSes, but they tend to choose very clinical, soulless type places. And one of the things that I liked the best about coming to the BSSH meetings was the venues were always very elegant and personal. And there's just that, I think that mattered a lot to me to pay the money and to come. So I don't know if others feel the same, but I think that's definitely worth considering because even this place, sure, it's functional, but we're not that big a group. You know, we're elegant people. We need to maintain that, I think.
Some of us more elegant than others.
So absolutely, but we also have to deal with the fact that there is a reality, right? In terms of how much we're willing to spend and how much future surgeons and trainees are willing to spend. I mean, if you actually add up how much you spend on the conference, the accommodation and the travel as a trainee, or a junior surgeon, are you going to be coming to both meetings in a year? It works out to a lot of money. And the trusts don't pay anymore like they used to.
So in all seriousness, you'll change that from Northern Ireland to Ireland, will you?
Sorry?
Ireland should be, I mean, it was a great conference in Dublin, so that's one of the good venues, but you will change that, won't you?
Yeah,
I'm
yeah.
just speaking
We've
up
had
for
that.
all the Irish here, all two of us, Grania and I.
Yeah.
Absolutely, we will.
And I mean, the venues are not set. I mean, we don't have to follow that pattern. That is a BOFAS pattern, actually, or a BEST pattern. It's fine. We can look at whatever. But I think what was nice about that pattern is they've included all the devolved nations.
I don't think the two are mutually exclusive. I think being a smaller society, we can afford to have smaller, more elegant venues and still retreat to a once-a-year, 3-day meeting. We don't have to go to a massive, sterile venue for that.
You do have to have space for industry if you want the money, though.
Can I just say that what we need, really, you say some of the meetings make money, some of them lose money. When I was president, we were always concerned about the London meeting because it was more expensive to stay there, it was more expensive for the delegates, and so on and so on. We need that information, don't we, to make, because I'm sure that there are places that for some, and then we can perhaps drill down to find why they were particularly expensive, because I'm sure that, you know, I don't know whether Swansea was more expensive than Dublin, I don't know whether Glasgow is more expensive than wherever, you know, and we need to know that.
Agree. I think the first thing, obviously, is to overcome is a huge change, which would be to go from 2 meetings to 1 meeting, which I think pretty much most people are accepting of, and then we can move on to the next thing about, you know, location and spots. But we can get that information. We can have that information, but a lot of it has been so the office will. You know, when timescales are tight, prices go up, and that includes speaker fees. So if you're writing to someone in the US or Hong Kong with 4 months to go, and they're getting an airfare versus a year in advance, it's a massive difference.
Most places we have the meetings are in university towns. I agree completely that it's nice to have a variety. We don't want this to be Manchester, Oxford, London, Cardiff, Glasgow. You know,
I was speaking to Grania. I think we did. Grania, what did we decide? Manchester, Liverpool, Leeds. I think that was it.
No, I just think that fine.
Oh, and York. Yeah, York's got character.
Actually, if I could just say something as well, because everybody here, well, most people here are fellows, so obviously this is our opinion and we're current, but we're going to also poll on the future. So we will have like a Zoom meeting or an online meeting with the associates and the trainees, because we want to know what they want as well. So we're not making an ultimate decision today. We're just kind of finding out what you think, because we've discussed it at the strategy, we have the survey, we're having a kind of this meeting, and we will ask the future Hand Society as well. So just to say that.
David.
Thanks.
Yeah, and you're right, David. Currently, there's at least a year's notice for most speakers, as it happens. Anyway, we better move on now. We'll sort of use that as part of the strategy.
Just last one.
It's just really a suggestion, don't shoot me. where BSH fellows are concerned, I'm probably one of the poorer hand surgeons, but while you're waiting to balance out your books and waiting for the uncertainty of the journal aspect and changing the meeting and engaging industry, it's a suggestion, but I mean, this is our society, so even raising the membership fees for a short period of time to then lower it later to just cover and balance up things, because 3 years is a great projection. Your ambition's great, but it's not going to be quick because there's so many uncertainties. So as fellows, I'm sure if you put it out to us, most of us will be happy for an elevation in our fees for a short period of time to then drop it down later, not touching the affiliates and the trainees is what I mean. Only a suggestion.
Yeah, so it's a good suggestion. I think we'll see where we are actually at the end of this year. after this increase and perhaps consider it then. But I think we should move on. I think we're staying with you, actually, Zaf. We've got the risk register.
So it's just to say whether, so it's been circulated, it's to say whether there's any follow-up from that in terms of the risk register. And also officially we have to mention the accounts which have actually already been submitted, but traditionally we also ask whether there's any, we also ask for a proposer and a seconder. We've always done that, even though the accounts have been submitted. In terms of the risk, Charlotte, in terms of the audit, with the audit's not been done yet, and so it's going to be moved to, delayed until the meeting. We'll do an extraordinary general meeting probably in spring.
There'll be an EGM in late.
An EGM, yeah. Yeah.
Okay, thanks. We'll move.
Okay, thank you.
Thanks, Zaf.
Yeah.
If we move on to Steve, please, and resignations, honours and deaths.
Yeah. Is this on? Yeah, it is. Since you've seen the two names in the papers, since then we've sadly heard of a further death, which was Ken Wise, who was a retired orthopaedic hand surgeon and anatomist from High Wycombe. We'll more formally inform members about that electronically. But I think the two names that are there in the papers show that we have lost two real giants of our speciality in Rolf Birch and Nicholas Barton over the last 12 months. I'm sure they're well known to the vast majority of people in the room, but it probably is worth just reflecting on their lives, really. Rolf Birch was born in 1944. He trained and worked with George Bonney and Kit Wynne Perry and took over George Bonney's brachial plexus practice, initially at St Mary's before moving to Stanmore and latterly in his career to Headley Court. He was a giant of brachial plexus surgery and co-authored the original version of Surgical Disorders of Peripheral Nerves and did the second version, led the second version himself. He was a PSSH member since 1981, served on council 1983 to 84, and was made an honorary member in 2007. Nicholas Barton was born in 1935. After graduating from Middlesex Medical School in 1959, he did hand surgery training at Oswestry and Los Angeles, and in 1971 started his practice at Nottingham, where he became a professor of hand surgery. He made a huge contribution, I think, to BSSH. He was honorary secretary in 1983 to 85, president in 1989. He was editor of the journal from 87 to 91, and was elected an IFSSH pioneer in 2007. So I think it is worth just standing and taking a few moments to reflect on their lives. Thank you.
Thanks, Steve. That moves us on to elections. Has everyone read the note I put in the AGM papers? Okay, I'll read it out. As far as the presidential election is concerned, the Council would like to propose Mr Wee Lam as BSSH President to 2026. Now, the circumstances of the election were a bit unusual in that when Mr Lam was nominated and asked if he would like to run, he informed the Secretariat and Council that there was a possibility that it may not actually be residing in the UK for part or potentially all of his presidential year, and this was a consequence of him having to spend some time in Singapore for family reasons. And it presently remains unclear when Mr Lam will be able to return to live full-time in the UK. After a detailed consultation with the Secretariat, no potential difficulties were identified with respect to the day-to-day interaction and running of the office, with the President living outside the UK, since most BSSH correspondence is either by telephone, email or Zoom. And it's the intention of Council going forward to meet face-to-face twice a year now, and for the other 2 meetings to be virtual. Mr Lamb confirmed prior to his application that he would attend all face-to-face Council meetings, committee meetings and scientific meetings without the need for reimbursements for any international travel, and he will also be in Edinburgh on a regular basis. After reference to the BSSH Constitution, it was confirmed that there was no reason to preclude this application for BSSH President, even if she would not be entirely resident within the UK for all or part of his or her presidency. Following consultation with the Secretariat, officers and Council, Mr Lamb was therefore permitted to stand for BSSH President 2026. An election preceded the Council meeting 17th of April 2023. This election proceeded with full knowledge of these circumstances, and careful consideration was made to the merits of each nomination. A winner was obtained at the first round of voting, and it is therefore the intention of Council to recommend Mr Lamb to the membership for ratification as BSSH President for 2026. Could I ask a show of hands of those in favour? And any against? So, congratulations, Mr Lamb, on your presidency for 2026. Council elections, there were 3 new members elected to Council. Ms Sarah Tucker, Mr Prash Jesulison, and Mr Dougie Russell. Congratulations. Do you know Ian?
Thanks. So, moving on to the membership. So we have a pleasure announcing Council suggested honorary membership for Mr Di Newington. And traditionally, I think we have a proposer and seconder. There we are, proposer and seconder. Thank you. Moving on to the more regular categories. So first of all, those members who've now retired from clinical practice. So we have two applicants there to become senior members, Khalid Sharif and Kirsten Bayerman. So they're moving into the senior membership category. Since our last meeting, we've had 2 new full fellow member applicants. So Vicky Cherry and Sarah Dorman. So no objections, we will enter them into the, welcome them into the Society as fellows. We have 1 applicant for the international membership. That's Lambros Athanos from Cyprus. And then we have 16 applicants for the associate membership category, and these are going to be the lifeblood of the society for the future, so it's fantastic to have 16 members there. I won't read through all the names, but we were hoping you could see them on the screen, but they've been circulated well in advance. So any questions or queries on those 16 members? Excellent. We will enter them into welcome them into the society. We also have one applicant for affiliate membership, which is Andrew McDonough, who's a consultant physiotherapist in Salford. So it's great to have colleagues from professions associated to medicine as well. So that's all of the new members. And moving on to the next section, which is me again. We have, you'll be pleased to know there's only a couple of very small changes to the Constitution that we need to make at this point. So again, hopefully you've got your papers that we circulated in advance. And this really relates to just clarifying our intentions with the previous constitutional changes, so that our fantastic current lay member, Robin Horton, who's here. There was a very strong desire to have him as an appointed voting trustee, and then went on close inspection of our current articles. It was clear that it was slightly unclear on that one point. So the two relevant articles are Articles 41 and 42, and again, I was hoping that might be displayed above my head, but it doesn't appear to be. Yeah. So the problem was that these two articles effectively contradicted each other. So in Article 41, it lays out who are the voting members, and it lacked the lay representative, so we've inserted the lay representative into that list. And in Article 42, it lists the other people who might attend council who are not voting trustees, and it included the lay representative in the list of other members like committee chairs and so on. So we're removing the lay representative from that clause, so it's two very tiny changes. But because it's a change to our articles, it's not a regulated change, so it's a change we can make ourselves, but we just need a quorum meeting, which we have. I think, I've just counted again, I think we've got almost 70 people here, which is good. And we just need a 75% majority to be able to make those changes to the articles. So if everybody is happy to vote by hand, we'll do that and just count the votes. I think we'll take the two articles together as a single motion. So if everyone's happy for us to make those changes, those in favour, we just need to count the numbers. Do you want to count that side, perhaps, Jonathan, and I'll count this side. I've counted us. So I've got 33 plus 22, so 55. Yeah. No, I'm just checking that we're quorate before I proceed. So any against making those changes to the articles? Excellent. So that's makes it very easy not to have to count. So thank you very much. That concludes that item.
Next item is committee reports. These are to be received as read. Are there any questions with respect to the committee reports? Good. Then that moves on very quickly to any other business. Ian?
So we've not been informed of any other business. Does anybody have anything they want to raise at this point? We've had a couple of good discussions already. You may have, and it is getting late. Good. So the last item is just to, if you can note and put in your diaries now the dates for our meetings next year. Gráinne will say more about this tomorrow, again, because they're going to be her meetings next year. But we're all going to be at the Royal Armouries in Leeds, the 25th and 26th of April. And then we're going to Belfast in the autumn on the 14th and 15th of November. So pop that in your diaries now. So thank you very much, everyone.
Thanks, everyone. That's the end of the meeting. See you all very soon.